Of the session are Dr. Rajesh Keshavan, Dr. Madhu Periyasamy, Dr. Jesse Thomas. Please come to the dais. And Dr. Lee Rogers. To proceed with the session, we start with Dr. Rajesh Keshavan presenting on flexor anatomy.
Very happy morning to all of you. So my talk is on flexor tenotomies, a very simple procedure which can be done for patients with flexible hammer toe. So this procedure has come up in the last iteration, the 2023 iteration of the International Working Group on Diabeticfoot. So it states when excess callus or a pre-ulcerative lesion is present on the apex or distal part of a non-rigid hammer toe. So it has to be a flexible hammer toe. So consider digital flexor tendon tenotomy. So it is recommended as a preventive procedure, preventive surgery. And in the pressure offloading and ulcer protection guidelines, it states if the ulcer is on the lesser toes, that is digits 2 to 5, secondary to a flexible toe deformity, perform a digital flexor tenotomy. But very important point is there should not be severe ischemia, there should not be infection. So only in clean cases you can try this. Just a small thing on the anatomy of the tendons. So when you look at the flexor digitorum brevis, just underneath the plantar aponeurosis, so originates in the calcaneum and inserts, when it splits into two slips and gets inserted into the middle phalanx. So that is your flexor digitorum brevis. So between that, the flexor digitorum longus tendon comes and gets inserted into the, so you can see the flexor so you can see the flexor digitorum brevis here, splitting into two slips and getting inserted into the middle phalanx. In between the slips, you find the tendon of the flexor digitorum longus getting inserted into the distal phalanx. So this is your flexor digitorum longus tendon after removal of the brevis. So this is what you need to remember. Longus tendon always inserts into the terminal phalanx. Earlier, we used to do the procedure with a scalpel, where we go in at the level of the proximal phalanx and we keep the toe taut and pass the scalpel deep inside and cut the tendon. Nowadays, we have shifted to the using a needle. So the third toe, we are doing a flexor tenotomy with a scalpel. We usually use a 15 blade. You need to keep the toe which you are operating, you need to dorsiflex. You need to go into the, at the level of the proximal phalanx, you need to insert your scalpel. You will feel a pop when the toe gives way. So it becomes more flexible. So that is when you have to stop. But most of the time, you can go for a needle flexor tenotomy. Usually we use an 18 gauge needle for this procedure. So here we are trying to do a needle flexor tenotomy. So when you are doing a needle flexor tenotomy, ideally you need to give a local anesthesia. And you need to ask the patient to flex the toe. So when the patient flexes the toe voluntarily, the flexor tendons become taut. So you hold the needle and you try to insert at the level of the middle phalanx, and you make to and fro movements, and you can feel a creaking sound which you can hear, and the tendon suddenly gets released, and you can feel the pressure getting relieved, and the toe becomes a little free. And the patient is not able to flex the toe voluntarily. So that is your stop, this thing. So this was the patient where it was done on the third toe. You can find that post flexor tenotomy, the third toe has become straight. So immediately after the procedure, you may not find the toe to be completely straight. It may be a little bent. You need to give some time after. You need to put a dressing. You need to ask the patient to wait in the OP, keep the foot elevated for about 30 minutes so that there is no bleeding afterwards. And afterwards, I think the patient can go home. And usually we ask the patient to come on the third day to change the dressing. One day we ask them not to exert themselves too much. They can go to the washroom. All those you can do, but ideally use a rigid footwear when post the procedure. So this was a patient who had an ulceration on the fourth toe. Flexor tenotomy was done, and you can find the ulcer also has healed, and the toe also is almost straight now, and the incision also has healed. Usually by third or fourth day, we find that most of the time the side through which the needle has passed becomes pretty dry and almost healed. Another patient, again the patient has developed a callosity on the second toe. It was a flexible hammer toe. Audio. So you have to hold the needle near to the tip. You can hold so that you have better control. Usually, I have the needle along with the syringe, so it is much more easier to handle that. During the process, you can hear a sort of a creaking sound, that sound of the tendon getting cut. So you ask the patient to flex the toe. That creaking sound that tells you that the tendon is being cut, and the toe becomes straight after that. And when you are passing the needle, the pivot of the needle should be at the skin level. You don't try to keep moving the needle like this. It has to pivot at the skin entry level. So that is where so that pivoting moment is important. So this was the patient before the procedure and after the procedure. So this was on the third day. The needle entry point is almost healed now. So it's a pretty simple procedure. which can be done on the bedside with basic precautions. You need to see that it is a clean field, there is no ischemia, and there is no infection. Number of studies have shown that this procedure is pretty safe. So this was looking at the cost aspect as far as going for a percutaneous procedure to a conservatively managed clotto. So ulceration post a conservative clotto, the healing was not much. Only 3 of the 15 patients who were managed conservatively, the ulcer healed, and the cost for them was something like 9,000 pounds. But where the intervention was done, the healing was almost complete, and the cost saving was something like 8,600 pounds. Another study which looked at the healing, which looked at almost 101 feet, where 84 was done for ulcers, it's a therapeutic flexor tenotomy, and 17 were done as a prophylactic flexor tenotomies. 95% healed within about 27 days. 11% re-ulceration happened. So again, the conclusion was it is a pretty safe procedure. This was a systematic review which looked at around 11 studies on flexor tenotomies. The healing rate was something like 92 to 100% with a mean healing time of 2 to 4 weeks. And the complications that was routinely seen were transfer lesions affecting the adjacent toes. So the recommendation was, if you are doing a flexor tenotomy, if you have a similar lesion on the adjacent toes, proceed with flexor tenotomies on those toes also. So don't do an isolated flexor tenotomy of that affected toe. So it's a simultaneous tenotomy of all toes will prevent occurrence of the transfer lesion. And before doing that flexor tenotomy, you need to tell the patient that the patient will not be able to flex the toe after the procedure. So maybe later on the patient can come and ask you, I'm not able to flex the toe. So that thing you need to tell the patient beforehand. And the functional outcome, based on the visual analog scale, the patient satisfaction increased from 3.9 to 7.7 in most patients undergoing flexor tenotomy. These are some of the references for this procedure. Thank you.
Next, we move on to Dr. Lee.
Morning.
2 minutes, sir. I need to move that.
Okay, no problem.
Dr. Lee is going to explain on transmetatarsal amputation.
This is my fault because I changed the lecture last minute, but I didn't have great videos on Keller arthroplasties. I'll talk about them for 2 minutes while they're setting up, but the Keller arthroplasty is a fantastic procedure for distal hallux ulcers. It can be technically difficult, and so most of the time I'm scrubbed in, and you'll see with an open transmetatarsal amputation, I'm mostly the cameraman taking video while the residents are doing it because it's a lot easier, and I'll show you that in those videos. But the Keller arthroplasty, it can be technically difficult if you don't take enough of the proximal phalanx at the metatarsal phalangeal joint, because it's very hard to get out at that point. It's a great procedure for offloading the distal hallux, but the base of the proximal phalanx, you need to take approximately 30% of it in order to have an adequate piece to take out. And then the adductor hallucis muscle is attached to the medial side of, well, I guess it would be the lateral side, the inside of the foot of the base of the proximal phalanx, and that's also difficult to remove from the bone. You don't really want to do it with a scalpel because you can't see the end of your scalpel when you're in there and you're just blind. So I mostly use a curved Mayo scissor to get in and remove the medial, that transverse head of the adductor hallucis muscle. Those procedures are fantastic for distal hallux ulcers. Oftentimes the ulcer heals before the sutures are removed from the dorsal incision, and so it does result in pretty significant offloading. There is some transfer of force when you do the Keller arthroplasty to the second toe. So if you have a long second toe, compared to it's going to be longer after a Keller arthroplasty anyway, but if you already start out with a longer second toe, there's a risk of not only an ulceration, but then sometimes hammering of that toe because of the compensation of the flexor muscles. Ready to go? Okay, good. So I'm using Google Slides for this one instead of PowerPoint because the videos I have uploaded to YouTube and they have to run on the web. So this is we call this the 4-minute TMA because it's an open guillotine TMA is really fast, and it should be fast. It's mostly done in cases of emergency when the patient is septic and you need to get source control very quickly. So you don't really care much about the parabola or any of the other factors that you normally do with a TMA. You're just trying to get the source of infection off very quickly. We see these commonly in patients that are septic. They're in the emergency department. They've got a systolic blood pressure of 80, and this is, the only way that we're going to stabilize them is by removing the source of the infection. So so let's first look at the outcomes after closed TMA before we move on to open TMA. There was a systematic review looking at 22 studies, around 1,600 patients, and the outcomes show a healing rate of about 70%. There is a major amputation rate after TMA within 18 months of 23.9%. There's a relatively manageable postoperative infection rate. This is very common to commensurate with other diabetic foot surgeries where there's an open wound. Postoperative infection rate's around 15%. This is around 16%. And commonly you have to perform a revision of these and take back a little bit more bone, or maybe if the parabola isn't correct, there may be a revision necessary. Looking at patients that have PAD, this comes from our unit, Larry Lavery. This was a retrospective review of 125 TMAs that had an angiogram or a CTA beforehand, and there were 17 failures in this group, and the main conclusion was that 2 or more vessel runoff to the foot had over 75% success of limb salvage. And so it's really where you have 1 or no vessel runoff to the foot where you're worried about some of these failures occurring in the transmetatarsal amputation. And this was a combination of both open and closed TMAs in that study. So if we look at the outcomes of a guillotine TMA, these TMAs are open. Now you can allow them as an open TMA to go all the way to closure through by putting on tissue and then vac and then later a split thickness skin graft. That's often how we do it, and we do it that way so we preserve length. Many times patients that are presenting for an open TMA in an emergency already have destruction of the plantar flap, so you're not going to have adequate tissue to be able to use a flap planarly to close. And in those cases, you would have to revise and go back to either a more proximal midfoot amputation or a very proximal TMA, and you're sacrificing length. One of the other benefits of an open TMA is that the patient can be ambulatory throughout the entire phase. You're not, with a closed TMA, we're keeping people non-ambulatory for at least 3 weeks afterwards. And if somebody already has a below-the-knee amputation on the other side, or they're older and they're not able to be non-ambulatory, an open TMA is actually a good idea to keep them from reducing their fall risk and keep them ambulatory. So they're ambulatory in a removable cast walker, and they can have vac therapy, everything else that you're going to do with an open TMA, and be ambulatory in a removable cast walker. So we've talked a lot about wound vac, but wound vac really is probably the thing that saves the open TMA. This pivotal study, which was published in 2005 in The Lancet, it was in the issue of The Lancet where the cover, you may have seen the cover of The Lancet because David Armstrong talks about it all the time, and it says every 30 seconds somewhere in the world a limb is lost as a consequence of diabetes. That was the cover of this issue. And this was a randomized controlled trial of 162 patients following some level of partial foot amputation, some partial raise, open TMAs, open midfoots. And what we found in this was that more patients healed in the negative pressure group than in the controlled therapy group, which was standard moist therapy. And there was a lot faster time to granulation tissue and closure. These are some of the graphs from the study showing faster granulation tissue, so this is on the left-hand side is what's called a survival plot, and so that's you don't want your wound to survive, right? So you want the wound to close as quick as possible. So you're looking at the blue line going down with the TMA with the negative pressure wound therapy group. And then on the right-hand side, we're looking at the incidence of re-amputation in the negative pressure group versus the control group, and that incidence was also significantly lower. So negative pressure wound therapy is really a key to in keeping these open TMAs viable and allowing you as a bridge to get to the next step, which is probably going to be split thickness skin grafting. So our considerations for an open TMA, patients that have sepsis or SIRS, if they have a necrotizing infection, if there's already major loss of plantar tissue, in patients that have chronic limb-threatening ischemia, they surprisingly enough, an open surgery might be better than a closed surgery in those patients, and especially later when I get to the next session with my talk on the transverse tibial transport, which is a method, it's a bone surgery to improve perfusion. You just have to give yourself enough time to get to the point where you have enough perfusion. And then if patients have a fall risk or they're unable to be non-weight bearing. So then we look at risk factors for poor outcomes, patients that have ESRD or they only have one vessel runoff. And then the other considerations that are pretty standard in other TMAs, whether we're going to do a concomitant tendo-Achilles lengthening, we look at the parabola and the length, whether there's adequate angiosome perfusion both on the plantar and the dorsal surface. We're going to use NPWT maybe, some biologics or tissues, and whether or not we're going to use hyperbarics. So those are all the considerations that go into the open TMA. We have an open TMA tray, so we have two of them because sometimes we do two at the same time. This is what's in our tray. So we have a 10 blade. The Liston knife, we had one made specifically for us. If you know the traditional Liston knife, it's 12 inches long. We had one that was 8 inches long. We have a giggly saw with two handles, lots of hemostats and vessel ties, and then we think about the other things that are in the room are the tissues, skin stapler, and negative pressure. So this is a patient that comes in, already a below-the-knee amputation on one side, unable to be non-weight bearing after a closed TMA, has some obviously critical limb ischemia, and so we're going to perform an open TMA here. So the first step is, you can turn the volume off. Yeah. The first step is just taking a 10 blade and just going circumferential as deep as the 10 blade will go around the skin. The idea for these is that you got to be very fast, and that's why this one's done actually in 2 minutes and 36 seconds. The whole procedure's done, and you have to be very fast with these because if you have arterial bleeding, it's going to bleed everywhere, and you want to get you're not going to be able to get those arteries clamped until you get the forefoot off. So the longer you spend there, the more bleeding you're going to have. So circumferential with the 10 blade. And you can just bury the blade. This is one of the residents. They're putting the towel clamps on wrong. They're supposed to be on pointed distally so that you can hold them with one hand. If the volume was on, you'd hear me say that. And this is a Liston knife. It's a shorter Liston knife than if you would perform a below-the-knee amputation, and you just go all the way down to the bone. It's pretty easy with the Liston knife. Some Liston blades are sharp on both sides. This one obviously is not. You can see that's my fellow using his finger to support the knife on the dull side. And then with the giggly saw, we always go from lateral to medial. It's just easier because of the external rotation of the leg, and it doesn't take very long to get through this, 30 seconds maybe, but you have to, when you're using the giggly saw, a couple of things. You got to make sure that you're constantly moving, and that you're always thinking about the exit point. And so if you start to change your angle, then your exit point's going to come out through the skin. So you have to always be thinking about the force of the giggly as it's going through. This is just a kind of a wire blade, and you got to move your hands pretty fast, and if you stop, it's really hard to get started again. And sometimes the handles can come off the blade, and you can see there that was maybe 10 seconds to get the foot off, and so then if there's any arterial bleeding, we go ahead and clamp those arteries, and so here's another one. So oftentimes we'll use tissue at the same time. If there's no infection that's remaining, just go ahead and put tissue on, staple it, put the vac on. We use a vac setting of in most cases of minus 125. If there's significant ischemia, then we'll reduce it down to minus 75. So this is another one of our residents going circumferential with the blade. Then using the Liston knife. So these have to be sharpened a lot, so it's good to have them. They get dull when they're rubbing against the bone. And you just want to pull with this. You don't really want to saw. And so they should be sharpened about every 5 or so surgeries. If you send me a message afterwards, I can send you a link to these YouTubes, and you can send it through Dr. Kesavin. So here's the giggly saw, and you can see that this person's having they're a little bit, having a little difficulty getting all the way through. And so usually in the background, I'm saying faster, got to go faster. Separate your hands a bit, because the wider your hands are, the more surface of blade that you're going to have to cut. So thank you very much. Yeah.
For showcasing the procedure. Following this, Dr. Madhu Periyasamy will present his session on tendon balancing in diabetic foot.
So thank you. I had 2 overlapping talks. One was the peroneus brevis, which is mentioned on the brochure, along with tendon transfers. So I decided to make it a single talk. And instead, for the second talk, we'll have a talk on free flaps in the diabetic foot. Maybe for the plastic surgeons and for the general surgeons, it'll show you when you need to refer to a plastic surgeon. So now coming back to tendon transfers in the diabetic foot, we have a small recap on the movements of the foot and ankle, which we did yesterday. So there are 3 joints there in the ankle joint: the tibiotalar joint, the subtalar joint, and the transverse tarsal joints. The transverse tarsal joints are the one in green. On the medial side, it's the talonavicular, and the lateral side is the calcaneocuboid. So there are 2 columns in the foot. So the medial column, the talus on the side up to the metatarsals, and the lateral column, calcaneum, cuboid, and metatarsals. So on the plantar side and on the dorsal side. The three basic axes of movement: dorsiflexion and plantar flexion, inversion and eversion, and abduction and adduction. So why is all of this important? Because you need to exactly know where the tendon lies along when you divide the foot into the axis of movements. So the ankle axis is a transverse axis. It's a slightly oblique axis. Any tendon that lies behind it will cause plantar flexion, and any tendon that lies anterior to it will cause dorsiflexion. The broken blue line is the subtalar joint axis. So any tendon that lies medial to it will cause inversion, and any tendon that lies lateral to it will cause eversion. So once you are sure with the lie of the tendons around the ankle, that is how we proceed to tendon transfers. So usually it's a combination of movements, pronation and supination. So what are the most common tendon transfers used? There is a series of the tendon transfers. The first 5 are usually a stance phase transfer. These are tendon transfers that act during the stance phase when the foot is on the ground. The last is a swing phase transfer. It helps the foot when the foot is off the ground. So peroneus longus to brevis transfer is the transfer which is usually combined with an EHL Jones-Steno suspension. The peroneus longus to brevis is the more important part of this transfer. It is usually used for a first metatarsal head ulcer. I think those of you whom would have listened to me yesterday's talk, the peroneus longus goes around the lateral side of the foot and inserts into the base of the first metatarsal. It is primarily a metatarsal flexor and a secondary everter. But doing this transfer, the idea is to take away the metatarsal flexion but retain the eversion by putting it onto the peroneus brevis. The Jones transfer is a transfer that was primarily used for correction of claw toes. So it is a static claw toe correction operation. It helps it is an add-on to the peroneus longus and brevis. So this is a video. So here we had a patient who had a problem in the first metatarsal head, and you see that there is a plantar flexed first metatarsal head also. On the pedobarogram, you can see there is a pressure on the first metatarsal head area. So the first, you start off with doing the peroneus longus to brevis transfer, because that is going to act like a tendon that is going to hold the metatarsal down. So you don't do the EHL Jones first. You do the PL to PB first, so that you release the tension on the plantar tension on the foot. The incision is made just behind the fibula, and then you open the deep fascia, identify the peroneus longus just behind the fibula. You cut the peroneus longus, leave the distal end free. The proximal end is taken, and then you do a pulvataft weave into the peroneus brevis. We usually use 3-0-proline sutures, that's enough. And we do about 2 weaves. We insert it about twice into the peroneus brevis tendon. Once that is, you can see that then that area is again fixed with about 2 or 3 sutures of 3-0-proline. An important thing is you need to try and close the deep fascia once you do it, otherwise there'll be a sort of bulge outside. But if it's not possible to close the deep fascia, you can just close the skin. So after that, you go to the dorsum of the foot. Here what we are doing is we are separating out the EHL. Once we separate out the EHL, you go on, locate the metatarsal, do a subperiosteal dissection, then with a 4.5 drill, you make a transverse tunnel, and then weave the tendon through that tunnel. So in fact, we are trying to create a new insertion here. There are 2 or 3 methods of creating a new insertion. One is a transverse bone tunnel, the other is a suture anchor, and the third is a interference screw. The transverse bone tunnel is the strongest way of creating a new tendon-bone interface. So once that is done, the pulvataft weave again, so the tendon is weaved onto itself. So here now the metatarsal is being held up and the claw is getting corrected, because the pathogenesis of the first metatarsal head is both a peroneal overdrive and a claw. So if you have a supple foot, with both of these, you can do a combination of this tendon transfer. But however, in a stiff foot, we would prefer to do a dorsiflexion osteotomy, where you have a scarred foot. So you do a combination of a PL to PB with a dorsiflexion osteotomy. A PL to PB is sometimes even done after a metatarsal head excision, because the residual stump starts to plantar flex. So your ulcer, even if you excise the metatarsal head, your ulcer keeps on migrating proximally. That is because of the intact peroneus longus. So at that time, we would prefer to do, even with a metatarsal stump excision, we would do a PL to PB transfer. So that is another indication there. Now we move on to the next tendon transfer, which is the FHL transfer. It is a tendon transfer that you do for reconstruction of the Achilles tendon when there is a gap of more than 5 centimeters and it is not reconstructable with a tensor fascial lata because of the loss of the insertion of the Achilles tendon. So you don't have, you have a gap, but you can't bridge it because both ends are not available. If the distal end is available, you can do a tensor fascial lata graft. So for example, here is a patient. So he had pain. This patient, for this video, he did not have an ulcer. But I would do the same thing if the patient came with an ulcer, but in stages. In the first stage, we would go ahead and make the foot ulcer-free. And then for the second stage, then we would take him for a tendon transfer. You can see the calcaneal gait when you put him on a pedobiogram, even though his walking looks okay. So once you take that, you put him on a semi-prone position, turn him to the same side so that the entire tendon is exposed. Dorsally, you have a good view of both sides of the foot. We usually prefer to take a medially based flap so that if we have a problem with the wound healing, we would just take a lateral calcaneal artery flap and close it there. So we prefer to take a medially based flap rather than a central flap or a laterally based flap. So the entire, you can see that is the bridge of the fibrous bridge that has been created. So a lot of times people say that even if you allow the wound closed management of Achilles tendons, this is how it happens. It happens with a bridging of a fibrous tissue, which is in fact not effective at all. You can see the calcaneal gait that was there, even though you see that there is a fibrous bridge there. So we would actually prefer to excise out the whole thing. For any Achilles tendon repair, the most important point is debridement of that ruptured Achilles tendon. You can't repair bad tendon and try to get a good outcome. So once we have taken off the gap, we go into the deep fascia, the fascia that separates the deep compartment. You can identify the FHL there. It is called the beef of the calf. So that's the only muscle that has a lot of muscle in that area. That's the tendon. It comes from the fibula onto the medial side. And once you identify it, you can pull it and identify the flexion of the toes. So we prefer to take the tendon out completely from the distal insertion so that you have enough tendon length to actually bridge the gap also. So once that is hooked out, we identify the distal area, and before we cut it, we would also identify the tendon in the midfoot, because there is a connection between the FHL and the FDL, which if you do not disconnect, you will not be able to retrieve the FHL in the ankle. So you need to identify the FHL in the midfoot also. You can see there, once we take it out, we disconnect it here. Retrieve the tendon in the midfoot, and when you give a good dissection, you can also see the connecting fibrous band between the FHL and FDL. Once you disconnect that, you'll be able to retrieve the tendon in the ankle. And that is quite long. So again, here also, we would prefer to do, see that is the FHL, we would prefer to do a transverse bone tunnel. We take care to make sure that the incision is placed away from the postitibial vessels. We use a 4.5 drill. Sometimes we would use a 5 mm ACL drill. Get through it, try to enlarge the hole a little bit. Again, using a tendon transfer, bring the tendon. We bring it, prefer to bring it usually from the medial side to the lateral side. So again, use a straight tendon tunneler, go through the bone tunnel, and then bring it out. And again, a subcutaneous tunnel, so now you have a sort of a loop there. And if you see, then again a small pulvertuft weave to fix it onto itself. So now there is an FHL transfer, which the FHL muscle in time can hypertrophy and substitute for the Achilles tendon. But if you have a working Achilles tendon, see that is the reason why we left this long. Now we will also use that to bridge the gap between the Achilles tendon and the new insertion. So now this transfer will start to act both as an Achilles tendon repair and a tendon transfer, which is, it is an Achilles tendon repair that has been augmented with a tendon transfer. So we use this residual fibrous band to pull it there. But you must also be aware that when you have a long-standing Achilles tendon injury, usually you have a adaptive shortening of the muscle. So it's very difficult to get back the original length. So unless you have the original length, you will not have the power of the Achilles tendon. The original muscle power will not come back. So that is where the tendon transfer here helps. So once that is done, we prefer to close the skin, and we usually immobilize these patients for about 4 to 6 weeks. So next we go on to the tibialis anterior transfer, as we had seen yesterday. So this is a transfer. So you can see the tibialis anterior is actually an inverter. So if you have an everter loss, whereas you have an intact inverter function, for example, like this patient here. So here, this is what you have is you have an inverted hind foot along with a equinus contraction. This is a young boy who had a club foot. So he came with an ulcer on the lateral side. So the first step would be healing of the ulcer to get a wound-free foot. Then you go ahead with a tibialis anterior tendon transfer. And this is how he was walking preoperatively. You can see the equinovarus deformity. And this is his gait afterwards. But a growing child, be aware, will keep, he may recur. So you need to always keep these patients under good thing, because if it fails again, then you'll have to go for an ankle fusion. So the Girdlestone-Taylor transfer is a method of intrinsic reconstruction of the claw and claw toe deformity, but however, this is a very complex transfer. A tenotomy has made the need for this transfer, now it's not needed much. When you go for the swing face transfers, it's usually for anterior compartment loss. That is, you have a common peroneal nerve palsy or you have a sciatic nerve palsy. When you have an isolated common peroneal nerve palsy, you can do a tibialis posterior two-tail transfer. Whereas if you have a sciatic nerve palsy with partial recovery and only the gastrocnemius or soleus has recovered, no other muscle is there, the tibialis posterior is not acting, then you go for a static brittle transfer. So here you have the two-tail transfer. You take out you can use the interosseous route or a subcutaneous route. We prefer the subcutaneous route, two tails, EHL and EDL, and that's done. Whereas for the brittle, you take the peroneus longus and use it proximally and bring it about into the same wound. Tibialis posterior is taken this way, inserted into the tibialis anterior and the peroneus longus. So the tibialis posterior is now hitched up to the tibialis anterior and the peroneus longus. So it's sort of like a bridle for the horse. So now it is a static transfer that will not move, but it will help to correct the foot drop and allow the patient to walk better. So that is how this is a simple tibialis posterior transfer, and you can notice that there is no foot drop. So thank you.
Thank you, Dr. Madhu, for walking us through this tendon balancing method. Back again, Dr. Rajesh Kesavan shares his views on tendo-Achilles lengthening and gastrosolius recession.
Like the cheetahs in this picture, no? You need to be always be alert. Even the hunter can get hunted, so you have to keep looking at all the problems. The same way with diabetic foot, no? You need to have a overall view of the foot. You need to be aware of all the complications which can happen and be ready to manage them. As far as possible, you need to look at going for prophylactic surgeries rather than going for curative procedures so that the patient doesn't develop an ulcer. Just a brief view on the anatomy. So the gastrosoleus, the triceps surae is makes up the superficial compartment on the posterior leg, and it's made up of the gastrocnemius, soleus, and plantaris muscle. And you find the short saphenous vein as well as the sural nerve here. So you need to be aware of these structures when you're dealing with any procedure in the posterior leg compartment. So here you see how the gastrocnemius and soleus are related. Gastrocnemius is coded red here and soleus is coded green. Both join together in the, somewhere in the mid-leg area and together form the tendo-Achilles. One thing you need to notice, the gastrocnemius crosses the knee joint, so it is an important flexor of the knee joint. So that is important when you have contractures in the leg. When you have an equinus, you need to make sure whether it is because of an isolated gastrocnemius contracture or it's a combined gastrosoleus contracture. For normal gait, you need at least a 10 degrees of dorsiflexion with the knee extended. Otherwise, there is going to be excess pressure in the forefoot area. So, in a normal person, you find that the pressures are the stress levels in the forefoot are normal. With the during walking, you have to have at least 10 degrees of dorsiflexion. If the 10 degree of dorsiflexion is not there, in cases where the gastrocnemius is or gastrosoleus is tight, a lot of stress is there on the forefoot area. So that can result in ulceration happening. So you can see a pedoborogram which shows increased pressure in the forefoot in patients with equinus. Because of neuropathy, there is structural changes happening in the tendo-Achilles. So it loses elasticity and results in shortening of the tendon. So you find that the gastrosoleus complex, the tendo-Achilles becomes a little shortened. So that pulls the calcaneum up and the midfoot starts breaking, or there could be an ulceration in the forefoot. So you have increased pressure in the forefoot as well as in the midfoot area. It can predispose to a Charcot foot. So whenever you find equinus, you need to rule out a gastrocnemius contracture or it's only a tendo-Achilles contracture. You need to find out why that equinus is there. So with the knee extended, you dorsiflex the foot and see. Here you can see that the gastrocnemius muscle crosses the knee joint. So with the, here this patient has some amount of equinus even with the knee extended. But when you flex the knee, gastrocnemius relaxes and you will be able to dorsiflex the foot pretty well. So in that case, you call that as a gastrocnemius contracture. So here with the knee flexed, you overcome the gastrocnemius, you relax the gastrocnemius, so you are able to dorsiflex the foot. In cases of tendoachilles contracture, even with the knee flexed, you are not able to dorsiflex the foot. So that is the main difference between gastrocnemius contracture and tendoachilles contracture. So you can do the silver skull test. Again, the same what I had shown earlier. So that you can do to define a gastrosoleus contracture, whether it's an isolated gastrocnemius or gastrosoleus contracture. So you need to look at the anatomical levels in the foot. The area where the tendoachilles is there, that is the zone 1. Any procedure done here, most of the procedures done here is tendoachilles lengthening. You have the Hoek, White, and Paley procedures. The next zone is zone 2, where you have the gastrocnemius tendon and the soleus muscle. Soleus has not yet become a tendon here at this level. Above that, it is zone 3, where both are muscles and part of the gastrocnemius is a tendon here. So here it's a distal gastrocnemius release. The procedure is the Strayer procedure. So we do the Hoek's procedure, a triple hemisection as far as tendoachilles lengthening is concerned. We make 3 cuts. The first cut is about 2.5 centimeters above the insertion of the tendoachilles. That is the first cut. Second cut is about 2.5 centimeters above that level. And the third cut is again 2.5 centimeters above the second cut. So these cuts are in opposing areas. It's a hemisection. So you insert the blade in the middle and cut rest of the tendon. If the ulcers are on the medial aspect of the foot, try to have 2 cuts on the medial aspect. If the ulcers are on the lateral aspect of the foot, try to have 2 cuts on the lateral aspect. The distal cut as well as the more proximal cut. So this is in a different plane. Here it's a cadaver study, which again tells you how when the cuts are made and the tendon is stretched, you find there is some amount of lengthening happening here. So again, in the cadaver, you can see the stretching happening. So this was a patient where tendoachilles lengthening helped in healing the wound. So before doing the procedure, you always use the goniometer and see how much of dorsiflexion is there with the knee extended. So here, even with the knee extended, the dorsiflexion is only at 90 degrees. You don't have any dorsiflexion beyond the midline. So you mark the edges of the tendoachilles. So both the borders of the tendoachilles, medial and lateral border, you try to mark. And you make, this is the insertion of the Achilles into the into the calcaneum. And 2.5 centimeters above that, you make marks. We use a 15 size blade. We insert the blade vertically and turn it 90 degrees. We don't try to use the blade to cut through. We try to slide the tendon over the blade so that it is a controlled cut. Otherwise, you lose the balance and the blade can cut through the skin. So you need to be careful when you are making the cut. See, I'm going vertically and I'm turning the blade to the other side. And I'm trying to push the tendon towards the blade. So that is a much more controlled cut. The same thing is repeated over the other two places. And then you can just try to dorsiflex the foot so that the tendon lengthens. And at the end of the procedure, always check how much of lengthening you have. So here from 90, it has gone up to 110. So you have a 20-degree lengthening of the tendoachilles. A number of studies have shown that this is a pretty safe procedure. And there is some amount of complications here. If the patient doesn't do enough dorsiflexion exercises, there is a good chance that there is a recurrence of the equinus. So you need to ask the patient to do dorsiflexion exercises post the procedure. A number of cases, there has been a need for a re-lengthening procedure 12 months from the time of the original surgery. Madhu Tiruvudila and a group from the UK, they have tried to do tendoachilles lengthening as a primary procedure for patients with acute midfoot Charcot arthropathy. So what they did is tendoachilles lengthening was followed by a weight-bearing TCC. And what they found out was at about 12 months, 30 of 33 patients returned to their pre-procedure level of mobilization. The disease progression stopped or receded to a lower stage. And this was a study which looked at about 64 patients randomized to either immobilization in a TCC or combined with a percutaneous TAL. 29 of the 33 patients in the TCC group and 30 out of 30 in the TAL group healed. But the chance of recurrence with the TCC group was very, very high. As far as tendoachilles lengthening was concerned, the risk for ulcer recurrence was 75% less at 7 months. So just doing a TCC may not be enough. So ideally, you need to combine it with the tendoachilles lengthening. But one problem with tendoachilles lengthening is there is a high chance of, not great, but again, you have a chance of the patient going in for a calcaneal gait. So once a calcaneal gait comes, the chance of heel ulceration is pretty high, and the patient is going to trouble you for a very, very long period. So in those cases, I think we have now moved over to gastrosoleus recession. So usually we do this at this level. So in the zone 3, that is the area that we prefer to do the gastrosoleus recession. So again, you need to check for the presence of equinus. You need to document how much of equinus is there. See here, there is not much of dorsiflexion happening at all. So you mark the outlines of the tendoachilles as well as the gastrosoleus muscles. So when you are making an incision, be careful that you don't damage the short saphenous vein and the nerves which are close to it. We usually don't use a tourniquet for this gastrosoleus recession. You go up to the gastrocnemius fascia and you make a small cut in the gastrocnemius fascia. You can use a pickup, and with the blade, you can proceed with cutting the gastrocnemius fascia. So you are cutting it. With the retractor, you can retract on both the sides so that you are sure that you complete the cuts on both the sides, both medially as well as laterally. And post that, you need to try to dorsiflex and check whether there is sufficient dorsiflexion. number of times, even after cutting this fascia, the dorsiflexion is not sufficient. In those cases, you need to cut the median raphe which is present there. You can use a hemostat to lift the fascia, so you make a controlled cut of the fascia. You can see the median raphe there. So in case the dorsiflexion is not sufficient, you need to cut the median raphe. Thank you.
Thank you, Dr. Rajesh Kesavan, for your surgical precision and insight. Now I welcome Dr. Jessie Thomas for sharing her insights on how do I do bedside debridement.
Good morning, everybody. Sorry. Sorry about the quality. Go back. How do I go back? Sorry about that. So after listening to the prophylactic surgeries, offloading techniques, tendon transfers, I'll not be wrong in saying that even now we have a whole chunk of patients roaming around with non-healing ulcers who refuse to come back on time and land up with major amputation. So it's more about preventive and wound care, what I am going to talk, and which I have learned over decades by mistakes and from my teachers and my seniors. Wagner in 1984 described debridement as removal of devitalized tissue, and it's a gold standard of wound care once ischemia is excluded. This is very important because if there is ischemia, you are not supposed to debride. So it's a very important part. So the first comes when you talk about basic wound care or basic OPD care, outpatient care. The most important part is about skin care. This patient came to me after a skin graft, and if you see, there are small wounds there. This is the thing. No, the highlight. Sorry. This one? So he was washing with saline routinely because his previous doctor said that. And then if you see, you can see this acute dermatitis here because of washing with Dettol and Savlon. This was the reason why he came to me. What was required was I just washed it with plain, simple, boiled cold water or Bisleri water, and I told him to do that because our skin doesn't require saline. We cannot have a bath with seawater. What you require is pure water. So you clean it with saline, and I gave him some steroid cream to apply. Within 48 hours, the skin resolved. So this is about bedside management of skin. Now coming to callus care. Here, when I was sitting there, I saw most of them filming Dr. Madhu Paryasami's and Dr. Rajesh Keshavan's video. So I understand most of you sitting here are surgeons and plastic surgeons. So a callus care would be too frivolous for me, but still, because Rajesh told me that I have to do this, so I am showing you how I would debride a callus. So the first thing is I would position my foot in this way. I have a pillow like this, a sterile sheet. After cleaning the skin completely, I steady my grade 2 there. Then I take a blade. This is how I do a bedside debridement. So I do it this way. So after cleaning, I take a blade. I do not use a handle. Here I'm taking a 22 number blade. This is a 22 number blade. I do not use a handle because I get better control. Somebody is helping me counter traction the grade 2. And first, I make a plane there. So once I get the correct plane, I try to give a traction and the other person is giving a counter traction. Even the small procedure is always with the consent. And whenever there is a black dot in the center of the callus, I instruct the patient or the relative, I tell them there is going to be a wound. Here I did not see a black dot, so I knew that there is not going to be any underlying ulcer. I see to it there is no skin tags around and also try to smoothen the skin surrounding it. This is how I would do. The counter traction is very important, and here if you notice I'm using an artery forceps that gives me a better control to maneuver the skin instead of a tooth forceps. The next I have is a hematoma. All this was filmed in 72 hours. So this was the routine case what we get, and I thought that would be helpful. People ask me, why do you want to take out or de-roof that skin tag there over the hematoma? Why don't you just puncture it? That would be easier. You will not leave behind a wound. But I would like to do it this way because sometimes it is not a clear fluid or a clear liquid what you get out of it, or you actually can sometimes see a clot there. So just by a mere puncture, that is not going to come off. And sometimes if a clot is present, that can give rise to secondary infection. So the next will be, the next video I'm going to show will be of a hematoma where actually there is a clot. Now here, even though the patient came with a hematoma, he also or she also had a small callus. So you have to look at the foot as a whole. You cannot just look at the callus and the hematoma and send her back. So I also did a callus care there. I'm sure Dr. Madhu Paryasami would have asked for some kind of a tendon transfer. I am not very skillful in that part, so I think I resort to all these techniques. And so this, if you see, you have a, after de-roofing, you can see a clot there. So here, just a puncture would not have worked. So I would like to clean the clot which was present, avoid a secondary infection there, and this would heal fast. All this has happened because patient was not, yesterday I think Dr. Kothrud explained as to what is the shear friction and the shear force and the reason for getting these kind of blisters and hematomas. So this again, this is a patient who had a popliteal artery thrombosis, and that was a wound swab which I took for culture. Even though the wound is almost going to heal, at any point of time I see a kind of infection below the callus, I always culture, whatever might be the stage, so that it helps me to know whether it is some kind of a deadly microbe which is sitting there. Along with that, I think most of my wound care, more than the skills, it's the passion with what I do. If you see me, I am always gowned. I am always, the wound, leg is always draped well, and I always see to it the leg is washed. So it gives, and I think this I learned it from Dr. Mangal. Respect the foot what you treat. He has always told me wash it. And so I think that was something what I learned from Mangal, and most of the things I learned it from Sir Dr. Pan. But this washing the leg and taking care of the leg and the passion comes with it has come from Mangal. So this is, I am syringing the wound. Here I use a 22 gauge needle. At a 1 arm's length, I syringe. It's more of mechanical. If I use a wound care solution, it is biofilm oriented. So I clean the skin around it, and wherever I have used a blade, I try to use a cream, antimicrobial cream like a tea bag ointment there. So skin macerations, I try to avoid blades, and I use scissor because it gives me better control. When I use a blade, sometimes there can be bleeding because I don't get good control. So this is a simple, sorry, it's gone. Anyway, this is another chronic wound which came to me, OPD. Sorry. Sorry, anyway. So this, first I'm taking out the callus there. This was the patient who came to me first visit. So after washing the leg thoroughly, first I tried to take out the callus there. Then I dealt with the peri-wound maceration. It is a repetition, I know. The peri-wound maceration, where I'm using a scissor. After this, I'm taking this tissue out for a culture. Preferably, we don't swab the wound for culture. It is, even if it is the first visit, I take a tissue for culture. You can see I'm sending the tissue for culture. After this, I'm probing into the wound to see if it is deep or if there is any pockets, or is it probing to the calcaneum. For the remnant necrotic tissue, I would use something like a dressing material which can do the debridement for me during the next visit. So this again is an acute post-operative wound. This is not of much importance. Even here, I would like to deslough all this to reduce the bioburden. So that, and after that, I would like to use a debriding agent like a debridase cream or some kind of patch which has got TLC fibers, which will help me in debriding it the next time. Amongst the bedside debridement, negative pressure wound therapy is one of the important bedside procedures for debridement, but I have not covered in this because it will take a lot of my video space. This is a debridase cream what I am using. This again is a patient with chronic lymphedema. If you see, she had this ulcer for quite a long time, but it was not treated. It was just wound care what was being done. What actually was required is a peri-wound skin care, and you can see how well the skin has healed. And also once the wound is healed, I teach them how to take care of the skin apply some kind of moisturizing cream. Every wound care, after the wound care, I do a secondary dressing, which involves a mild compression to it. So once the primary covering is done, you can see I have removed the outside glove and I have a plastic glove inside. So if you throughout the video, if you see my tip of my gloves are hanging out, that's because I wear a glove like this inside. And yeah, I think this is just to, leg is a dependent organ. The moment you hang the leg in a diabetic patient, you can expect some amount of edema. When there is a wound, there is bound to be some amount of edema. So this kind of mild compression garment helps in controlling the edema and helps in wound care. Thank you.
Thank you, Dr. Jesse, for explaining that debridement procedures. Now, to conclude the session, Dr. Madhu Periyasamy presents his views on optimizing free tissue transfer for the diabetic foot, indications and technical insights.
Thank you, madam. To be honest, the question that prompted me to substitute this talk was a question from Dr. Mangalan yesterday morning, which said, to plastic surgeons, how do you assess microvascular aspect to plastic surgical reconstruction? Is a flap surgery needed in the dorsal wounds of the foot? And can it be only a thick split thickness graft? So I'll try to answer these questions in the talk. So what are the roles of free flaps? Flaps are usually useful when you have mostly in class 3 feet. That is when you have an invasive infection with soft tissue loss. You have an invasive infection, and then post-debridement, you have a large defect which needs to be healed. You can use skin grafts. You can use local flaps for small defects, or you can use free flaps. So when do we use free flaps? We use free flaps when you have defects exposing critical structures. So what do we mean by critical structures? Critical structures are those structures which are incapable of producing granulation tissue. Then you can use flaps when you have a large tissue void. We usually use them for juxtaplantar defects, where you have unstable grafts or scars, and then defects that need primary or secondary reconstruction. For example, to enable primary reconstruction, usually in failed Achilles tendon repairs, people have gone on to do, there's a spontaneous rupture, a surgeon has repaired the Achilles tendon, unfortunately there's been infection with overlying soft tissue loss. What we have done is we have done an FHL transfer, but to cover the soft tissue, the transfer, we do an acute FHL tendon transfer. We published this on JPRAS. Then when you have defects exposing critical structures, for example, here is an infected ulcer post-debridement. What you would see is you see the capsule or the sesamoids exposed here and the capsule of the second metatarsal joint exposed there. You keep on dressing this. The capsule is an avascular, relatively avascular structure. What is going to happen is it is going to necrose, the underlying metatarsal heads are going to get infected, and the whole thing is going to come out, and you're going to come out with a suboptimal result. So what we have done here is we've taken a small rectus muscle with its pedicle and just plugged it into that defect. We have done a dorsal anastomosis, and if you see, this has gone on to heal very well. And what are we usually basing this procedure on is deneurotized muscle will undergo fatty metaplasia. So that will start to act like a good blob of fat there, which will keep cushioning your metatarsal. You can see actually the curvature of that foot is near identical to the normal side. Then unstable grafts. So the question was, can you use a thick split thickness graft on the dorsum of the foot? Would you prefer it? For example, if you see that there, many of you would have got this result, particularly when you use a graft overlying a joint, be it the ankle joint or the metatarsophalangeal joints. So you start to get a breakdown, the skin keeps oozing, then you have a small wound like that. The patient has frequent episodes of cellulitis because whenever there is a skin breakdown, there is an open wound. So what we do is we completely prefer to excise that complete unstable graft. The graft itself is unstable, leave alone a scar. Actually, Dr. Jesse's talk had shown one of the wounds that had healed on the dorsum by secondary intention. So whenever a wound heals without dermis, it is unstable. Even with dermis, it will be unstable over a joint. So once you take that off, you have a perfectly healed, recurrence-free dorsum of the foot. So juxtaplantar defects, a plantar defect here, we have put a graft here. These are our patients only. We only put the graft. But the patient comes back to you after a few months saying that there is a constant breakdown of this graft. The answer is not excision and a regrafting. This is because there is a mobile surface here. There's a mobile surface here, and there is an immobile graft that is stuck to the underlying bone or the capsule, which is relatively immobile. So when you have two adjacent defects like this, with different properties, immobile and mobile, there is a tendency for the junctional breakdown to happen. So what have we done here? We have taken a small adipofascial ALT and put it onto the anterotibial vessels, allowed it to shrink, and then grafted it, and that is the long-term outcome. So even for very small defects, we will prefer a flap over a graft when we think that both of the surfaces will not be mobile. So again here, breakdown over the MTP joints. The graft is well settled over immobile, non-mobile areas, but over mobile area, you'll see that there is a breakdown. So the entire thing is again excised and covered with a flap. Now the next indication is filling a void. The patient has come with a small heel ulcer, and you see there is a type 3B Charcot fracture, which is infected. So you open up and you debride. You do a radical debridement. You see there's a huge void there. That is never going to heal by itself. It's going to fibrose, stay bad, and keep oozing. And particularly, this joint cavity is all exposed, so there's going to be leakage of joint fluid from that. So in such cases, we would prefer to put in a gracilis flap to plug the hole. So here is the patient. Later, she underwent an ankle fusion with a dorsal plate. And then, even if she's developed a small defect over there, a small local propeller flap there, and you can see stable wound healing. Now, the calcaneal gait is gone. The patient is able to load the forefoot and hindfoot equally. And this is the type of outcome that they get. You can see here, she has got a calcaneal gait on this leg also, but since it's not ulcerated, we have not touched it now. So you can also do soft tissue reconstructions for heel ulcers. Then the next is enabling secondary reconstruction. So we've got a patient here treated elsewhere who has come to us with a unsightly graft on the dorsum. But our problem was she was developing pain on these metatarsals. And when we found out that the whole forefoot, the first and second metatarsals were actually non-functional because there was a bone gap there. So when you want to reconstruct this, you need to have a good flap over it. So we excise the whole thing, put a nice ALT on top of it. Secondarily, you go in iliac crest bone graft as to bridge the gap, and now you've got a functional first ray. So the loading also comes onto the medial side. So another indication is maintaining the span of the foot. So the span is the distance between the first and the fifth rays on both the hand and the foot. So for example, if you take this foot, if you allow secondarily healing like this is what will happen to the foot. The span will get reduced. So, and as I said yesterday, pressure is a function of surface area. So contact, when you reduce the contact area, automatically the pressures here will start to get increased, and you will keep on getting one ulcer or the other on every side. So you can do gastrocnemius, whatever you do, it will keep on getting ulcerated. So to avoid that, what we do is, if we have a central ray defect like this, we prefer to put in a flap. You can see that the span is near normal now. Because you have a large mass of tissue, there's no severe fibrous contraction is not there. Take this plantar defect. Debrided, healed with a graft. But a graft will also contract. And you can see that there is a overlapping and the metatarsal crushing is there. Instead, when you have a large plantar defect and put in a flap, you can see near normal plantar surface area. So plantar shear is the next indication. For example, two identical defects. One has been grafted, the other has been flapped. This looks well healed. I could actually stop with this picture and tell you this is a fantastic result that we got, and this is a 3-year follow-up. But the actual 3-year follow-up will be this. So why is this happening? This is again happening, as I told you, because this is an immobile graft stuck to a mobile joint over there. But whereas if you put a flap on this area, it will take the shear. If this is going to move, this will move along with it. Whereas if this is going to move, this will not move along with it. And you get a junctional breakdown. So this has also been published in JPRAS. So what are the problems that we face? I think we've got 3 minutes more. I'll just go a quick walkthrough. When we have, this is for the established plastic surgeons who are already doing microsurgery. So these are the problems that we face when we are doing a microsurgical reconstruction. Usually there is severe periarterial fibrosis because of the chronic lymphangitis that surrounds the deep vessels. So you will actually have a cocoon of vessels there. It becomes very difficult to get a pedicle. So what do we do there? So usually what we do there is we go to a plane just outside the adventitia of the artery, catch that plane, use very sharp scissors and start dissecting out the artery. We don't concentrate on the deep veins because we're not going to use the deep veins there. We would rather use the subcutaneous veins. So once we get that out, then we can use this artery for anastomosis. This same problem you'll also face when you do when you have a perivenular fibrosis, because the superficial lymphatics will go along this long saphenous vein. So how do we assess that? Whether this vein is fit enough for a microsurgical anastomosis. You can see here there is a large amount of perivenular fibrosis. What we do is we use the dilatation test. So whenever we harvest it, we check if there is enough venous dilatation. If the vein segment is not dilating well, we do not use it for anastomosis, but we would rather go to a section where there is good dilatability, and we would use a vein graft for the vein itself. Pedicle access, as this we have already seen. Usually we prefer to use, for the 4-foot ulcers, we prefer to use a dorsal pedicle access, because going from here to here, you have the business end of the flap, which becomes the most ischemic part of the flap. So I don't want that to happen. I want my flap to be well vascularized part. So I would rather prefer to take in the pedicle through a transmetatarsal approach and do the anastomosis on the dorsum. So this has helped us to do reliable free flaps on the 4-foot. So this is how we do that and finish it off. So here is another patient undergone a revascularization and a free flap on the 4-foot, maintaining the span. So vein grafts. So when do we use vein grafts? We started using vein grafts after reading Karen's picture, particularly for atherosclerotic vessels. Use a small interposition vein graft when you have both the recipient and the donor are severely atherosclerosed. So this helps you to take inside-out bites on both the ends of the atherosclerosed vessel, and also gives you good ergonomics for you, helps you to have good ergonomics to anastomose these vessels. So this is there. And this vein grafts will start to act like an interposition vein graft there. So that is how that will help. So a scout vein graft, sometimes we take a flap and find that the flow is not enough. So here what we do is we initially do the small interposition patch vein graft and then assess the flow. Once we see that a good squirt of blood is there, we close it up, go on, harvest the flap, and then hitch it as a usual interposition vein graft. You can see that now that vein was anastomosed to the artery there. You can also use vein grafts to extend pedicle length. For example, we didn't have the anterior tibial here, so we used a vein graft to get the posterior tibial artery to a branch there, end to side done here, and you assess the flow. You can see there's a good squirting of blood, and you go on to do a flap there. For example, here we have lengthened the pedicle from the anterior tibial to the dorsalis pedis there, and done a flap. So vein graft for veins, you can use, whenever there's a severe perivenular fibrosis, we do a vein graft for vein also. Usually a Y-shaped vein graft will be taken and done there. And sometimes we would use an additional vein hitched on end to side to the flap vein. Arteriovenous loops, when you want both sides to be lengthened, you can take a long vein and then hitch it to the artery. Acute AV loop, you can see that now blood is flowing through. So by the time you harvest your flap, you've got a matured AV loop. And we plug the artery and the veins end to side to the AV loop. So now you can see that, and we just clip the middle there. So this side is acting as the artery and this side is acting as the vein. So thank you very much for your kind attention.
Madhu, for the practical session, it's enlightening. Now the floor is open for question and answer session.
Question to Dr. Lee. After TMA, what deformity happens? Maybe like aversion, and how to correct it? The second question is, can TMA be done as an outpatient procedure?
So there's not usually, if you're doing a proper TMA and you're distal to the insertion of the major inversion and eversion tendons of the foot, then normally you don't have an inversion or eversion deformity from the TMA itself. Maybe it existed before, but if there was an inversion deformity, let's say when you do a Liz Frank disarticulation, that has to be done sometimes, then you do lose the eversion tendons, but not the inversion side. And we'll do a tibialis anterior tendon transfer to move the force a little bit more laterally. I have done some stats, split tibialis anterior tendon transfers, but I'm almost always disappointed in the amount of correction that I get. So I do a full tendon transfer now. But the most common deformity you get after a TMA is, it may even be present before, would be an equinus deformity. And that's why you address that usually at the time of the TMA with a tendo-Achilles lengthening or a gastroc recession.
So for every TMA or any midfoot amputation, you always combine it with a tendo-Achilles lengthening or a GSR, gastrosoleus recession?
Not for any, but I would say probably about 70% of ours. We still, some patients just have adequate dorsiflexion at that point. And they will develop, I think, equinus over time because they don't have the lever from the forefoot that's helping to dorsiflex and stretch the Achilles tendon. So it's probably an argument to be made to do something more like a gastroc recession with a lower risk of Achilles tendon rupture and calcaneal gait, but I just haven't yet. Do you do it that way?
Most of the time we combine it with a GSR or a tendo-Achilles lengthening because after about a year or so, they keep coming to us with ulcers on the forefoot. So that becomes a little irritating. So,
as far as the outpatient procedure goes, as far as doing it as an outpatient, I have very rarely done a TMA as an outpatient. It has to be somebody that's completely almost elective and stable, no infection. The vascular status has they've already been optimized. But it's rare. I mean, maybe on one hand, I can count the number of times I've done it as an outpatient.
This is a question to Madhu. PAD and tendon transfer. Will you do a tendon transfer in a patient with PAD?
Not with the To define PAD, we would define PAD as impalpable pulses of the both pedal pulses. So such patients, we would not directly proceed to a tendon transfer until we've had the vascular consult and had the vascular intervention done, and then we at least get one pedal pulse that is palpable, then we would proceed to the tendon transfer. So that is how we would.
And one more question, how to take care and prevent wound maceration?
Wound maceration as in around the ulcer? I think the best way is to just nicely debride and scoop the ulcer.
And maybe more frequent dressings. And
Yes.
I can read from here itself.
this is a question to Dr. Lee.
Mic is not big.
I think from Dr. Saravanan. Post-scalar arthroplasty, there is a dead space after taking out the PPX base. It takes a long time to fill. How will you want to obliterate that? And again, will you keep drain for this procedure? If you are keeping it, when will you want to remove it?
I don't typically use a drain in a Keller, but the dead space there's usually contraction right away, and so there's not as much of a dead space as you think. It's not that's held out to length. I have done things in the past where I've skewered a skin substitute like graft jacket, which is human dermis, and wrapped it up and as you're going through with the wire through the hallux into the metatarsal, and just kind of wrap it up so it creates like this big ball to try to create some space there. But I don't do that anymore because I don't really think it made much of a difference. So you do get the osteotomized bone against the cartilage of the metatarsal head, but there's just not as much force there because the tendons are now a little bit looser, and so I don't really think it matters that much. Yeah.
I have a question for Dr. Madhu. Sorry, I'm here. Okay. So while doing a free flap, any moderate size or large flap for the foot, okay. So the arterial anastomosis, you said that you prefer the dorsalis pedis.
Yes.
But for the vein, so you deliberately look for a superficial, like that vena comitatus one, and then another one is either great saphenous or short saphenous. You always do both of that for moderate or larger size flaps.
For us now, after having done about, in the last 3 years, we've done about 180 to 200 flaps. So our preferred vessels are the dorsalis pedis or the anterior tibial vessels for dorsal defects. Posterior defects, we also do if you saw for the heel defects, we would prefer the posterior tibial artery. Vein, we always go for the subcutaneous veins. We find they are better suited for, at least in diabetic patients, because the deep veins are usually, they don't dilate as much. We had about 6 complications and 5 of them were venous complications. So we always go for the subcutaneous vein, look for dilatability, and if the segment is fibrosed, we will always use, we even go to the extent of using a vein graft for a vein.
So my question is, both of those are superficial, or one is most of the time the vena comitatus of that, or maybe another one?
No, you can use a small segment where you have 2 branches of this the saphenous vein and hitch it to both vena comitans of the flap. We try to avoid using the deep veins as much as possible.
Thank you.
And almost like 50 to 60% of patients have some amount of ischemia, no? What is your...
No, sir. Unfortunately, for us, we feel that if the pulse is palpable, we would go ahead and do it. But what is the investigation that we would do is we would do a Doppler to see that the velocity of flow must be at least more than 20 to 25 centimeters per second. So that is so
You
about
don't look
15...
at biphasic, triphasic, or...
We usually don't have that problem. Because the flap, usually the flap demand, particularly for a skin flap, is very low. You don't have a large demand on the...
Post-flap, do you put in how long, and do you do anything special as far as medications are concerned, like aspirin?
Yes, we would put them on low molecular weight heparin, sir.
How long?
At least till they are bedded. So once we start mobilizing them, we will just take them on aspirin.
And I would like to thank the panelists here. It has been a wonderful discussion as far as video sessions are concerned. Thanks a lot for a great audience. Thank you.
Thank you, doctors. Now I request Dr. Rajesh Kesavan to felicitate our speaker, Dr. J.C. Thomas. Next, we move on to session 2. Session 2 features emerging therapies, vascular interventions, and diagnostic innovations in wound healing. The speakers on the dais, Dr. Srinivas B.R., Dr. Vinaya S., Dr. Preeti. To the dais, Dr. V. Balaji, Dr. Lee, Dr. K.V.N.N. Santosh Murthy, and Dr. Rajesh Kanaya will chair this session.
Hello, hello.
We begin with Dr. Srinivas B.R. presenting on his views on maggot debridement therapy, the Indian perspective.
Hello. Today's topic is maggot debridement therapy, the Indian perspective. I am Dr. B.R. Srinivas, Shrikara Maggots and Research Private Limited, Kolar, Karnataka. Good morning, everybody. Before I begin, I would like to take a moment to express my utmost respect and gratitude towards stalwarts of DFSI, Dr. Arun Bal, Dr. V.B. Narayanamurthy, Dr. Rajesh Kesavan, Dr. Milind Ruki, and Dr. Madhu Pereswamy and others who have given the opportunity to give a presentation on MDT, and I have been supporting MDT from last few years. Their guidance led me to have patent with respect to maggot egg logistics, sterile egg transportation, which has shelf life up to 24 hours. Regarding maggot debridement therapy, in spite of having DFU treatments like conventional surgical treatment, antibiotic treatments, good glycemic control by conventional anti-diabetic regimens, NPWT, HBOT, Versajet protocols, the seniors of DFSI have given opinion for at least 30% of all DFUs are in need of MDT in prevention of amputations. Now, what is maggot debridement therapy? Is simply defined as introduction of live disinfected maggot larvae or maggot eggs into the chronic, non-healing skin and soft tissue wounds for the purpose of debridement, disinfection, and cleaning of the necrotic tissue. All over the world, the species used are Lucilia sericata and Cuprina. In Indian geographical content, what we are using is Chrysomia megacephala. This is very important. Coming to the medical uses of MDT, in US, in 2004, FDA has given clear license to MDT as a medical device for the treatment of non-healing necrotic skin and soft tissue wounds, of which 90% comprises diabetic foot ulcers, remaining 10% non-healing chronic ulcers like pressure ulcers, venous stasis ulcers, neuropathic foot ulcers, and non-healing traumatic or post-surgical wounds. Sometimes surgeons have preferred wound bed preparation prior to the surgical closure. And background and history. Now here we have to remember our sage Shushruta's evidence is very important for us. He has documented in Shushruta Samhita, Chikitsa Sthana, chapter 18, Arbuda Chikitsa, shloka 37 to 40, has mentioned maggot therapy in 600 BC. Maggots were used by Mayans of Native America, that is before Christ, Aboriginal tribes of Australia before Christ, And 15th century onwards, military physicians have documented very clearly. Dr. Williams S. Baer has evidenced complete treatment of 21 osteomyelitic cases during First World War. In the next slide, I want to read first 4 lines of the shloka, respecting the Sanskrit language. Nispava pinyaka kulatta kalkaihi mamsa pragadeerdhari mastyuktaihi lepam vidadyat krumayo yatatra murchanti murchantyata makshikascha. The meaning of the shloka here, at that period species is not known. Paste of hyacinth seeds, avarekai. I have given in, on small one in Tamil also. I don't know how to read the Tamil words. Paste of horse gram, paste of oil cake with curd and water, with putrefied meat is mixed properly, placed over the wound, left for 2 to 3 days in the open atmosphere. Thereby, different kinds of housefly will come and lay the eggs, will become larvae and eat away the slough. I have given the page of that book also. Coming to the next slide. This was Dr. William Baer's First World War photo, where he has clearly given cage bandage for MDT in osteomyelitis, because the larva is in need of oxygen for the initial period of 24 hours. Otherwise, the larvae may die. For that reason, 100 years back, he has shown cage bandage. Now, recently, Harrison's Internal Medicine 19th edition has given few lines about MDT in DFU. Now, coming to the life cycle of bottle green housefly. Egg to larvae, hatching time is about 18 to 30 hours. Larvae lifespan is 5 to 7 days. Pupa lifespan is 5 to 7 days. Adult housefly is 5 to 7 days. Almost all the Lucilia, Sericata, or Chrysomia species lifespan is same. And what we here, the important thing to observe, in the larva life, the reproductive organs are immature. Usually the patients do ask, sir, the multiplication may happen. How to prevent it? Because the reproductive organs are immature, there is no multiplication. Only during the time of adult housefly, the sexual organs mature. Now, coming to the mechanism of action of MDT, debridement, removal of necrotic tissue. Maggots, I have given a picture of adult larva, hindgut, midgut, and the foregut. Foregut is having 2 strong anterior hooks, and the hindgut is having anal colon with respiratory apertures. This is very important. Maggots are voracious eaters with the help of 2 strong chitinous hooks clearing dead tissue in the wounds. Disinfection. Maggot secretes the cocktail of enzymes from foregut, midgut, and hindgut. These cocktail of enzymes contains collagenases, peptidases, serine proteases, chymotrypsin, and trypsin-like substances, antibacterial factors like new words. These are all the new words, what we are listening. Lucifensin, lucimycin, defensins, nucleases, and metalloproteinases. Also, the gut secretions contain allantoin, urea, phenylacetic acid, phenylacetaldehyde, calcium carbonate, ammonia. In total, these compounds create alkaline environment in the wound bed, which is not favorable for bacterial growth. And stimulation of healing, active, continuous, robust movement of maggots acts as stimulation of fibroblasts and its function. Indirectly, the biofilm inhibition and eradication. Maggots' activity improves circulation. Now, coming to the spectrum of activity, there is no bacteria which is not susceptible to gut enzymes of maggots. This is complete list of susceptible multi-drug resistant bacteria. Gram-positive bacteria like Staphylococcus aureus, including methicillin-resistant Staphylococcus aureus strains, Streptococcus pyogenes group A, group B Streptococcus like Streptococcus agalactiae, Enterococcus faecalis, including vancomycin-resistant enterococci, and Clostridium perfringens gas gangrene pathogen, and also gram-negative bacteria E. coli, including extended spectrum beta-lactam strains, and also anaerobic bacteria. Now, contraindications for MDT in DFU. Please listen to this sentence carefully. Chronic DFUs, where the necrotic tissue is not amenable to regular scalpel debridement, it depends upon our eye acuity, which tends damage to good granulation tissue. The maggot can precisely cut 0.01 mm necrotic tissue. And also, you can use evidence of MDR bacterial infection. Contraindications: peripheral arterial disease, TAO with ankle brachial index less than 0.8, patients suffering from CKD, septicemia, and MARDS. Now I'm giving few case studies where you can observe the maggot debridement therapy is necessary or not. The first video is first day, and the second video is almost after 4 days. The third video is almost after 7 days. Second video is, you can observe minute creatures, which is about 2 mm in length, 0.05 mm in girth. And the third video is after 48 to 72 hours. If the necrotic tissue is very good, the growth of the maggot is very good. And the first video is after nearly 1 month, having 2 to 3 sessions of maggot therapy. The second video is almost after 60 days. And the third video is almost 90 days. First case is over. Now, second case is very important. Here, interphalangeal joint is totally infected, plantar aspect and the dorsum aspect. The communication between primary wound and the satellite wound is so evident, you can observe it. You can see the interphalangeal joint along with biofilm, infected biofilm. In the third video, the maggots are entering from the primary wound and entering the joint cavity and coming out of the joint cavity also. Now, this is after 1 month. Here we had 3 sessions of maggot debridement therapy. The terminal phalanx is completely saved. Third case, this is operated somewhere else, necrotizing fasciitis. The whole necrotic tissue amidst good granulation tissue. The second video is almost 48 hours of maggot therapy, 4 mm in length, 1 mm in girth. This is after 24 hours, little bit squeamish to see. The length is 10 mm, just after 72 hours. Non-stop voracious eaters. They don't take any rest. They do respire from hindgut. The foregut is in the depth, the hindgut is in the back, and the respiratory apertures are at the back, continuously respiring, continuously eating. I think they don't sleep. This is after 60 days. This is after split graft. And coming to the fourth case, the first video, the second video after, in the third video, you can see the maggots. The maggots are already matured after 72 hours. After 72 hours, we are removing all the maggots. If you don't remove also, it will come out. After maturity, it won't stay there. The first video is nearly after 45 days. Second video is 60 days. Third video is almost after 75 days. Objectives. Under the guidance of DFSI surgeons, training of the respective OT technician to MDT therapists, like NPWT technician, just 2 months training is required. To adapt respective SOPs to handle logistics, CDSCO protocols, which concerns MDT and surgical grade maggot egg transportation, which is under patenting process IPO India, to apply maggots in selective patients with an aim to prevent or minimize the extension of amputation and helping to achieve complete healing of the wounds. Thank you. Thanks, DFSI and Keshavan team.
Next, we move on to Dr. Vinaya S., who will share her views on cleansing solutions, what and when. This session is sponsored by Bactiguard.
Good morning, everybody. First of all, I would like to thank Dr. Rajesh Keshavan and DFSI Executive Committee and DFSI for bringing me here for this lecture. Respected chairpersons and the audience. I work in Bangalore in Bhagavan Mahavir Jain Hospital. In this slide, you can see Dr. K.R. Suresh. I'm working with him from 1992. We were in a corporate hospital for 8 years, where we used to do the diabetes foot education and diabetes education. After that, we opened a podiatry department in Bhagwan Mahavir Jain Hospital, Bangalore. Just a week back, we completed 25 years for our foot clinic, and the team has grown bigger. In this picture, you can see Maureen Bate, who's my teacher, who was my teacher in IDF Fellowship in London, in King's College. My sincere gratitude to her. I have grown in this last 29 years, and I'm here presenting this lecture in front of her. And you can see my happy team who work very hard throughout. This is a disclaimer. I have no commercial interest in the company or the products displayed. Information has been included solely for the education purpose. My topic is cleansing solutions, what and when to use. You have been seeing the slides. We saw Dr. Jessie's slide where she said, washing with the water, sterile water itself is adequate. I agree with that. But still, there are many cleansing solutions which wash the wound to take off the microorganisms. Efficient cleansing is very important for the treatment of the wounds, as it removes the debris and necrotic tissue and decreases the burden of wound colonizing microorganisms. Wound care in Jivas, we have 15 beds. We have a complete foot team of 26 people. We have trained them as wound care specialists. They do the foot care, wound care, helps the people in case of the lower limbs, foot and ankle. Since it's the vascular surgery department, we have vascular wounds also. It is called as HJ. HJ means feet. We started the podiatry department only for the preventive care where we do the foot evaluation education. But from very first day, we do the wound care also because it is attached to vascular surgery department, and we have come very far. We see around 120 to 130 patients every day. The podiatrist in the wound care center has different responsibilities. First, we do the complete assessment of the foot, even if the patient is with the wound, assess the other feet also. Prescription of the creams and the dressings, the wound care minor and major procedures, cons, calluses, and nails. We have a small minor procedure room where we can, it is not a big wound to take the patient to the operation theater, but cannot attend in the foot clinic. So for such patients, we have made small minor procedure room where we do the ultrasonic debridements, bedside ultrasonic debridements also, specialized dressing like VAC and antibiotic beads like meropenem, we do the dressings in the foot clinic. So there are few essential steps: clean the wound daily, dry the wound completely, use the topical medications as we prescribe if necessary for the patient, and use the sterile bandages, and preferably do the dressings every day or alternate days, and keep the pressure off from the wound. The efficient cleansing of the wound is necessary for all kind of ulcers, whether it is ischemic, neuroischemic, or neuropathic. And to understand the healing process, the wound bed preparation is very crucial element. So there are many high risks for the diabetic foot ulcers. It can be neuropathy, poor circulation, foot deformities, wearing inappropriate footwear, walking barefoot, uncontrolled blood sugars, and along with that, the smoking, alcohol, high cholesterols, and uncontrolled blood sugars are another cause. So prevention and treatment of the diabetic foot ulcer also includes very tight glycemic control. The solutions for the wound wash are preferably always normal saline. We also prefer normal saline, but there are times the wounds will be so bad that we have to use betadine dilute solutions, antiseptic solutions like hydrogen sprays, superoxidized solutions like oxum, oxidized waters, vinegar and acetic acid, which is diluted whenever there is Pseudomonas infection. And there are various other products like hypochlorite and hypochlorous acid, microdizin. And especially now, we use silver stream, which is silver nitrate, which kills the bacteria. And Usol solution, very occasionally we used, because there is not much availability or usage among the surgeons, and most of the surgeons don't prefer this. I don't know the specific reason. It is a topical antiseptic for the wound disinfection and cleansing ulcers. And we have 8 vascular surgeons with us, and each one has their choice. And according to their choices, we use the solutions, and most of it works very well. Why normal saline? Why we need to use the normal saline? Because it is isotonic, it's non-cytotoxic, safe and effective, removes the debris, reduces the infection risk, and since ours is a charitable trust, we can use sometimes the low-cost cleansing solutions only, and normal saline is a hospital supply and suits us very well when the patient cannot afford other solutions. And first, wash the hands, keep the normal saline in the sterile bottle only, then clean the wound, remove the debris, dry the area, apply the dressing, and change the dressing regularly. Betadine, again, it's very common, and patient is very happy when we use betadine because they know some colored solution which is coming on the wound is cleaning the wound. We used diluted betadine on some wounds which are infected, and it is not used in some situations, betadine and hydrogen peroxide, because of its cytotoxicity. But there are other alternatives, and if there is opportunity for other alternatives, we choose that, and after a betadine wash, we definitely give a normal saline wash on the wound. It can be used on the diabetic foot ulcers, and most of the healthcare professionals choose betadine. But for skin cleaning surrounding the wound, definitely yes, the betadine solution can be used. And to maintain the moist wound environment, we need to use the other normal saline solution on the betadine because sometimes it dries up the wounds. Uzole or the normal saline can be used during the dressing of the wound, and Uzole has overall better results, granulation tissue, which is developed early. We also use Oxum very often because it's an oxidized water and hypochlorous oxide, and it is the topical treatment for the chronic wound. Sometimes we use Oxum, leave the patient with the Oxum sometimes, then do the ultrasonic debridement, and after a saline wash, we cover the wound. Oxum spray is superoxidized solution for local application, and it's intended for use in the debridement and irrigation of the acute and chronic wounds. And it shows a reduction in inflammation and early healing of the wounds. And there are other many superoxidized solution, wound fix solution. When the patient has brought it once or twice, I have used it. But this is also superoxidized solution, but not available in our pharmacy. It is used for the damaged or infected tissue to enhance the healing potential of the remaining healthy tissue. And irrigation with the superoxide solutions will definitely bring down the microorganisms. It helps in chronic wounds, ulcers, cuts, abrasion, and burns. Hypochlorous acid and the oxidized water is preferred in the modern days, and we use because it works. And we can see a big change in the wound when we use it regularly in the wound dressing alternate days. We also use the microdizin solution. It is clinically proven to be significantly reduce the wound healing time. And we have seen that it established the optimum wound healing environment without irritation or stinging or staining of the wound. Silver Stream, even though it was very expensive a few years back, so we didn't prefer, we used in very few patients, but now it is available freely, and it destroys the biofilm to promote the effective wound cleansing. We confirm that with the wound camera. We take a picture and we see what microorganisms are present, whether gram-negative, gram-positive. And after proper cleansing, we take a picture to see and make sure the microorganisms are washed off. Of course, it is washed off with a normal saline also, but better washed off with the Silver Stream and other oxidized solution. It is non-toxic, non-irritating, contains no steroids and antibiotics, no alcohol or iodine, and is environment friendly, and no special disposal is required. It is very effective in our practice whenever we have used it, and as and when it is required for the patient to go for plastic surgery, skin grafting, we use the Silver Stream for some time on the patient's wound, and also use the ultrasonic debridement along with that. This is the Illuminate camera we have been using for last 5 years. It has helped us a lot to see the wound depth and width, and it also helps us to see whether the gram-negative, gram-positive organisms are present. Since ours is a charitable trust, 80% of the patients are the poor patients. Every time I take a culture and we charge 1,200 rupees for the culture, they cannot afford. That's the reason we take one culture, later we take the wound camera and we take a picture, we make sure whether there is any infection, and decide on the antibiotic usage further. So whenever we are using this camera, we use the hydrogen spray, and this works wonderfully on the wounds. When we do use the hydrogen spray, we can see 99.9% of the microorganisms are gone after a wash when we wait for 1 minute after the wash. So it has got the broad spectrum efficacy and neutral pH levels. It helps to hydrate the dry wound and maintain optimally moist wound healing and environment. It is colorless and odorless, and it's comfortable for the patient, and you can use it for the superficial wound to the deep wounds, and it's available in the aqueous gel spray and gauze form also. And it does not hamper the wound healing process. It is non-cytotoxic to the granulation tissues. And when we used it for a trial, we were very surprised, but since we had help of a wound camera, we could really see when we waited for 1 minute how the microorganisms were washed off, and we could not see any. Almost 99.9% did very well. And it reduces the bioburden and minimizes the risk of the infection, and easy and very comfortable to use. So it's environment friendly, and my staff are very happy to use this also. We have a hospital supply now. So biofilm resistance combined with the general increase in antibiotic resistance among bacteria is double whammy and a major challenge to treating infections. So rethinking of the antiseptics and breaking free from the tradition, we do use the normal saline, peroxide, diluted betadines and silver compound resins, but we can think of the antiseptics also. Blood sugar should be under very good control. This is the ultrasonic debridement we do, soaring machine we use. We also had experience with Arabella for 10 years. Now that's not working, so we have 2 machines, pre and post ultrasonic debridements. You can see this. So we also use the VAC therapy. It works very well, and most of the patient, after 2-3 VAC therapies, we use irrigation along with that, and then move on to the regular dressings. And we use Milcept, which is a broad spectrum, new generation, and it's a very good antiseptic solution, and it's always there on our dressing tray, and we regularly use that. We use the antibiotic beads, preparation and applying on the wound, which is also Indian made, and one comes from abroad. Both works very well. We use different antibiotics on that. So this is the procedure room. So management of the ulcers. This is Dr. Bal's slide. Thanks to him for sharing this slide for me. We can put anything on the wound except the patient's weight, and we always have to improve the quality of wound healing and closure. And we use the modified footwears and the modified insoles, and ultimate goal is to prevent the amputation. Thank you.
Thank you, Dr. Vinaya, for your clarity in clinical decision making. An important announcement. Dear doctors, the checkout time is at 12 noon. You can keep your luggage in the clock room. To contact clock room, please press 0. Now I request Dr. Preeti to express her views on managing venous ulcer. Thank you, ma'am.
Very good morning, everyone. Basically, I think we have a mixed bag of people who are treating diabetic foot, from physicians to surgeons to specialized surgeons. So what I thought, instead of telling how I do a procedure, it is always better when a procedure is to be done, when it is not to be done, or whether actually a procedure is to be done. So going to venous disease, it's a high prevalence in our country, not only because of patients having varicose veins, but most of them will have a deep venous thrombosis, and around 50% of them will end up with something like a post-thrombotic syndrome and will have crippling quality of life. So why does it occur? It all occurs because we pay a price for evolution. We are just standing static. When we are standing static, the pressures are at around 85 millimeters. We are not walking. That's the reason that we end up getting venous hypertension. So this is what I usually explain all my patients. The question comes, doctor, why did I get it? What did I do wrong? Or what should I do so that my next kin or my family members should not have it? The way I explain is, the outer room is your superficial system, inner room where we are sitting is your deep system, and top is your heart. So the way there are doors which say that we are supposed to attend the conference, so we have to come from out to in. That's the way these unidirectional valves will tell the blood to go from the superficial chamber to the deep chamber, and deep chamber up to the heart. So anything which is at fault in this assembly will cause venous hypertension, and eventually it will lead to venous ulcers. So there is importance of the foot pump, the calf pump, because whenever the muscles are contracting and relaxing is where the venous assembly is actually active. After talking all about this, still we get Google doctors and they said, madam, forget everything, I don't want anything. Will any of these things work? No, nothing of this works when you start with C2 or C4 level of disease when we say. And I practice in Hyderabad, and I get to see almost in my OPD a huge number of patients who have undergone these kind of hijama therapies in which different organisms are used. And I think my one patient came up with this article also, because once I said, no, there is no evidence, the next visit he came, madam, it is published, it is on the internet. So is it actually, I said, it has not worked, and you have come to me, itself proves that it is not the right way to treat. And we always believe in Sasta Sundar Tikau, so they want instant, this generation. But if you see, even when we cook Maggi, it takes more than 2 minutes. It takes at least 8 to 10 minutes if you cook a proper Maggi. And so that is what we have to cater to patients' expectations whenever we are treating any ulcer. This is the basic what we do for all the patients, give them flavonoids and kind of compression. We had detailed interactions on the compression workshops, when to do, how to do, and what to do. What is also important is, because I have been talking on calf pump, and calf pump. So there is enough literature to say that whenever we are activating our inspiratory muscles and when we are activating our calf pumps, there is a good venous return which is happening. This is our postgraduate. I have given him this thesis topic. In the next 2 years, we'll come out with results. As of now, there are good results. Venous ulcers are healing well when we are telling them how to do the exercises. We are using actually short stretch bands also and teaching them respiratory exercises. So let's come to what happens when patients with different ulcers walk into our clinic. This is a lady who has come with a classical cellulitis and has developed a venous ulcer in the gaiters area. The reason why I have highlighted certain is she has inverted champagne bottle appearances in both the leg. Pulses are palpable, and we do a scan and we find that there is no DVT which is there in this leg. So this is a pretty straightforward patient in which either I do EVLA or an RFA. The reason why I'm emphasizing is I'll do a thermal ablation. I will use an heat energy to burn these veins, which I can combine it with a sclerotherapy. And I get a good wound, cover it with the skin graft, and the wound has healed, and she's wearing good compression. So this is a pretty straightforward case. And most of the patients come to us and they say that we have undergone laser, but things have not gone right. Unfortunately, now there is that to have leg is only the indication to go laser. Even it is, means this is not the right way it should be. The vein should be at fault to treat it with laser. So which vein is supposed to be at fault? Is it a superficial vein or deep veins? I'll be talking about case scenarios in which after doing a laser also things have not helped the patient. The reason is because in those cases probably laser was not the right choice. So this is a 56-year-old gentleman. He had varicose veins since many years and ulcer in 2019. Seeing the ulcer and varicose veins, going by whatever the investigations was available, in 2020 he underwent a laser. But unfortunately, even after the laser, he had recurrent episodes of painful ulcers. So when we scanned, we found that the GSV was ablated, there was no reflux, but what we saw was the left thigh was bigger. So that is very important that we examine the patient. The indication that his thigh was bigger was giving us that probably there was some deep vein disease which was there. And also, there was a very strong history which none of us actually maybe spent time adequately with the patient to make sure that gives any history. So he had a fall from a bike, trauma which had DVT. This DVT which was not picked up was the reason for he having varicose veins and ulcer in 2019 itself. So when we did an MR venogram, we can see that he had an ilofemoral DVT, and that is why he had an ilofemoral DVT. And if we do laser, it is like what I told you in the first thing. The fault is in the deep veins, and you are ablating the superficial veins. So that was the reason his disease was not healing and he was getting recurrent painful ulcers. So what did we do to the health patient? We have IVUS, like intravascular ultrasounds, in which we can see the veins. We did a venogram. We found that the iliac vein was severely stenosed. So we did is a balloon, there is a wasting, and we did a balloon angioplasty. So iliac vein angioplasty, so there is an inline venous outflow which is there. Because we could re-establish the inline iliac vein outflow, that is the reason this patient ulcer healed. Similar patient, he had a stroke, and after that he had a chronic DVT. The color Doppler report said it was recanalized, but the lumen was taken care of. The valves were still destroyed because of the DVT. That is why he was getting recurrent ulcers. So this was his MR venogram, where we can see that the deep vein is still at fault. So what we do is we passed a balloon over the wire in the iliac vein and then stented this. We wanted a good flow into the profunda vein, so we did iliac vein. What we do is plasty of that vein. So this is an hybrid reconstruction, and with that the ulcer healed. Now another thing is, the reason why I had emphasized is on thermal ablation is because, especially with diabetes or with chronic venous ulcers, patients get phlebolymphedema, where there is lot of scarring which is there. So in such patients, it is better to use non-thermal, because when we are using heat, that will cause more of damage to the fibrosis, and fibrosis will occur. So we have mocha, in which, if you see, these are like prongs, they will scratch the endothelium. So that will be a chemical abrasion, and then there will be a sclerosant which will be sprayed. And also there is something which is like a glue. Glue is like something like a Fevicol or a Fevistick. It will go sit inside the vein and the vein will close. So in nutshell, the emphasis on this talk is not all ulcers need surgery. Good amount of compression, right amount of compression is necessary, because if I am doing an intervention in terms of laser, or if I am doing compression, what I am doing is I am making an incompetent venous system competent. If I am doing laser, I am burning off the vein. When I am giving stockings, I am getting the vein valves closer so that it starts pumping. We have to tell patients to walk, to do calf pump activation, to do ankle exercises. And what is important is we find out which part of the venous structure is at fault. If it is just the superficial veins, do an ablation. If it is the deep veins, then correct the deep veins. Because if the deep veins are at fault and if the superficial veins are burnt, we are putting the patient to much more trouble, because where will be the venous outflow? Because we are, whatever DVT has done, we are adding to that. That causes, that is why I emphasize that laser is not the solution for all patients with venous ulcers. Dr. Matre from Vascular Society of India was very kind enough, and he got us to publish. So our opinion about what should a vascular surgeon, or what should basically a surgeon or a doctor is. So I strongly believe that you become what you believe. Ambition is the path of success, but persistence is the vehicle. We have to keep on doing it, because irrespective of whatever we do, we feel we are doing it, but it is not enough. So we keep on doing it, keep on telling the patients that move, walk, wear right compressions. That is very important. Thank you very much.
Thank you, Dr. Preeti, for your valuable insights. Next, I invite Dr. Balaji V to speak on angioplasty versus bypass decision conundrum.
Good morning, friends. At the outset, let me thank Dr. R.K. for his invite. And on behalf of the Vascular Society, I carry my appreciations and greetings to our society and the participants that you've been doing a wonderful job. And both of us share the same goal of saving the limb, and let's make our country amputation-free. Thank you. Our topic is angioplasty versus bypass decision conundrum. I think few people have talked about peripheral vascular disease as one of the non-healing reason for the ulcers in the leg. And as a vascular surgeon, we have plenty of experience and trying to do different kind of procedures to heal the ulcers and saving the limb. And let's talk about some bit of history or experience and what we should be doing. What we see in our experience is just tip of the iceberg. Here you can see it's a critical limb ischemia or gangrene. What we see in the clinical practice is very, very small percentage. Underneath lies a huge population of patients who are being uncared for, who has no access to the tertiary level healthcare to save the limbs. I think that is where India is faulting. I think it's our duty to go reach out to them, bring them up, and save the limbs. The Indian population, as it says, is, out of the 200 million population suffering from peripheral vascular disease in India, we know that about 40 to 50 million populations are suffering from peripheral vascular disease. You heard that recently that nearly 101 million population is suffering from diabetes. More than that, 150 million population are having pre-diabetic conditions, and imagine if they live longer, they are going to have a peripheral vascular disease and come back with associated complications. Interestingly, the peripheral vascular disease, when they present to you, they are not alone. They have a combination of other vascular diseases like carotid disease, cardiovascular disease. Also, recently we saw that a lot of patients with these three combinations have chronic kidney disease also. This is becoming a major issue here because when you're having a population of patients with already a major problem, they all have other comorbidities, i.e. cerebral vascular disease, carotid artery disease, coronary vascular disease, and CKD, which makes your treatment plan very, very difficult, and the results are going to be very poor. So you have to pick and choose your modality of therapy very, very carefully so that you get the right treatment for the right patient. Why do we actually care about this kind of population? Well, the next years, these patients, 30% of the populations, they're going to die. 27% of the patients are going to get worse. 20% of the patients will develop other complications like myocardial infarction, ACS, or stroke, and about 4% will land up in amputation. I'm talking about patients with unattended or undiagnosed PADs. And if you do a ABI, which you commonly do in your outpatient practice, that itself is going to tell you what kind of life period is going to have. It's almost like your fortune teller. You can tell them how long they're going to live. If you look at the ABI of 0.85, which is just asymptomatic peripheral vascular disease, he's going to live longer, and somebody is going to present with critical limb ischemia, he's going to die within the next 10 years or so. So they are a pretty sick group of patients. And now comes, what is the correct therapy? How do you choose? And what is the right modality of therapy for the patients? We have patients presenting with critical limb ischemia. We need to revascularize quickly and save the limb, heal the ulcers. You have two options. Either you have open surgical revascularization or endovascular therapy. So there has all been a dilemma and debate which one to choose. So what is the advantage and what are the downside of the open surgery? Traditionally, it always involved general anesthesia. I mean traditionally because olden times, we always tried only general anesthesia as the only modality of anesthesia for this patient. Now, with the advent of anesthetic technologies, ultrasound-guided nerve blocks, we do most of them under nerve blocks because we realize there are sick patients. This operation involved several days of stay in the hospital because they were large wounds. And although we had complications associated with the surgical wound because they are all diabetic patients, kidney disease patients, the wound didn't heal very well. So obviously that increased the mortality and morbidity. Here you see a long segment SFA occlusion, which is being treated by a classical great saphenous vein, femoropopliteal bypass. And the on-table angiogram shows pretty good. The outflow through the posterior tibial artery and is very good. And you can extend the length of the bypass. You can even go up to the leg, like tibials. Here you see a long segment bypass with anterior tibial arteries. And you can even go down to the foot, up to the plantar arteries. What about the endovascular? Again comes selection of patients, which kind of patients will be benefiting by this endovascular procedure. You have to choose the right vascular access. Is it a femoral access or a brachial access? Are you doing a balloon angioplasty alone, or are you going to combine with stenting? What kind of stent you're going to use? Is it a bare metal stent or a covered stent or drug-eluting stent? Or are you going to use a debulking methodologies for atheroma, like atherectomy devices? Or are you going to use thrombolysis if the patient has got a thrombus inside? So there are different options you have. Over a period of time, we saw that there is an increase. There's a steep increase in the usage of endovascular procedures. Here is one of the old charts from Charing Cross where you saw that surgery incidence is going down and the endovascular procedure is going up. What are the advantages? It's a percutaneous, no wound involved. It's an endoluminal surgery. The main goal is to treat the patient without any knife, wound sutures, etc. And of course, it translates into lowering the morbidity and mortality. But you again choose the patient according to is it a stenosis or is it a CTO, a total occlusion? Where is the lesion? What is the length of the lesion? What is the diameter of the vessel? And is it a tandem lesion, multiple lesions, etc. Depending on that, we can always try and choose what mode of therapy you can use. Because we have a lot of technological advances happening in the endovascular procedures, we have a wide array of catheters, guide wires, stents, balloons available to us so that wherever the lesions are, we can access them very easily. If you are going into the foot, ulcers, you need to decide which vessel you're going to access, which tibial vessel you're going to access, because I have the angiosome concept. Are you going to do a direct angiosome revascularization or indirect angiosome revascularization? These are some of the pictures. You can start either from the aorta to the iliacs. Here you can see the iliac artery being stented. And here you can see a long segment saphenous superficial femoral arteries being stented, almost like a jacket, extending from the origin of SFA up to the popliteal artery. And here you can see the tibials. Tibials also can be accessed up to the foot. You have small balloons from 2 mm onwards to access onto the plantar vessel. So you can treat any artery starting from the aorta to the foot. What is the downside? If you put in a stent, again, in the long term, they can cause stent fractures. So they are not without complication, fractures, occlusions, instant restenosis, etc. Here you have some data which show that on the long term, they do have some amount of occlusion rates, both with the balloon angioplasty and the stenting. And the latest trials are going on, which is best now with the angioplasty or stenting. And here you see the SFA, which is the best modality, balloon, stenting, bypass with either PTFE or a vein graft. They've all been covered. And you see that some of them with a long-term, long segment occlusion don't do very well on the long term with the angioplasty or stenting. So to find out which one is better, the endovascular or open surgery, it was a great attempt by Andrew Bradbury from Birmingham. About 15 years ago, he published this study, Basel 1. Basel 1 study showed that, in fact, both the group of patients did very well in the long term. But what happened was, in the short term, the cost of the surgery went up, mainly because of the stay in the ICU and because of the wound complications. There was a slightly increased mobility. And also, they did a long-term subset analysis. After 3 years, they found that they all did very well. Both of them did very well, as long as you chose the patient according to the type of lesions they had. Then came Basel 2, which is one of the latest publications. Again, on the long-term results, this is how they divided the patients. It's quite a large number of patients conducted within UK and the continent. And finally, they concluded that both of them did very well. So there's not much of difference between endovascular and open surgery. So what about the trials from the US, the global studies, the best CLI, the best endovascular versus best surgical therapy? Again, it is a very well randomized, large number of patients were included. As you can see here, there are 2 cohorts. First cohort was nearly 2,500 patients. The second cohort was 396. And finally, they concluded that if you have a right patient, right conduit, I think both the results are very good. So ladies and gentlemen, India is going to have a huge explosion of patients with peripheral vascular disease and critical ischemias. And if you have both endovascular surgery and surgical procedure in your armamentarium, and if you're the one who can choose the right one for the best for the patient, and if you get the best therapy, I think you can expect to salvage the limb with the long-term results. Thank you.
Navigating the clinical dilemma with such financing. Next, Dr. Lee will present on the no-option vascular patient tibial osteodistraction angiogenesis.
So this is I'm going to present a few cases on what is, if you've heard in the Chinese literature, the TTT, the transverse tibial transport. And we've renamed this to tibial osteodistraction angiogenesis because it makes more sense in English. And this one doesn't have any videos. You could run it as a PPT if you wanted. No. So if you click download, and it'll download as a PPT. It's a concept that sounded rather crazy to us, and we didn't believe the Chinese data. They've got over 2,000 patients now that they've done this on, where they osteotomize the tibia, and it results in revascularization to the extremity. And so we've already submitted an NIH grant to get some US data on this and see if our results are similar to theirs. And I'm going to present to you the first few cases that we've done. We've done 6 cases already. I think I have the last 2 I just did 2 weeks ago, so I'm not going to present those. But the ones that we have long enough follow-up on, where we've had rather surprising results. I know. That's yeah. So the main concept behind this is that when you create an osteotomy, or let's say you have a massive bone trauma, that it results in a cytokine response systemically, and that cytokine response, among other growth factors and other things that come out of that, can cause neovascularization. And surprisingly, even in the Chinese study, they found that creating the osteotomy on one side, on the tibia, led to improved perfusion on the contralateral side. So it's not only about the limb in which this is done, but we think that creating this cortical osteotomy and removing some of the cortex does expose the marrow to the soft tissue, especially in the proximal tibia, where the trifurcation is and the access to the perfusion. The procedure is pretty simple. It's done, so we're doing this right now in no-option vascular patients. These are patients where vascular surgery has evaluated them. There's no option for a bypass or further optimization by endovascular means. Some of these patients did receive an angioplasty before the procedure, but just weren't optimized. And so we thought that was probably the most ethical patient to start on the ones that were really had the option of below-the-knee amputation or something experimental and heroic. And of the 4 cases I'm going to show you, we had 3 where we achieved limb salvage, with almost a fully gangrenous wound, and one that went on to below-the-knee amputation from an episode of infection that led to sepsis, and he had to be put on pressors, which worsened his limb outcomes. There we go. Let's see if this works. All right, so the first case that we did, this was back in October, and this is a 53-year-old male presented for pain and odor of the foot worsening over 2 weeks, had an elevated white blood cell count, and met SIRS criteria. So our first step in any of these patients is immediate source control. We wanted to remove all of the infected source that was leading to the sepsis. And I want you to pay attention to that slide, the FLIR image, where it shows the temperature of the foot at 73.4 degrees. That's roughly room temperature. So, anytime you have, we call it a room temperature foot. Anytime you have a temperature of a foot that's the same temperature as the table, that's probably a really bad sign for an outcome. And so we did an open TMA. There was the condition of the tissue looked fairly good, but there was no active bleeding. It was a lot of venous oozing. So the non-invasive studies, he already had an AK on the other side. Non-invasive studies showed non-compressible vessels with monophasic flow, essentially. Went on to angiography, and angiogram showed a desert foot with no pedal arch. So looking at some of the Chinese literature, and they call it the character, we had somebody that translated this for us, but the Chinese character for this directly translates to transverse tibial transport. Doesn't make all the sense in English. That's why we renamed it to the tibial osteodistraction angiogenesis, which is essentially what we're accomplishing here. It's a simple procedure. In China, it's done with a monorail, and a window of cortex is cut from the proximal tibia, usually the proximal medial tibia, where there's minimal soft tissue overlying the bone, and then that bone window is distracted 1 millimeter a day for 10 days, and then put back in for 1 millimeter a day for 10 days. And then the external fixator is left on for various amounts of time. There's a lot of heterogeneity in the Chinese studies, just to allow for bone healing after that. But this also takes a significant amount of time to get that neovascularization. It's not something that's like a direct approach from a vascular surgeon where you'd have immediate response. So you have to really have appropriate patient selection, somebody that can wait that amount of time. And we're seeing it takes about 8 weeks total for us to see differences on the angiogram. So there was a meta-analysis of 2,000 cases reported from China. There's some from Italy. And there was a lot of heterogeneity in the methods of the corticotomy, the length of the corticotomy, the fixation was variable. The endpoints were also variable. Some looked at wound healing, some looked at limb salvage. But overall, more wounds healed and faster healing times and higher limb salvage rates in the TTT groups than in the control groups. So this is back to our patient here. This is a few days after now, where you can tell this is obviously a dysvascular foot. You wouldn't expect this to heal if you saw this and you had no other option. This goes to below the knee amputation pretty much all the time. So bring the patient in the operating room. We chose pretty much the largest study in China had a 5 centimeter by 2 centimeter cortical window. We chose that as our target. We come 5 centimeters distal from the tibial tuberosity. You're on the medial tibia. in that area, the tibia is really kind of like a triangle, and so you have three cortices, and you can access this area pretty easily. So expose the area, don't strip the periosteum. We put K-wires at the corners just so we can identify where our cuts are going to be, and then we go ahead and osteotomize 3 of the 4. You don't do all 4 because then the piece is just floating in there before you get your external fixation set up and your half pins. So we do 3 of the 4 sides of the window, and then we go ahead and attach the half pins and the first ring of the external fixator. We're using a circular external fixator. The main complication in the Chinese study was tibial fracture. It occurred after or during the treatment phase of this, and we thought that it was mostly due to the torsion on the tibia when the patient was walking, because patients are ambulatory during this, and so we chose an external fixator with a ring to completely offload that segment of the tibia. So you attach it to a motor, and you can see that this is a unicortical. You can see the cuts here, but there's a unicortical osteotomy. That's a rectangle 5 centimeters by 2 centimeters. The 2 half pins are in the center, and they're hooked up to a motor. And then we give it a little bit of a latency period of 7 to 10 days before we start distraction. And then there's right here you can see that there's a motor on the end of this that's connected to these half pins, and you can twist this in. It's got an arrow that says distraction. So you twist this. 1 click is 1/4 of a millimeter. So it needs to be turned 4 times a day. So every 6 hours, roughly, the patient turns it themselves, 1 click. And after they get to 10 days, they reverse and turn it the other way. So we usually have them come in at 10 days, take an X-ray, make sure that the piece has been distracted, and then start the reduction phase. So this is our, based on all the data, this was what we decided to come up with. So the first 7 days, just a latency period, we don't do anything. The days 8 through 17, we distract 1 millimeter a day. 18 through 27, compress 1 millimeter a day. And then the next couple of weeks allow for consolidation, and then we remove the external fixator. So this is about 6 weeks after. Did another debridement, resected a little bit of bone. There's nice bleeding there. Went ahead and applied fish skin and negative pressure with black foam. We reduced the negative pressure on the vac, and you can see here's one at maximal distraction. That's about 1 millimeter of distraction. You can kind of see right here. And I went too long with the half pins. I got into the other cortex, so I pointed that out just as a cautionary tale. I put the half pins when they went in too long, and on the field you tried to distract a little bit just to make sure that the piece is movable, and nothing was moving. So I thought my cuts weren't complete. So we went around and redid all the cuts, and it wasted about 30 minutes figuring out that I was through both cortices. So then this is the impressive part. This is the pre and the post angiogram. This was 8 weeks later, and you can see this angiogram is the pre-angiogram. There's barely anything here, and here's the post angiogram with a lot of new vascular structures. No named arteries really. This is just a lot of small arteries that have been formed. And then what we thought was really impressive as well was the temperature of the foot. Before was 73 degrees, now regular body temperature 97.2 degrees, and so that was our first case. Then when you would based on the condition of the foot at the first image, you would never expect this to get to this level of granulation tissue to be receptive of a split thickness skin graft. Here's a second case we did. A lot of these are midfoot amputations. The one at the end I'll show you that we failed on was a hallux amputation, but a lot of these are midfoot amputations just because of the infection and the ischemia, and you do have to have that time, like I said, to wait 8 weeks. If somebody can wait while this is occurring, they're a good candidate. And we don't do very aggressive debridements when they're really ischemic. Just as long as that tissue is not infected, we leave it alone until, roughly around the time when the frame is coming off, which is about 6 weeks. We'll go ahead and start doing more debridements and see what the quality of the tissue is. You can see this tissue's really improved all the way till we can get a split thickness skin graft. Here's the third case that we did. Similar thing. This is a more proximal midfoot amputation, and we can go on to grafting here. So this was the last. This was the one that we failed in, and we had a couple of issues in this case. First was the hallux was dry. This was a desert foot as well. It was dry. We thought we had enough time to wait, and so we tried it here. This patient. It's not from walking, because you can imagine when you're walking on this, the tibia is taking all the stress, and there shouldn't be any stress on the frame really, but the patient was, I think, just the way they were laying in bed were causing extra tangential pressure on the frame itself, and bent one of the wires, and we see this sometimes when we do Charcot foot surgery, but bent one of the wires here. And because the wire was bent proximally, it moved the window out of its correct position. So this cortical window had been moved distally, maybe 1 or 2 millimeters, but it was enough that we weren't able to get full reduction of this. So we had to take him back to the operating room and adjust the frame in order to get the cortical window back in place. Then he comes in with signs of sepsis, and I think you probably see this as we do after a direct approach with revascularization. When you have gangrene, a few days later, sometimes just from that revascularization, if they have dry gangrene, it can convert to infection because of the revascularization. And this guy, this is maybe 6 weeks later, has signs of sepsis, comes into the ER. So we went ahead and did a hallux amputation at that point. Sepsis was so bad that the blood pressure was low, had to be put on pressors, and so you can see the wound here becoming pretty necrotic almost immediately afterwards, and so we had to convert to an open TMA a couple of days later, and then just due to the patient was in the ICU for 3 or 4 weeks. With lots of complications and kidney failure, and had to convert over to a below-the-knee amputation after that. So we've done 2 more cases since then. About a couple of weeks ago, I did them, and so we're really excited about this as an option. It's not going to be an option for everybody, but it could be an option in cases really where you have no other option for vascular reconstruction. So I thank you very much for your hospitality. This is the last lecture of the time for me.
Thank you.
I always appreciate being here in India. I feel like I learn as much as I give, and that's a sign of a good conference. So thank you to the organizers as well. Yeah.
Thank you, Dr. Rajesh. To conclude this session, we move on to Dr. KVNN Santosh Murthy, who will speak on the power of near-infrared spectroscopy in wound healing and clinical decision-making. This talk is sponsored by Adivo Diagnostics.
A very good afternoon to everybody here, respected seniors of Diabeticfoot Society of India, and my dear colleagues. Now, I would like to have 10 minutes of your time because I'm sure I can add a good value addition in your clinical practice. So, I hope you're all with me. So, the first thing, before ever I start giving a talk on this, I would like to ask everyone of here, which is more important, blood or oxygen? What could be the answer? Other than both, you don't have the option. Is it blood or oxygen? Everyone says blood. Of course, vascular surgeons are here. They will say blood. But what I say is, 50 seconds, if I close your nose, you're going to die, even though you have 5 liters of blood in your body, right? Similarly, there are wounds which is having good vascularity, but still the wounds don't heal. What is happening? It is the oxygen which is lacking there. Now, the another thing I want to ask, since we know oxygen is important, since we know blood is very important, coming to blood, we have got so many investigations to find out whether the blood is present in the wound or not. Starting from capillary refilling, starting from your pinprick test, up to your MR angiograms, CT angiograms, everything. You have got many, many ways to detect blood in the wound is reaching or not, but can you detect if the oxygen is reaching into the wound or not? We have one test that is TCPO2, but then it also has its own limitations. But do we have any other way to detect blood oxygen into the wound? And when you don't know if the oxygen is actually reaching into the wound site or not, can you assure a proper wound healing? So what we see is different, and what we don't see is what we want to see, and that's where the spectrum of visibility comes into the picture. The power of near-infrared spectroscopy in wound healing. I hope everybody would have seen Lucy movie. Can you see this? With the small touch, she can even sense what is happening in the body, which is not visible to the naked eyes. That is infrared. And now this lady is giving a prescription to her saying that your kidneys are not functioning properly. You need to take this diet and do all these things. So this is just a thought provoking I just wanted to create. So understanding near infrared. Okay. Understanding near infrared, see beyond the wound, see what is not visible to the naked eyes. That's where near infrared comes into the picture. You have got many devices. You have got, I don't need to mention, most of the people have already started using these devices, imaging technologies. But none of the imaging technologies can actually detect if you have oxygen reaching to the wound site or not. So that's where the snapshot NIR comes into the picture. So what is this snapshot NIR doing? It is a portable imaging device that uses near-infrared technology with non-invasively measuring the content of oxygen, which is bound to the hemoglobin, below the surface of the tissues, which we can't see with our naked eyes. And yes, if you know if the oxygen is really delivering to the wound site, then you're pretty sure that your wounds are going to heal. No doubt about it. So definitely this is a big add-on in your practice. So this is how the device actually looks like. This is highly portable. You can just carry with your hands. And how it helps in your clinical decision making. It establishes a diagnosis. Okay, it formulates the treatment plan, and the monitor responds to the therapy and intervention. So what are you doing? Let it be a vascular procedure, let it be a plastic surgery, or let it be anything like HBOT or debridements, whatever you're doing. Can you be pretty sure that after your procedure, is the oxygen properly delivering to the wound site or not? So even now, with this thing, after the procedure, you can have a treatment plan change. How many imaging technologies can actually offer you this? So current and the future, the patient history examination, skill in patient identification is different. Now the two more important things which we need to add in our regular clinical practice is imaging technologies and AI intelligence. This is a small video showing how actually this works. So simple, just taking a laser light and all the images are in front of your screen within 20 seconds. You can actually see this, and you can understand the white, the yellowish background, bluish background is an indication that there is no oxygen into the wound. Oxygen in the wound looks like this, like how it is the blood. The visible light the visible naked eyes can see a wavelength of 500 to 600 nanomillimeters. And infrared is beyond 600, that is 700 up to 2500. So what exactly is happening? What is the science behind it? I'll come to that. The science behind is the oxygen which is present in the hemoglobin to the wound site. The NIR passes through the skin, and the NIR is not getting affected because of the water, because of the fats present in the skin. It is not getting absorbed. It is traveling. It is traveling with the wavelength. It can travel up to 3 to 4 centimeters below your skin. And it can detect whether the oxygen is actually present there or not. So how does the oxygen look like? Red, just like blood, to naked eyes. To the non-visible eyes, it's still red, oxygen. So how are going to be effective plans? You have got many ways, revascularization. I don't need to teach all that because already many lectures were taken on that. PRPs, you have got hyperbaric oxygens, you have got many things. And whenever you do something, just recheck with imaging whether the oxygen is actually getting delivered into the wound site or not. When there is low oxygen concentration, the reason may be because of inflammation, the reason may be because of infection or hypoxic damage to the tissues, or maybe because of hypermetabolic state also. That's where even the oxygen is present but is being utilized to the other parts of the body. So snapshot wound imaging, deoxygenated and oxygenated blood. So when you take a picture, it shows that if the percentage, it shows in percentage the amount of oxygen present in the wound. If it is less than 40%, it means you need to be concerned, you need to improve your treatment plans. Whether you have done the procedure, is the procedure effective or not, it will tell. If it is coming between 40 to 60, that's quite a good range. You can improve your quality of your wound management. You can still go with your VAC therapies or other things. You can go with your PRPs. You can, for all these stages, definitely without a vascular surgeon, things will not be possible. So your fat graftings, your PRPs, whatever you're doing at your center, if your therapies are improving, is the percentage in the wound is also improving. Percentage of oxygen into the wound is also improving. That means your protocols are right. Or if not, you need to change your protocols. So there are other views also, like hemoglobin views, and immediate bedside assessments also we can take care of. In this picture, you can clearly understand the concentration. If you can just zoom it a little, the concentration is only around 50 to 60% in the wound. The wound, below the wound, we don't know what is going to happen. And after the treatment, you see, the SgO2 is able to detect around 60 to 70%. So it means there is a slight improvement in the oxygenation. Coming to HBOT, these are certain clinical trials which were specially done for HBOT cases, where you can see how the series of photographs which can make you clearly understand that after HBOT, the concentration of oxygen in the wound site was properly delivered, and now you can be pretty sure you don't need to do any add-ons for your wound healing. You can be pretty sure because oxygen is life, and life is there in your wound, and your wound will gonna heal. This is some of the images like post-debridements. Post-debridements, are you sure that your debridement is effective enough that you don't need to go for another debridement? Every debridement, we don't even assure our patients that this debridement is enough. We keep on doing debridements. 1, 2, 3, 5, even 7, 8 times we keep on doing debridement, but we cannot assure whether again a debridement is actually required or not. But yes, with this imaging technology, we can be pretty sure that unnecessary debridements can be avoided. So these are post-debridement snapshots. You see the oxygen concentration is improving. Pressure injuries. In pressure injuries, you know there is a low tissue oxygen concentration in the wound bed. There is high deoxygenated hemoglobin and low oxygenated hemoglobin. So what is the first thing which we need to do? Improve the oxygen concentration, reduce the pressure. And how are we going to detect it? That which is the ideal way? For everything, HBOT is not the answer, right? Everybody is not having a HBOT. But with this, you can understand, even with the good offloading, this can improve because the surrounding tissue you can see is slight yellowish in color. That means there is around 50 to 60% of oxygen. And on the wound, there is less than 40% of oxygen. So if you just reduce the pressure of the surrounding areas, you can be pretty sure that there will be good delivery of oxygen into your wound site, instead of going for any harsh, tremendous procedures. So this is like dermal substitutes applications also. We can be pretty sure that your dermal substitutes are actually taken up or not. You can detect your skin graft is actually going to be giving you a good result or not. So everything can be detected with this. Vascular interventions, immediately post-vascular intervention, the next 24 hours, you can even detect whether there is an improvement. Not just the blood, it is the oxygen that is more important. So if your oxygen is delivering to the wound site, you can pretty sure you don't need to go for another procedures. So this is a series of imagings, like how after bilateral stenting was done, even after 28 days, the stent was viable, the wound was healing or not. Everything can be detected, not just a blindfold study. Everything is visible in front of your eyes within 20 seconds. Now, yes, there is conditions like people, you can ask, like when your foreigners are there, their skin tone is different, Indian skin tone is different, but still there is no effect of the melanin on the detecting of the oxygen levels. So this is at my center. This is how I'm explaining, showing the patient also post-HBOT, that how the oxygen concentration has improved in the wound site. And they are now more confident that my HBOT is actually going to work on them or not. Now, this is a very important thing because there is only one thing which is available in the market, that was TCPO2. And how better NIR can give you better results is because of the time factor, number one. The target area is only skin in TCPO2, which acts only on the partial pressure of the oxygen. And suppose the major issue which we see is your hands, if you're cold, it will not be able to detect properly. But here, it's not about the temperature which is going to be affected. So here, the muscle and subcutaneous tissue is only the target organs. And then you have a real-time monitoring. The depth is only up to 2 to 3 centimeters, where here on TCPO2, it's only 0.5. And definitely it's easy, portable, and the time taking is only 20 seconds in comparison with TCPO2, which take 20 minutes to give you a result, which you're not even pretty sure that what is going to be your plan of action, whether to go for amputation or not. So that is I think it's time up. So that's all from my end. Thank you. Thank you for patient listening.
Thank you, Dr. Murthy, for integrating technology into clinical strategy. Now we open the floor for the Q&A session.
This is a question to Dr. Srinivas. How to procure the maggots and how will you remove the maggots from the wounds after the therapy?
The procurement is easy, but in upcoming conferences, with the permission of DFSI seniors, we have to conduct workshops for your respective OT technicians. Without conducting workshops, the procurement should not be done. It is my gut feeling. And also, DFSI seniors are very much interested. Dr. V.B. Narayanamurthy, Dr. Keshavan have started this therapy. And we are supplying to them. But still, the hurdles are there. There are so many hurdles. I hope within 2 to 3 years, in the coming up conferences, we have to plan workshops for OT technicians under the guidance of DFSI surgeons. We have to be patient to receive the workshop protocols. And the removal of maggots if you don't remove also, after 72 hours, the life cycle says the complete satiety of the maggot should, after its complete eating, it should come out. In between, if you want to remove the maggots, just your simple suction apparatus is enough. You can remove very easily. Any other questions?
The next question is to Dr. Preeti. How long we can use flavonoids, treatment protocol for DVT, and how frequently we monitor INR?
Flavonoids are being used only maybe for a month or two. If whatever the venous pathology is corrected, then flavonoids will not have a role anymore. DVT protocol. No, the second question. So treatment protocol depends whether it's an acute DVT or a chronic DVT. Acute is which presents within 14 days. So we have very good machines, and we do mechanico-pharmacological thrombectomy. We remove the clots, we macerate the clots, we suck the clots, and we put in some thrombolytic agents locally in those veins. And in that way, we give better results. And the main aim for treating DVT is to decrease the post-thrombotic syndrome, the ulcers and pain and black discoloration. So if it is an acute DVT, we are very aggressive depending upon the presentation, what problem patient has, what is the etiology, whether it's a provoked, unprovoked DVT. And if it's a chronic DVT, again, we have to find out where it is. If it is only in the femoropopliteal segment, then we might not be able to do any intervention. But if it is up in the ilofemoral segment, so I had shown some slides where we do balloon angioplasty, stent, and create outflow for the vein. The reason why I'm talking is outflow for the vein is we, as vascular, we have arterial system and venous system. Arterial, we create an inline flow. We make sure that the blood reaches the organ. In venous pathology, we have an outflow. We have to make sure that the venous channels are patent. And the third question is we monitor the INR. Once we put them on any of the VKAs like acetylcholine and warfarin, we monitor them monthly basis if they have reached their therapeutic values.
The third question is to Dr. Shantosh Murthy. Clinically, the wound healing is good after therapy. And why to check for infrared after oxygen? Is it necessary?
Because can we assure that your wound is going to heal and not going to recur? I hope we cannot assure that. That's where if you have infrared technology and you can find out that oxygen concentration is very good into the tissues, you can be double sure that chances of recurrence is less. That's it. Thank you.
Thank you for the session, doctors. Now I request Dr. Lee to felicitate the faculty members. Dr. Srinivas Bia, Dr. Vinaya S., Dr. Balaji V., and Dr. K.V. N.N. Santosh Murthy. I request Dr. Lee to felicitate the chairperson, Dr. Rajesh Kannaya. Thank you, Lee. Now we move on to the session 3, which features a blend of international and Indian expertise with a focus on anesthesia, neurostimulation, and evolving therapies. The speakers on the dais, Maureen Bates, Dr. Vikas Kakkar, Dr. R. Shekhar, Dr. S. Thirinyana Sambandam, please come to the dais. Dr. V.S. Aarthi, Dr. Sudhir K. Jain. We now start the session with Maureen Bates presenting her views on managing diabetic foot presentation in UK.
Hello, everyone, again. Nice to see you all. I guess the trick is having the band at 6:30 in the evening rather than 11:30 at night time, because the dancing and the celebration happened early in the evening rather than late in the evening. Therefore, you're all here and not still in your bed. So congratulations to Rajesh on such a lovely, entertaining evening yesterday. So I'm going to talk about, I guess, managing foot presentations that we see in the UK, in London, where I work, but I guess it's similar to what you've just heard from Dr. Vinaya, that we met in 1996 in King's College Hospital, and I think we've both evolved our practices along with our MD teams. So our service has been continuing since 1981, and the aims of the multidisciplinary team service in those days, as it is now, is to provide the best possible care of the person with a diabetic foot, to research into the pathogenesis of the diabetic foot syndrome, and to teach healthcare professionals and patients about optimum healthcare, just like we're doing here now. And this is how, I guess, life will progress for our carers and also for our patients for optimal outcomes. So we can talk about the establishment of the Diabetic Foot Clinic and its underlying principles, the expanded role of podiatry within the multidisciplinary team service, as well as all the other expansive roles that we've been hearing throughout yesterday and then again today, and also the increasing roles within the multidisciplinary team. And I guess there seems to be a bit of an explosion going on with different types of treatments, different types of modalities, and different types of analyses. And I guess we're probably going to need artificial intelligence more than anything so that we can work out what we're supposed to do. So in view of the aggressive natural history that we're all aware of, we know that you know, the amount of patients that are coming through our doors, they're living longer, therefore they're becoming more frail and fragile, and there's more patients that are becoming ischemic. Certainly in the 1980s and the 1990s, we had a plethora of patients with neuropathic problems. Now we've got neuroischemic problems, we've got renal problems, and we've got critically ischemic foot problems as well. So our aim is to provide the rapid and open access of a focal area of clinical care, which is ideally a multidisciplinary team service to provide optimal outcomes for patients and therefore allow the staff to realise that we're achieving what we need to be achieving for our patients, and, I guess, satisfaction for ourselves and our values. And so within that focus, we have established a one-stop multidisciplinary team service. And what we mean by that is if a patient is attending our diabetes foot clinic, they're going to have blood tests and blood results on the same day. They'll have an X-ray on the same day. They'll have an assessment. And if they've got impalpable pedal pulses, then we'll be asking the vascular lab to do a vascular duplex scan. And then they'll be seeing either a diabetes doctor, an orthopedic surgeon, or a vascular surgeon, or perhaps all three, so that everything gets done on the one day and the patient is offered a diagnosis and a treatment plan. And we, from the very early 80s, there was a paper written in QG Med to highlight the benefits of working within the multidisciplinary team service. And you can see the amputations reduced quite significantly from the beginning, when the foot service started, and then in 1984. So you can see that, and you can also see that the numbers of, as I said, the variation between neuropathic presentations and ischemic presentations, but the picture would be very different now. And there's benefits to being a podiatrist working in King's College Hospital. Number one is I'm here in Chennai. And number two, I was also invited to number 10 Downing Street in London by the Prime Minister. But these were my predecessors, and some of you are probably familiar with Ali Foster. She came to India quite a lot, and she really put podiatry and diabetic foot care on the map throughout the world, I would say. So in the UK, India, America, and a lot of other places as well. So to highlight, I guess, what we actually do and to provide you with some structure, as a podiatrist, working within the multidisciplinary team, we've had to set up and move forward with our weekly timetable planning to, I guess, adhere to modern medicine. So way back in the 1980s, there were about 3 or 4 members of the multidisciplinary team service. Now we have over 30 members coming through our door. And as a podiatrist, I need to know which patient am I bringing to which service. So I will assess the patient with regard to their medical history, their foot history, do a neurological assessment, a vascular assessment, and then I will be either bringing the patients with neuropathic problems and deformities to our Monday clinic. We have a joint orthopedic clinic that's virtual. We also have what we call a huddle. We've got 30, 40, 50 or 60 patients coming through our clinic doors through the day. So we need to know what's happening with those patients. Well, some of them require procedures so that we're not wasting time of our vascular surgeons, our orthopedic surgeons, because time is precious for everyone. So if we're needing bone biopsies, flexor stenotomies, minor toe amputations, and the patient's got good blood supply, I'll be bringing them to our Monday clinic. If they've got peripheral vascular disease, I'll be bringing them to the Tuesday clinic. And then again, we have orthopedics on a Wednesday with a specialist Charcot clinic on a Wednesday afternoon. And Dr. Vaz down here does a painful neuropathy clinic as well. And then we do the same again on a Thursday with our vascular and plastics, and then an ulcer clinic in the afternoon. And then on a Friday, we have a renal MDT and an ulcer clinic. And throughout the whole week, we have emergency clinics running every day. That means that we don't have a waiting list, and then patients who need to come with an urgent foot problem can be seen within 24 hours. And if they're being seen within 24 hours, then hopefully you're going to arrest the problem and reduce your numbers of amputations. we've heard a little bit about total contact casting already. I won't go into any great detail. I think we've heard what the benefits are. What I'd like to highlight here is that we did 106 episodes of casting for neuropathic ulcers for Charcot osteoarthropathy with ulcers, because a lot of people ask you what the iatrogenic lesions are, what the complications, and are there any risks of DVTs? And the answers to all of those questions are not really, where we had less than 6% of minor cast-related tissue injuries, and these were not insurmountable, in which case the casts were allowed to continue. This is an innovation that was developed by my colleague Tim Gemott, who's also a podiatrist. So when we have patients who are moving into footwear, or maybe they live a long way, or perhaps they've got large wounds, or perhaps they've got cast phobias, this is a good option. It's like a Charcot restraining orthotic walker, which is instant. And this can be made within 30 to 45 minutes. The top part of the cast overlaps the back slab by at least an inch, and therefore we're not going to get the squelching of oedematous tissue down the medial and the lateral border of the cast. So that's been a great addition and a great function for patients in our clinic. And of course, we can make casts with windows. This person lived quite a long way away and therefore was unable to come to the foot clinic frequently. So the patient had a cast with the window. There was a cast tube overlying that, and you can see that the ulcer went down quite significantly and then went on to heal. And using modern technology again, we have a three-dimensional camera, so we can see that the treatment that we are providing to these patients with their size, the volume, is going down and down and down and down until it finally heals. And I'll show you a picture of that later. We've also been talking about total contact casting post-surgical correction, and you've heard a lot about that already. As I said yesterday, it's my and the podiatrist and the multidisciplinary team service to provide our surgical colleagues with assurance that patients can be looked after optimally pre, peri, and post-operatively for good outcomes. Now, this was a young gentleman who doesn't have diabetes, but had a road traffic accident and developed neuropathy. He had this transmetatarsal amputation that wasn't healing. So he did agree, finally, to go into a total contact cast, but he continued to be non-healing. And you can see from the X-ray that he still has two very sharp areas of the shaft of his metatarsal. And you can see from the weight-bearing X-ray that there's still some sharpness as well. Now, however, there's more extensive damage you can see from the MRI scan, and therefore, in the multidisciplinary team service with our orthopedics and our diabetologists, you're thinking, well, what should we do here? And the orthopedic surgeons were talking about involving the cuneiform and the base of the first metatarsal. And so I went back to the X-ray and said, why don't we try and do a little drop here, first of all, again, to see how that goes. The patient's a little bit more compliant now. He's agreed to go in casting. And you can see that he went on to heal and did very well with minimal invasive procedure rather than more. Okay. I've talked too much, I'm sorry. So another, I guess, advance is the bowler walker. This is like a caliper that's used so that it's got an iron bar that goes down the lateral border, the medial border, and it suspends the foot in air. and therefore will progress towards healing and patients weight-bearing more quickly post-surgery. And then what's also interesting, I think, is from the artificial intelligence that we heard about yesterday, it's very important to capture, I think, your imaging. This was old-fashioned. This is what we used to have. This is what we have now. And it allows us to see and track ulcer sizes, the volume, the depth, and it also allows us to determine whether. So this ulcer doesn't really look as if it's getting any bigger, but from the graph here, you can see that the volume's increasing, and that your practice has to change. Got very simple offloading of the toes. We're providing flexotenotomies, and all I wanted to say is that, you know, diabetic foot is a complex complication. Limb loss is inevitable, and most amputations can be prevented, and we can all reach for the sky when you're receiving good outcomes and working together as a team. Thank you. Sorry for taking up more time.
Good afternoon, everyone. Good afternoon, everyone. To begin, I want to thank Dr. Keswan and the organizing team for inviting me to present the role of hydrosurgery in diabetic foot debridement. So, what is hydrosurgery? The hydrosurgery is a water jet surgical method. In this, we use high pressure jet, which selectively removes the unwanted dead tissue, leaving all the live tissue intact. And we can use this technique now in wound debridements, burn treatment, plastic surgery, and some tumor removals also. So, what is the advantage of this over normal traditional surgery is that this procedure is minimally invasive. That is, we are creating less trauma to the surrounding tissue. And because of this, there is reduced inflammation and better wound recovery. As we are dealing with, we are removing only the necrotic tissue and the live tissue is still there. The moment we get a small amount of bleeding from the healthy tissue, we stop and there is reduced bleeding. And the jet just works like a blade, and there is very precise cutting between a non-viable and a viable tissue. So as this procedure can be managed in local anesthesia and can be as an OPD procedure, so it is cost effective also and causes less pain to the patient. So these are the places where we can use. It is very effective in cases of pressure sore management, diabetic foot ulcers, and burns. We can use just as like a tangential excision we can do with this, and we can do early skin grafting for better and early healing of the wounds. We can use it for wound bed preparations, for grafting and other procedures, and foreign body removals and all. So why we are using this hydrodissection is, we should understand what is the role of these and what is tissue over excision. See, whenever we use blade or any other method for excision, we have to remove a good amount of normal tissue to get the clearance. So when we are dealing with some vital structures, especially when we are using this in the web spaces or when there is neurovascular structures and all, so this may lead to injuries to the vital structures and which can lead to further damage to the distal organs and may lead to delayed healing or even no healing. So why debridement is necessary is, if we don't do debridement, there are high chances of infection. The infection can be bacterial, viral, parasitic, and to avoid these infections, we have to do proper procedure and we have to use the proper surgical techniques so that we get the best of the results. Because if we don't do proper debridement and manage the case at the first site, this is what we will get. So a normal wound which can be managed early can lead to a wet gangrene leading to sepsis, and we may lose the patient if we don't manage properly. So in case of diabetic foot ulcers, the most important thing is we have to prevent this. And we have to check at the first sign of when there is any callus or anything, we have to manage that time and to get a best results on this. Common hydrosurgical devices are, first is Versajet. So the beauty of this instrument is that it holds, cuts and sucks. So because of that jet, there is local vacuum and the tissue is just lifted up, and with the jet of this, it cuts the dead tissue, and along with it, there is suction. So the whole of the necrotic tissue and all goes into a separate container, and the wound is total clean, and there is minimal contamination of the surrounding tissue. Other device is Dermitome, which also works on a hydrosurgical procedure, and Aquamantis, which use radio frequency, especially for coagulation and all. These are the devices. So now I will share some cases which we have done with this hydrosurgery techniques. So this was the case of diabetic foot involving the great toe, and in the initial we can see that there are hardly chances that we may save it. We started with this Versajet. First we have to start with low settings, and see, it just holds the slough and cuts it, and slowly and slowly it will suck it. This is a quick procedure, and we can manage it in local or in blocks we can manage. So when we increase the settings, so it can easily cut tendons and even up to the cartilage if we go to the higher settings. The moment we get good bleeding from the edges and from the flow, see, this is before and after the debridement. This is another case of ulcer over the lateral malleus with thick scar. It makes a plane between the dead and the normal tissue. And we can just shave the margins also to make them start healing. This is another case of ulcer over the medial aspect of forefoot, and we can see there is, this is the biofilm, and the edges you can see, and with this, you can just clear off the biofilm, and with this, you can undermine the edges, and we can just shave the edges to make them start healing. This is case of diabetic foot involving the heel, and there was biofilm over the middle. Sorry. So there was slough which was going laterally deep into the tissue, and with the help of this instrument, we can go even about an inch inside. So we don't have to cut the skin and all, and we can selectively suck the necrotic tissue from inside the wound. This is especially used for these tunneling wounds and all. So we can remove till we get a healthy bleeding. We can just curate this biofilm and fresh the edges. This is another case. Initially, it looks like that we may lose part of the 3 toes, great and second toe. And the moment we start it, see, this just works like a blade, and it makes a plane. And this is on the first dressing. On another case of heel ulcer with necrosis. We can remove whole. This was a case of non-healing ulcer over TA region. There was thick biofilm. So with this, we were able to clear all the biofilm and make the margins. This is especially useful when we are dealing with when there are vital structures in the depth, so we can slowly clear whole of the biofilm necrotic tissue, saving all the vital structures. So this is another case in which initially it looked like that we may not be able to save. This instrument can go beautifully within the webs, and it can just clear the web spaces. And this was after debridement. in this first dressing. So like any other procedure, we have to do proper care of the patient, proper wound dressings, and we have to follow all the protocols for early recovery of the patient. To conclude, the hydrosurgery represents a cutting-edge approach to the wound management of offering precise cutting, reduced tissue damage, and improved wound healings. This technique enhances debridement efficiency, minimizes infection risk, and accelerates patient recovery. By integrating hydrosurgery into the modern wound care, we can significantly step forward in enhancing the patient safety, comfort, and clinical effectiveness. So I will take this opportunity to invite you all for our annual conference at Amritsar. So we promise you that you will have the best of the academics and rich cultural heritage of Amritsar, and especially Amritsari food. So one and all, I request everyone to join us for this annual conference in Amritsar, which is in the month of October. Thank you.
Thank you, Dr. Kakar, for shedding the light on precision debridement. Now we move on to Dr. R. Shekhar, who will share his views on advances of therapy in calcific disease.
Good afternoon, everyone. So over the next 15 minutes, I'll share with you advances in the management of calcific diseases. Calcium in the arteries as a vascular surgeon is a bugbear. We all know, and I'll discuss with you why it's a bugbear and why we don't like it. But to start, let me tell you that my talk will be in 3 parts. The first part, I'll tell you why calcium happens. In the second part, in a few slides, I'll tell you why the calcium needs to be removed. And in the third part, I'll tell you how we remove the calcium. So we all know that about 1/3 of diabetics will have arterial calcification, but the question is, why do diabetics get calcified arteries? There are many reasons. One is, of course, the hyperglycemia, and that disrupts the extracellular pyrophosphate metabolism, and pyrophosphate deficiency is supposed to be the potential mechanism. In fact, there's a lot of research going on how to sort out pyrophosphate deficiency and potentially prevent blood vessels from becoming calcific. There is, of course, insulin resistance, which leads to a calcium imbalance. There is inflammation. We all know that diabetes is associated with the chronic low-grade inflammation, and this contributes to the development of plaques, and then the plaques calcify. There is advanced glycation end products, and these AGEs can bind to receptors on the cells of blood vessels and promote inflammation, and that can cause structural changes, and those can cause calcification. There is abnormal lipid profile, and of course, we all know that when we have patients with CKD, how calcific their arteries are, and that is, of course, due to imbalances in calcium and phosphate, which leads to calcification. On a plain X-ray, we can see these. You can see these arteries, and even without a contrast, you can see how well they can be seen, and they lead to ischemic ulcers such as these. When we do an angiogram, you get lesions like this, and these can be quite a challenge, especially if you have something like this. As you can see, the entire the superficial femoral artery in the thigh is, it's multi-segmental disease with heavy calcium, and it's almost impossible to open these arteries out with the normal conventional techniques that were being used all this time. So the next part is why calcium really needs to be removed. The presence of calcium, as we know that when we have a blocked blood vessel, the trend is towards now opening them with balloons, sometimes stents. But because of the calcium, and very often it's circumferential, you need higher balloon inflation pressures. Means you need to inflate the balloon at a much higher atmosphere than in a compliant artery. And this can lead to dissections, meaning the artery might tear in places. And then your hand may be forced in putting in stents. despite the high balloon inflation pressure, the presence of calcium and excess plaque may limit the stent expansion. So you dissected an artery, you need to put in a stent, you put in a stent, but because the calcium is there, the stent doesn't expand properly. We are moving towards an era where we follow the policy of leaving nothing behind in the artery. So a stent is a metal, is a foreign body. So the trend is to using drug-coated balloons, what we call DCBs, the drug-coated balloons. But if you have calcium in the artery, the calcium actually interferes with the drug absorption, and the ability to remove calcium also improves the long-term results, as has been shown in the definitive AR studies. So in the third part of my talk, I will share with you two new, since it's advances, I won't show you the previous already existing older methods, but there are two new methods. One is shockwave lithotripsy. You all know lithotripsy as a concept for kidney stones and then bile duct stones, gallbladder stones. Now we have the same technology for the arterial calcification, and you see, just as a conventional balloon, you put in a balloon and you connect it to a machine, which you can see here, and it just goes bang, 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 bang. You can control the number of cycles. It's literally like an intravascular, it's called an IVL, intravascular ultrasound, lithotripsy, and you literally pulverize the artery, the calcium in the artery, and open it out. So this is one exciting thing which is being used more and more for diabetics with calcium in the blood vessel. It has its downsides in the sense that very often, you might land up having to expand the artery and putting in metal stents. But overall, it's an exciting thing, and you can see that what vessel I showed you previously, which was a multi-segmental with an IVL and a drug-coated balloon, you can get a beautifully patent vessel like this. So but sometimes you may have a different story. So take this example of this 69-year-old male from Tanzania. He had a large painful wound in the right leg for 4 months, hypertension, CV stroke. He had a hemiplegia with a motor of just 2/5. He's most of the time wheelchair bound, poorly controlled diabetes. On examination, there's a large wound. I'll show you in the next slide what the wound looked like, all around, circumferentially around his ankle and foot. And his primary issue was the pain that he was getting from that ulcer. He was wheelchair bound, so he's not walking much. And his distal pulses in the ankle were not palpable, obviously. Some of it because there was a wound there, so we couldn't examine it. And this was the initial picture. The general tendency of most people is to say, there's a wound, let us see what the arterial supply looks like. A Doppler sometimes is difficult with a wound like this. So you do a CT angio. Now, CT angio, the problem is that when there's calcium extensively in the arteries, especially in the below-knee blood vessels, very often it's difficult to interpret whether what you see white is the calcium or the contrast that you are seeing. So obviously, the next thing we think of is doing an angiogram, and you can see, as you can see in this picture, in the the second part of the the second part of here you can see the popliteal artery. This is the knee joint, and in the popliteal artery you can see a narrowing there. Now, what is also important to note is that there is a single vessel. Only the peroneal is the only vessel which is salvageable, and in the next angiogram, as you can see, here, this is the peroneal vessel. The antitibial is gone here. So it would be very tempting to actually, say as a surgeon to do a bypass between the popliteal artery and the antitibial using patient's own vein. But the problem here is that the wound is around the ankle. It's grossly infected. So you can't really have a surgical anastomosis in a diseased, ulcerated area, right? So what we tried to do is, you can see the lesion is quite calcified, so we tried and we do a plain balloon. But then the problem is that the circumferential calcium is there, and so there's a lot of recoil. As you can see there isn't much we achieve from a POBA or now that next trend then generally when it doesn't open with a balloon is to try a stent. Now generally as surgeons and people who follow guidelines strictly. Putting a stent here across the knee, a metal, is not a very good idea because metal ultimately is a foreign body, and if it occludes, the gateway to the leg is closed for good, and probably the leg is lost. See, here we have a new kind of technology which we are using more and more. This is an atherectomy device called the orbital atherectomy device. It's basically, I'll show you a brief video of that. There is a technology which actually wobbles inside the artery over a wire, and as it wobbles, it's like a sandpaper. It gradually shaves the surface of the calcium off, and it pulverizes it to very, very small particles so that there is not much of a risk of a distal embolization and choking up of the arteries ahead. So while it does so, it also maintains the continuous blood flow, and that is a great thing. And you can see there's a brief video. You can see if that is the plaque that you can see. Now this is the shaving head, and as it passes through, you can see that it literally shaves the whole area, so that at the end of it, you are left with a patent, nice artery, which you can either leave alone or probably use a drug-coated balloon to clean it off. So as you can see here, the orbital atherectomy cleans up everything. It's literally like a sandpapering of the surface, and the particles that are released are very, very small, so there isn't much of a risk of a distal trashing of the. So thereafter, once the vessel is open, we use a drug-coated balloon, and you can see here that what was like this, now we have achieved a fairly large lumen, and to magnify it, if you see it in a magnified, what was like this is now like this. So it's a very good lumen without using any metal, any foreign body, and thereafter, of course, the wound was looked after, debridement, dermis substitute, NPWT, and the patient went home with a healed. You might argue that it's a single vessel and how long will it remain patent, but the thing is that the patient is not going to walk. He's on a wheelchair, so he's not going to be a claudicant. What he suffers from is a painful wound, and essentially our goal is to treat the wound and give him a healed leg. So that was what we achieved. So that is in brief about I've just shared with you 2 new tools that are used to manage calcium, and more vascular surgeons are using this and will continue to use this in the years to come. Thank you.
Next, we move on to Dr. S. Thirinyana Sambandam, who will present on toe block and ankle block, easy and safe anesthesia for diabetic foot surgeries.
Good afternoon, everybody. And with the due respect to the chair, with the senior professors, and profuse thanks to Dr. Rajesh, let us jump into the topic straight away. Today's topic is ankle and toe block from me. And all of my surgical colleagues were interested in or focusing on arteries, whereas my focus will be on the nerves. So let us move on to the topic. So it's a very ankle block. Let's deal with the ankle block first. And it's a very reliable and a very highly effective regional block. And the success rate actually goes up to around 89 to 99% even with the landmark technique. And it is very simple and quick to perform, even though there are about 5 injections in minimum. But it doesn't require much of a gadgetry, and no special equipments are needed. And a wide range of surgeries can be performed below the malleolar levels, anything for that matter. And it can extend excellent post-op analgesia as well. And there is no distortion of anatomy because the injection is not given at the site of the surgery. And it can provide with the earliest possible ambulation, though there is some restriction to ambulation, even in ankle block. But there is, unlike the proximal blocks, there is no restriction because there is no foot drop, there's no proximal muscle weakness. And the patient can be discharged as an outpatient even before the block wears off. And when you take the ankle, the neuroanatomy, it has 5 nerves which innervate, and out of which 4 are distal branches from sciatic nerve, and 1, an odd man out, is a saphenous nerve from the posterior branch of the femoral, and it's a cutaneous branch. And out of these 5, 3 are superficial. They all start with S, superficial peroneal, sural, and saphenous. They are very superficial, and all these nerves have vascular associations. The superficial nerves are associated with the veins, and then the deep nerves are associated with the arteries. You can see the red dots are the arteries, and they are below the retinaculum. And then the superficial nerves, the saphenous, superficial peroneal, and the sural nerve are in the superficial compartment subcutaneously, except the superficial peroneal nerve, which does not have a vascular association, at least at this malleolar. So let us consider the innervation of the foot. If you check here, the top 3 pictures, it shows the sole of the foot, the innervation of the sole of the foot. Now it appears that almost the sole innervator of the foot, or the sole innervator of the sole rather, is the tibial nerve with its branches. Medial plantar, lateral plantar, and the calcaneal. Except for the medial arch. The arch of the foot is supplied by the saphenous, and the lateral border is supplied by the sural. And when it comes to the dorsum of the foot, predominantly it's supplied by the superficial peroneal nerve, except for the first web space, which is supplied by the deep peroneal nerve. And that's why it is called flip-flop nerve, because it actually innervates the area around the tongue of the sandal. And the lateral border again is supplied by the, or innervated by the sural nerve. It goes up to the lateral border of the little toe as well. And then the anteromedial part of the ankle is supplied by the saphenous nerve. And if you have to do a procedure in the four-toe or a forefoot, you need not even block the saphenous nerve. You can leave it out. Okay. So going to the preparation, you need a standard regional anesthesia kit with the choice of the local anesthetic, and then you get an informed consent. You should have an IV access and monitoring, minimum monitoring standards as like for any other anesthesia. And the most important thing is the last kit. And you need some sedation for the patient because it involves multiple injections. And the local anesthetic can be your own choice. And coming to the positioning, you just put a boulder or a bolster underneath the calf, and then the leg should hang freely outside so that you can go around, or you have an assistant, you can external rotate or internal rotate at the hip, or even you can flex at the knee in the figure of 4 so that you will have access on both sides of the foot. Let's consider one by one from the posteromedial aspect of the cross-section, and let's consider the tibial nerve because that is the largest nerve, and then the sole innervator of the sole. And it supplies almost all the muscles of the sole of the foot, except the extensor digitorum brevis, which is supplied by the deep peroneal nerve. And it is deeper to the flexor retinaculum. It is prudent to just know about the anatomy in the vicinity. And you all know the famous mnemonic, that is Tom, Dick, and Harry. You can see tibialis posterior, Tom, and the flexor digitorum longus, D, Dick, and then the artery and the nerve. And H for Harry, that is flexor hallucis longus, all deep to the flexor retinaculum here. Every other structure goes around the medial malleolus, takes the curvature, but the thing is, you got to know you can misjudge a tendon to a nerve. So if you have a doubt, you trace the tendon proximally, you'll end up in a muscle belly, whereas the nerve doesn't. And you should have it in mind, as always, that the artery and the nerve are very intimately related, and then they are together, always together. So if you can palpate the artery, and then it becomes very easy to block this nerve. You just got to palpate the posterior tibial artery at the lateral curve, and then you can go posterolaterally and inject after hitting the bone. This is the sonoanatomy, and again you can see the relationship of the tendons, the posterior, the digitorum, and then the artery and the nerve together. You can see at the corner here, this is the nerve, this is the artery. So it will be useful, particularly in a very difficult ankle like this with a lot of edema, and then where surface anatomy gets obscured. So you will have to rely on an ultrasound where you can pick up the artery and then proceed to give the block. Second is saphenous nerve block, which is very superficial, and the landmarks of the medial malleolus, and then the most prominent part, and it is in the subcutaneous plane. If you can palpate the external hallucis longest tendon, and then medially you can just place your local anesthetic, and it's very easy in supplies that we have already seen. Coming to deep peroneal block, and this is the second deep nerve, and this is the most important nerve again for the dorsum of the foot. And the thing is, everyone here will be knowing about our medical logo with the two snakes interwoven together, intimately interwoven together. Such is the intimate relationship between the anterior tibial nerve and the artery in the dorsum from the malleolar lever. It initially will be medial, then it crosses over the top, and then goes underneath, and then comes to the medial side. So that such is their intimacy. So if you can palpate the anterior tibial artery or the dorsalis pedis down at the mid-tarsal level, then it is easier to inject local anesthesia by the side of the artery, so you can easily block this now. And how to block this? You got to extenuate the great toe and make the external hallucis longus prominent, and then actually the nerve lies exactly lateral to the tendon, and there is a groove between the digitorum and then the external hallucis longus. If you can palpate the artery there, just adjacent to it, you can drop your needle, go hit the bone because it is deeper underneath the extensor retinaculum, and then just back off a little bit, and then deposit around 5 mils of local anesthetic. Then there goes a deep peroneal nerve is done. And then the superficial peroneal nerve, this is the only nerve which does not have a vascular association at the ankle level, and you can see just above the, it is above the extensor retinaculum, and then the landmarks will be the two malleoli. We will see how an intermalleolar line or a band, and then you can just deposit the local anesthetic between these two malleoli. Then you will cover both superficial peroneal nerve and the saphenous nerve together. And sural nerve, whenever we talk about sural nerve, what comes to our mind is that it is actually the most preferred nerve for nerve grafts, nerve conduction studies, nerve biopsies. Why? It is because of the most cutaneous location, most favorable location for the surgeons to harvest, easy to harvest, most cutaneous. And the same rule applies here even for blocking the nerve. The same thing because of its cutaneous presence, and then easy to just block it by giving a wheel of local anesthetic just behind the posterior aspect of the lateral malleolus. When it comes to the choice of anesthetic, then it depends on the duration that you need to. So mostly we use a 1:1 mix so that there is a faster onset, and then there's a prolonged action. 1:1 mix of lignocaine with levobupivacaine, that is what we use, 0.5%. And that can be, and then here This is an ankle block which I did 4 days back, and then you can, this is medial malleolus, posterior border, and then you mark the posterior aspect of the Achilles or the tip of the ankle, and midpoint corresponds to the place where you can actually palpate the posterior tibial artery. You can mark that, and then you can use the local anesthetic, and here you can be a little liberal, and here you can see the saphenous vein, and in between the saphenous vein and then the prominence of the medial malleolus will be the saphenous nerve. And go to the lateral malleolus, you mark the lateral malleolus, and then 1 finger breadth from there, you mark a sausage-shaped band connecting both the malleoli, and then if you're going to inject here, then in the subcutaneous plane, you can cover superficial peroneal, external halices, and then you mark the digitorum muscle there, and then in the groove, you will be able to palpate the dorsalis pedis, and then there you can block the deep peroneal, and this is the lateral malleolus, and again, posterior aspect till the tip of the ankle, and below that will be the sural nerve which crosses there. Then let us proceed with the actual block, do the cleaning with the alcohol solution, and then aseptic precautions are a must, because, and there is always a possibility that, if it is an infected wound, and there is a theoretical possibility that there is always a hematogenous spread, but we have to use a proximal location from the top of the infection for all these, but the basic aseptic precautions are to be taken, and we don't use betadine. We can use betadine, but we have to allow it for 3 minutes for it to settle down, and you can go with the posterior tibial nerve block first, and then go hit the bone. Yeah, now that you withdraw a bit and then deposit. Aspirate every now and then, because vascular access is a possibility, hematoma, and then you can inadvertently inject local anesthetic into the artery, which is going to be really dangerous. And now you raise a veil from the lateral malleolus. As I told you, you can see how nicely the veil is raised in between the band, and then go up to the other malleoli, so that superficial peroneal and saphenous both are done together. Then we will go into the deep peroneal now. Next. Yes, now go hit the bone, withdraw a bit, and then deposit. There, the deep peroneal is done. We saw all the landmarks, all described earlier. And then finally the sural nerve. Yeah, on the lateral malleolar side, behind the posterior aspect until the posterior aspect of the Achilles. So again, subcutaneously raise a veil. You can fan it around for a better take. Be sure that that ankle block is taking up properly. So yeah, we are done here, and then going to the toe block. Each digital nerve, each digit is supplied by 4 digital nerves, 2 on each side. The dorsal digital nerve, and then the plantar digital nerve, and then there are 3 blocks or 4 blocks or many blocks, but then the commonest that is used is the web space block. That is very patient friendly. It is single injection. You can see, you can go from the dorsum of the web space to until the plantar area surface, and then withdraw. While withdrawing, you can deposit the local anesthetic. That is simply done, that both sides it has to be done. It can be done either way. You can choose to give in the web space and then go in the both directions as well. When you come to the toe, there is one thing called flexure tendon sheath block. That is actually very good. It is a single injection, but you all know that our sole is bestowed with a lot of nerve endings, very painful. Even though it is a single injection, if that can be given, that is actually very good, very quick in onset. You got to just go at the middle of the plantar crease of the toe, right in the middle. You will hit the tendon, and then now in between the tendon, the local anesthetic which is given under pressure gyrates, or actually whoosh, it goes, and then just bathes it comes out at the interphalangeal level, bathes the digital nerves, and then the block is done. Here, a 3-sided digital block, you have to go from the medial side first, from the dorsal to the plantar, then turn the needle to the medial to lateral, and from the lateral there again dorsum to plantar. 3 sides it is done. 4-sided ring block is usually avoided because can be chances for ischemia, and complications can be infection, hematoma, nerve injury, residual paresthesia can persist, and then you have to give instructions to the patient to take care of the insensate extremity. And last but not the least, but the worst, it's the last. That is local anesthetic systemic toxicity. It can be very dangerous, ranging from simple symptoms like numbness, lightheadedness, numbness of the paresthesia around the mouth, muscular twitching, convulsions, and lignocaine causes more neurotoxicity, whereas bupivacaine causes more cardiotoxicity. And then how are you going to stop giving the injection? And then if there is a cardiac arrest, go to CPR. It is going to be refractory, and the magic portion is this. Everyone who does local anesthetic block, every other center should have this. And how is this helping? It is going to cause the excess local anesthetic molecules to shift away from the target tissue like cardiac tissue into a depot which is created by what you're giving as intralipid. That has to be given in boluses, like say 100 ml in 1 minute, 3 times repeated, and if it is refractory still, you can go up to 12 ml per kilo, and you have to have sufficient stock so that the target tissue, all the excess molecules move into the lipid zinc or the hydrophobic zinc, so that all the molecules come out, and then the normal metabolism is allowed to happen in the normal tissue so that your cardiac activity will return back. Thank you. Thank you for patiently.
Thank you, TNS sir. We welcome Aarti ma'am to talk on Gecko.
Good afternoon, one and all. I would first like to thank my mentor, Dr. Rajesh Kesavan, for giving me this opportunity to talk in front of you all. I'll be talking about Gecko, which is a neurostimulation device which we have been using in our regular clinical practice. This slide must have been seeing in the conference for the past 2 days, because it talks about the stages of wound healing. So we all know that the stages are hemostasis, inflammation, proliferation, and remodeling. So any wound which fails to progress through these stages will get stalled, and that is what we see in our common practice as chronic non-healing wounds. So most of these chronic wounds will be associated with either of these 4: ischemia, diabetes mellitus, venous stasis disease in the form of varicosities or deep venous disease, and pressure sores. So the local skin micro and macro circulation and tissue oxygenation are extremely vital for the wound to heal. And the product Gecko, it addresses this. So there was a previous session where Dr. Preeti had mentioned about the importance of calf muscle pump. So the calf muscle is referred to as the peripheral heart, and our patients, diabetic patients who undergo foot surgeries, are being advised not to walk. They are advised to strictly offload the limb, and most of them are in bed rest. So these patients will not be able to walk, and this device Gecko, it increases the blood flow, which is equivalent to 60% of that of walking. So they need not walk, but this will actually do the work for them. So this is a pictorial representation of Gecko. This is how it looks. It is similar to that of watch, and it is fairly around 10 to 15 grams, very much portable, very easy for the patient to wear. And it is a battery-powered disposable device and conforming to European standards. Let us look at the device up and close. So this has a plus and a minus symbol, which are the buttons to switch on or switch off the device. And also there are 11 stimulation modes. So by pressing on the plus button, you can increase the stimulation that you are giving to the nerve. It is usually placed on the common peroneal nerve at the head of the fibula, over the lateral aspect of the knee. So the arrow marking there, it shows. So the arrow marking here, it shows the location of placement. So that should be placed at the head of the fibula. And those LED markers, they will indicate the level of stimulus that is ongoing for the patient. So the other side of the watch, it has got positive and negative electrodes and also a container for the battery. And this will stick on to the patient's skin surface. So how does it actually work? So this watch, when it is placed at the level of the common peroneal nerve, it will stimulate the nerve, which in turn will activate the muscles, the lateral group as well as the anterior group of muscles. So that will result in contraction of the muscles. So the calf pump gets activated, your venous and arterial blood supply increases, thereby increasing the microcirculatory blood flow to the level of the wound. So these are the muscles which are activated when the common peroneal nerve is stimulated. So the anterior group of muscles, which is innervated by deep peroneal nerve, and the lateral group of muscles, which are innervated by the superficial peroneal nerve. So what actually happens? There is an increase in the venous blood flow, arterial blood flow, as well as microcirculatory flux. Microcirculatory flux is nothing but the movement of RBCs, which happens at the level of the wound. So when this device is applied, there is a 100% increase in the venous flow, 75% increase in the arterial volumetric flow, and 400% increase in the microcirculatory flux, which will definitely help in healing the wound. So this was initially developed for patients with venous ulcers who have a good amount of edema in their lower limb. So by increasing the venous outflow, this helps in bringing down the edema, so the discomfort comes down, and it also aids in wound healing. So this is used as an adjunct along with your standard of care, which is nothing but compression for venous ulcers. So this is a video which shows how the device works. So the watch is placed over the head of the fibula. So the common peroneal nerve gets activated. So you can see the twitching of the muscles. Thereby the calf muscle pump gets activated and the venous outflow increases. So this is a Doppler study of the femoral artery and the vein. This is at rest when the device is not applied. So the red color is a flow in the femoral artery and the blue is in the femoral vein. So you can see that the velocity and the volume increases when the device is applied. This is both US FDA approved as well as NICE approved. So there are few NICE guidelines which recommend this particular device for use in patients for preventing venous thromboembolism. So the NICE guidance, EMTG-19, it recommends gecko for people who are at high risk of venous thromboembolism and in whom pharmacological and mechanical methods are contraindicated. And the NICE guideline CG-92, it supports the use of gecko along with pharmacological prophylaxis in patients who had had major trauma or spinal surgeries, who had undergone major orthopedic procedures. This is a speckle imaging. So in the first 15 seconds, as you can see, the device is not switched on. And once the device is switched on, after 15 seconds, you can see that there is a 200% increase in the microcirculatory flux. There is a change in the color that you can observe. And at around 30 to 45 seconds, there is about 1000% increase in the microcirculatory flux. So the color change is very much visible now. So this was a study which was carried out in venous ulcer patients. So the results, they show that there is a 94% patient adherence, 42% of the wounds healed in 16 weeks when gecko was used along with compression therapy. 52% of the patients reported a reduction in pain because the edema comes down, and thereby there is a reduction in leg volume by 11.6%, and there was a reduction in nursing visits by about 33%. So who are the right patients? Patients who have been having non-healing ulcers, this can be tried. So, but you have to make sure that the patient doesn't have active DVT or active Charcot, and there should be cautionary use in patients with pacemakers, and the patient should be able to manage the device. The next are few studies of the gecko device. So this was in patients with venous leg ulcers, and they assessed how the arterial and venous velocity increased when the device was applied. So there were 14 patients with venous leg ulcers, And the velocity was measured at rest and after applying the Gecko device, both in lying down as well as in sitting position. And in both the positions, there was an increase in both the arterial as well as the venous velocity, which ideally helps in healing the wound. This was a study on microcirculatory flux and pulsatility in arterial leg ulcers. So there were 8 patients and the Gecko device was applied, and what they found was the microcirculatory flux as well as the pulsatility increased both in the wound edge as well as in the wound bed. This study was on multiple etiology wounds. There were 25 patients, and what they found out was 2 of them achieved complete reepithelialization in 8 weeks' time, and the mean wound area decreased from 24.4 to 16.8 centimeters square, and there was an improvement in granulation tissue as well. And most important of all, there was a pain reduction in 52% of the patients, which is significant, and all of them reported, 100% of them, they reported satisfaction following the use of Gecko. A few examples. This was a patient with a leg ulcer as well as an ulcer over the dorsum of the foot. So there was a lot of edema. So along with the standard of care, Gecko was used. And as you can see, there is a reduction in edema. In the second picture, this is the leg ulcer. There is a reduction in edema as well as there is improvement in granulation. And this was the dorsal wound, and that healed. At 12 weeks, it has started showing signs of healing. This was again in a patient with a leg ulcer, which was of mixed etiology, and the patient could not tolerate compression therapy, so Gecko was used as an adjunct therapy. And as you can see, that by week 58, there is 100% closure of the wound. This was a non-healing diabetic foot wound. Following surgery, there was a lot of edema. So once the device was used, we can see that the wound has epithelialized as well as the edema has come down. Thank you.
Now let's proceed to Q&A session. Sir, 1 minute, sir. Sudhir, sir. Sudhir, sir, please. Sorry, Sudhir, sir. To conclude this session, Dr. Sudhir K. Jain will express his experts in diabetic foot management, the forgotten factors.
So I was, I think, omitted at all, ultimately. It doesn't matter. So if I ask you, how is the mood now? I think must be heavy and happy. And it is heavy because a lot of academics has been already injected into your brain. So I'm here not to load too much of academics in you. My presentation will be something related, have some inputs of the humor and as well as some message. So what is the ultimate outcome if you have saved a foot, but we are celebrating posthumously in a patient who died of some other complications? Now I am here to describe some of the factors which are extra ulcer, but maybe with the patient or maybe with the atmosphere or the surroundings of the patient, which we usually neglect, which we usually don't consider in our cognition, management, and the outcome of the diabetic foot, but which are very important. If you consider those factors, the one of the factors is the gender. Because in female, we find mostly they are domestic worker, we can say domestic personalities, fashionable, high heel or Hawaii user, barefoot walker, more water contact time, softer sole and tissue, better vascularity, higher arch foot, narrow heel, and more lateral pressure. So this is what happens with the female sole. In case of male, they are mostly outdoor activities having formal official shoes they may be wearing, or maybe a barefoot walker who do a lot of paddy and harvesting work. They may have strenuous fit activities. They may be smoker, alcohol abuse, and maybe the having the harder sole with a larger fit and more contact time, and of course the thing. If you consider the age, which usually we forget, the younger in middle age, mostly they are physically active, family support may be better, and there is lesser or no comorbidities. So most of the time they recover faster. Elderly, which are having lesser physical activities with less family support, and may have also more of the comorbidities. So age has to be considered when you are planning a treatment in a diabetic patient. If you see the address, naturally the urban populations, they have got a better access to the healthcare systems, better transportation facilities, so they may have a little age over the population living in the rural areas. Education level, naturally, those who are educated, they are more having knowledge of the foot, or they are better, we can consider in their treatment that they listen to us early and they can follow our commands. But one problem with the educated people is the presence of Googleopathy. And this is usually been seen because they come with the treatment prescriptions to the doctor when they are approaching to a doctor for their foot problem. Occupations, certain occupations involving specific shoes use, prolonged standing or exposure to the hazards can increase the risk of foot injuries and ulcers. For example, the policeman, the army personnel, the farmer, the factory worker, and laborers. If you consider the religion, there are religions where the barefoot walking is a must when they visit a temple or any of the religion places. The saints of these communities, to which I belong also, Jain, they usually travel barefoot. There is a question of veg and non-veg. They may not consume a capsule which is gelatin made and which is a what I should say, a non-veg. And the fooding time is also a problem. If you ask somebody who is a Jain or something that you eat these medicines after 6, they may not take it at all. So most of the time, the TDS dose is converted to OD doses. So you have to consider those persons having this type of religious rituals. Nutritional status, physically fit persons, they recover fast, more chances of vigorous fit activities, and early recurrences may be there. Unfit persons, on the other hand, they take more recovery time. There are lesser chances of vigorous fit activities and may be quite heavy with amputation. Comorbidities, conservative versus radical, what to decide, what to take into considerations will depend upon the various comorbidities. Conservative versus surgical, we have to decide on the factors, what the comorbidity the patient has. Timing of surgical intervention is also decided by the comorbidities. Stage surgical intervention, drug adjustment, healing time, and rehabilitation time are the factors which you have to consider when we are treating a diabetic foot patients with various comorbidities. Well, life expectancy, I think, is the one which you must consider when we are providing a treatment to such patients. Lesser the expectancy, I think the lesser should be radical we should go for. Financial status is very important because individuals with limited financial resources may struggle to afford proper footwear, necessary medications, and specialized care, increasing the risk of complications. And the mediclaim backup is very important in our scenario in India. Not every person can afford SbO2 or any other the higher gadgets of the treatment protocols. Now this is self-explanatory. The Boston surgeon, after doing an amputation in a person which is healed totally, but he has converted that patient into a beggar. So such type of outcome, I think, doesn't going to help at all. Social and family support, strong social family support network can help patients cope with the challenges of the living with diabetes and its complications, including diabetic foot problems. The problem here is that most of the time when the patient comes to us, there's just fight between the husband and wife or wife and husband that it is only for you this has developed. So this blaming game has to be stopped. We have to consider that this is not he has not done it intentionally. It is because of so many, under some circumstances that he is forced to do or traumatize his foot, and that's why he is coming to us. Smoking is an alcohol, as we all know, that has got not good effects on the healing process. So that habit has to be taken into consideration. Access to the healthcare is very important. A person's living say 300 kilometers away from your center. Do you think that he will be visiting to you that frequently as you are supposed to ask him to come to your chamber or clinic? It is not possible. So this has to be taken into consideration, how best we can manage those patients which are living far away from your centers. Transportation facilities has to be taken into consideration when you are treating a diabetic foot patient. They won't come on their feet. They have to be shifted by some vehicles or something. So is it possible for them to come that frequently for the review? So I think the answer will be that you train one family members who will look after later on when the patient is being sent home, or you treat in such a way that your review schedule is given at a very longer durations, not frequently. Every second, every third day it is going to help you. Now, there are some patient-related factors that you must consider, that adherence to the medical advices, how much he is adhering to the medical advices. That is very important. And self-care behaviors. Patient may neglect himself because of so many reasons. It may not be intentional also. And same thing, what is his attitude towards his foot care and foot advices that you must consider when you are providing a prescription to the patient with foot problem. We may have different type of attitudes, positive attitude patients, negative attitude patients, and neutral attitude. So we have to cater our treatment according to their attitude level also. But we hardly, I think, see other than their foot when the patient reports to you. We are only concerned with the foot, nothing else. Like Arjun, you know that he is seeing to us that fish eyes. So that is not going to work in the diabetic foot management. We must consider expertise and facilities that we have, how much expert you are and what are the facilities you have in your centers has to be taken into considerations before providing a prescription and giving a treatment protocol or something to the patient. And of course, the most important thing is the personal and family choice. Your book may say it needs amputations. The patient is not at all ready for amputations. What you will do then? We can't force any treatment to such a patient. Either you have to make him understand, and even the family members' advices. So that has to be considered in our treatment protocol. Now, what should be the approach? Try to customize after narrating the pros and cons of every treatment that you have for a particular patient. It should be a team approach, timely referral, zero ego while referring a patient to another specialist, and use clinical skill before using battery of investigations. The approach should be like that. The discussion with an adult relative is very important. The first thing I think we can discuss with the relative of the attendant, who is of the patient, who is the responsible person there. Make him understand the present status, treatment options and plan, expected outcomes, possible complications, associated risk factors, the short and long term, and approximate cost of the treatment. They always ask, kitna kharcha hoga? How much will I have to spend? And never do a package deal with this type of patients. Discussion between the relative and patient should take place second. And the third, there should be a joint discussion between patient, relative, and the doctor. Clarify any doubts that they may have. And we should have a habit of talking. Talking. In my practice, I spend 70% time in talking, convincing, explaining everything. 30% time goes in doing the actual work. We should escalate the treatment. And the ultra technique may not be the best technique for that particular patient. Remember this thing. There is a humor that I am going to edit here, that those adamant patients who are not willing for, adamant relatives who are not willing for any sort of surgical intervention, or they don't know why you are seeing so much of serious, he's walking, he's having no pain. Then we have an idea that we bring the attendant of the patient to our OT, the dressing room, show him the actual picture. Okay, this is happening to you, your patient. And most of the time they become convinced. And at the time of convincing, they have a vasovagal attack. And at that time, you have to ask two of your robust OT attendants to hold him tight. And from this point onward, I think it will be, they will never create any hurdle in your treatment protocol. The things go so smoothly. I think Dr. Maureen, I think it will be quite different from your scenario. But we have to do all this type of, gimmicks and all these things to make the patient convinced. This is called fainting test, or what you call a sweating test. The approach, no warranty and guarantee to be given, keep hospital stay minimal, and repeated counseling and regular update is important. Do not blame and motivate the patient, rather train the relative and convert the IPD to OPD once the patient is stable. The protocol should that we should treat the patient, teach the patient, and learn out of this treatment. So the three questions that we have to answer: why it happened, why the ulcer has happened, how to be cured, and how to remain cured. So these three questions you must have in your brain before you are putting hand to this diabetic foot persons. Record keeping is very important. Repeated documentation, informed consent, use local language always. And audio-visual assistance is very important. Dear friends, mending a machine is very easy. You can change a part of a motorbike, but you can't change the foot with a person who is having so many comorbidities. So we must consider though we are called mechanical job, diabetic foot management, but we can't treat them like a mechanic. And the carry-home message remains that treat the whole of the patient, and not just the hole in the patient, that is the ulcer. Treat the whole of the patient and not just the hole in the patient. And we have a project called Chennai Spurs where we encourage the patient to touch the feet and learn a lot of information out of this. This is a project Chennai Spurs. And we must consider the extra pedal factors, extra ulcer factors before you prescribe anything to the patient. I think this is what is called Nandri. Thank you. And I welcome you all to Assam. I hope that in coming future, I will be able to host one DFSI with our Sir Ball, my mentor. And I think I should give at least myself a big round of applause to RK for this wonderful conference that I have seen. Thank you very much. Thank you.
Thank you, Doctor, for the wonderful take-home message.
At the outset, I congratulate all the speakers for their excellent presentation. I request the audience to give a big round of applause to all the speakers. Coming to the questions, first to Dr. Vikas Kakkar. How can we reduce the aerosolization during hydrosuction?
Thank you, sir. That's a very good question. So to reduce this, we have to start with the minimal settings. So maximum tissue which is soft will be easily sucked on minimal 2-3 settings. And during that, the pressure is low and there is less aerosolization of bacteria in the tissue. So the high settings where we have high pressure should be used when we are dealing with some tough structures like tendons or cartilage-like. And by using the higher settings only during those times, we can reduce the times of aerosolation. Not to forget, we have to put all the sterilization measures, mask, glasses, while doing this procedure, so that there is minimal contamination or minimal aerosolization. Thank you.
Next question to Dr. TNS. If given a choice to you, do you prefer ultrasound-guided ankle block or a blind method?
If the gadgets are there, definitely an ultrasound-guided block, because it will be like your take of the block will be 100%. At least for the deeper nerves, it is better to block with the ultrasound guidance if it is there. But in an outpatient, in a setting, still a landmark guided block is good enough so that the take is really nearly 98-99% if it is done properly. But only when the patient is having obscure landmarks in a very bad infected ankle with a lot of tissue edema or in a trauma, that'd be difficult, landmark-based block. Otherwise, if it is a skinny foot or even a normal foot, a landmark-guided block is good enough, but if ultrasound is there, that's great. And then with the ultrasound, we will be able to block perfectly, at least the posterior tibial and the deep peroneal. The rest of the superficial blocks can be done by the landmark blocks.
The next question to same Dr. TNS. And in your presentation, you were saying that lignocaine is short-acting as well as it causes many reactions than other medications. And what are the different combinations used in both in ankle block as well as in toe block?
Yeah, so there is one thing, use of epinephrine in the mixture. As far as possible, it is better to avoid because you are not sure about the vascularity either in a traumatic foot or a diabetic foot, and then still it is a proximal block. We have to consider that as a proximal block. There is a controversy, but it is better to avoid. We don't use mixtures containing epinephrine. Toe block, a strict no. Ankle block, yes, but still you can avoid. By giving a mixture, you can reduce the onset time. We use lignocaine to increase the onset time. Like say, in an outpatient, patient is waiting, and then this is usually done for outpatient procedures mostly. So we use a mixture. If at all you want a prolonged block for a post-op analgesia, then we use a lesser percentage of even ropivacaine or bupivacaine, levobupivacaine, which is supposed to be less cardiotoxic. And then the block can go with additions of dexmedetomidine and with little dexamethasone if there is no contraindication. The block can be solid and it can go up to even 15-20 hours.
Okay. Thank you so much, Dr. N.S. The next question is to Dr. Shekhar. How much time does it take for the intravascular lithotripsy in a single vessel, and what is the cost of it?
Well, the time is based on the length of the lesion, but generally these gadgets are good for short segment calcification. So on an average, it would take about 20 minutes to do either an atherectomy or the actual procedure time for an atherectomy or an IVL. Presently, both of them cost close to about 3 lakhs. But a lot of these costly procedures are done in our hospital and as also in other hospitals in Mumbai under various schemes. So we do a lot of BPL patients as well. So the lower economic status also gets access to these.
You are saying that insurance covers it?
Yeah, those who have insurance, well and good. If they don't have insurance, then there are certain, every hospital has to reserve about 15% beds for the lower socioeconomic. So under those schemes, many of our patients get these high-tech procedures done.
Thank you, sir. The next question to Dr. Aarti. What are the adverse reactions or complications you have seen using GECO therapy?
So far, we haven't seen any, since it is just a topical application of a device which is going to stimulate the nerve. The only technical difficulty that is possible is some patients have a lot of edema, so it might be difficult to find out the head of the fibula and place the device correctly. No complications so far.
Thank you. If there are no questions, we'll wind up the session. Thank you so much. Thank you all.
Sir, thank you, doctors. I request Dr. Shivakumar to felicitate the speakers. Dr. Vikas Kakkar. Dr. R. Shekhar. Dr. Thirinyana Sambandam. Dr. Sudhir K. Jain. Dr. Aarti.
Next, we move on to the last session of the day. We welcome the delegates on the dais. Dr. T.S. Mangalnathan, Dr. Rajesh Kesavan, Ms. Maureen Bates, Dr. Nagarajan, Dr. Prashant Vas, Dr. Santosh Murthy, Dr. Sheila Sasikumar, we welcome now Dr. T.S. Mangalnathan to talk on offloading in low-income settings.
Shivaya. Good afternoon to everybody. I will just tell something about my institute. There are many persons here who has done fellowship. Dr. Bal is the pioneer in starting podiatry, along with Johnny Kannambali. And Narendra Verma sir, who passed away, was my main teacher. Bal sir was giving me a lot of information. Online also sir comes now as a motivation. So I'm a senior consultant now, working along with a team of endocrinologists, lot of endocrinologists. Many fellows have passed out from here, from the Dr. Rajesh Kesavan. I congratulate you for this very good organization and give me opportunity also to talk. So the topic is actually very difficult actually, because majority of the Indians population is low socioeconomic group. And we are only giving this knowledge. Basically, it's mainly now here, all the people who have accumulated here is mainly high socioeconomic group because we are doctors. So this knowledge has to be transferred to a majority of Indians. That's the main talk here. And offloading techniques, intrinsic or extrinsic, is basically the same, because whether you are rich or poor, the health should go for everybody. And we know that offloading reduces pressure on ulcer areas. If you don't offload properly, it can end up in amputations. Like Dr. Balsar used to tell that diabetic foot walks to death because there is a severe neuropathy and they don't have any sensation. And how can we translate this to poor people? We have to conduct medical camps, awareness programs, like that. So if you offload the persons properly, then the wound will definitely heal. We saw so many talks about offloading in detail. We saw that. Along with offloading, actually initially I didn't know what was offloading in the beginning, many years back. What is the term offloading? It's actually non-weight bearing of the body on the plantar aspect of the foot. So, along with offloading, all the other factors are also important in diabetic foot wound healing. And like the previous speaker told, it's not just the foot. The whole patient has to be taken care of, like adequate blood flow, aggressive management of infections, metabolic control. We have a good team of endocrinologists headed by Dr. Harish Kumar. And regular monitored dressings. All dressings should be monitored by the doctors at least 3 days, or according to the wounds, frequently, how the wound. So this should be in between seen by the doctors. Nutritional therapy is also very important because they will have protein loss. Most of the time, protein is insufficient. Now, mobilization is also very important because if you tell the patient to sit in one place, they will become depressed. So physical medicine rehabilitation, we have a good team in Amrita. So low socioeconomic group, 1.46 billion is India's population. And out of that, 1.26 billion Indians are low socioeconomic group. What does it mean? It means 86.3% of Indians belong to low socioeconomic group. And how are we going to address these people? It's really a big burden. They have a lot of problem, no? Poor people, they cannot earn even 200 rupees per day. If you go to, so that's why all of us has to take and thought process that how we can help the people in rural areas. Like telemedicine is one thing. We can reach the telemedicine centers, tie up with the government organizations. This low socioeconomic group do not have money and they have to go for their basic work, manual labor, they have to find their work and they don't have any proper education. Forget about education, they may not have food, clothing, shelter, the basic necessities of life, Indians. So we are a developing country, but according to the statistics which I showed, we are actually a poor country. High cost of standard treatment is required for this diabetic foot management, economic loss. Sometimes they will lose the job also if they amputate the limb. Limited access to healthcare and resources, this low socioeconomic. So actually, although we are all good, we all came here together, a lot of people in Indians are awaiting, as told by the vascular surgeon also, that they are awaiting a lot of this one, diabetic foot management, all the details, we have to take care of them. So it basically affects the low socioeconomic group. This in Trivandrum Medical College, Dr. Hariharan Sheshadri et al. Shows this. This article is available in the PubMed. Says that 68.8% of participants in diabetic foot ulcer patients face catastrophic health expenditure. It's very shocking to me when I read this, that they spend 600 rupees to 11,83,250 rupees for diabetic foot ulcer management per annum. It's very big range, very big amount. Spends more than 10% of families' annual income on diabetic foot ulcer management. And how can India meet this? We have to tie up with the government sectors, primary health center, secondary health care, and tertiary. These are some of the wounds which are awaiting the first one, which I have done this one, the first one, we have done a bone curettage of the big toe, and then what we can give to the people commonly we give is posterior slab and felt offloading. These are the two things: felt material, felt offloading, and posterior slab. And we can mobilize them with a walker. These are the common things we do at Amrita. The second one, the second wound we have used, we have removed the big toe, second toe, elderly man, and we have used antibiotic beads treatment also. Him also we give the posterior slab after the regular dressings. Third person also, to create that midfoot amputated stump, of course he had to be offloaded, as well as after that we did a skin grafting. The fourth figure actually shows the big toe amputation. Again, he has to be offloaded. Most of them we give posterior slab. We cannot give a total contact cast in this case, although that's a gold standard. And if they don't offload, what is going to happen is this. What is going to happen is the infections can travel upwards, cause a necrotizing fasciitis, can end up in sepsis, and go for a major amputation. Heel ulcer also. The heel ulcer. Also, all ulcers needs offloading. So how can we translate this into the low socioeconomic group? This is a posterior slab, very easy to give. This is 600 to 900 rupees. Even that is not affordable in the lower section of our society. So we need to conduct camps, awareness programs, very important, every individual in this conference and has to take some initiative to tie up with NGOs as well as for offloading. This is the felt offloading commonly used. It's a callus ulcer, and then around that we have stuck the felt, and then we will give a regular dressings. These are the two things, felt offloading, posterior slab, as well as a walker or a stick. Physiotherapist will come and give, mobilize them. The other one is to, before the last figure which appeared now is before giving a total contact cast. We have covered the bony prominences with the felt, and then after that, we will be giving the total contact cast. There is a first MTP region, there's a clean ulcer, which should not be infected. I am very afraid when we give a total contact cast, because whether the ulcer will get infected, we cannot see them. After a few weeks only, we can open it. So generally, I give posterior slab, felt offloading, mobilize with walker. Like that, only with the help of the physiotherapist. Again, this is only felt offloading. And after giving a total contact cast, we have applied the two blue, the pads you can see, so that he can slowly mobilize to the washroom and to have food, etc. Then assistive devices are there. There are crutches as well as walker. All these yesterday and all elaborate discussions were there. So these things are the common things which we can give to all of this, especially to the rural areas. The government can provide with low cost all these things, and we have to tie up with the government because the population we are going to face is a vast population, the low socioeconomic. These are the common things. This will cost total contact cost. It will cost around. If you are using a fiberglass, it will cost around 600, 900 rupees and all for 3 of them, and then wrap it around. Again, to protect that, roll-on TCC also another cost. Then a air cast boot, another 12,000 rupees or 10,000 rupees. These are not. So why I am telling is, what we can give to the affordable group should go to the other group also. And as Indians, we have a lot of them awaiting all the complications. This is the posterior ortho wedge, where if there is a heel ulcer, you can modify the footwear like this. If there is a forefoot ulcer, you can modify the anterior ortho wedge shoes, where there is outsole is missing, and you can see that's a heel offloading devices. If there is a modified mid-tarsal amputation as well as the 2 toes amputation, then you can create an insole, plaster suit, like that we can make. So these are the insole cutouts of offloading. This also you can use. Even this is 2,000 rupees they will charge, 1,500 rupees they will charge. So orthotist, actually it's no good orthotist is not easily available actually. And it is taking a lot of money also. So take home message is what? Offloading is crucial. Yeah? And then it is the cornerstone of diabetic foot ulcer healing. Although so many other factors are there, the whole patient is there, so many other factors also we told. Because of what? Because the awareness will be less, complaints will be less, total contact cost is a gold standard. Affordability is the main problem for the low socioeconomic group. All this what we give to the affordable group should be also gradually come to the low socioeconomic group. Among that, what I feel is that we can give awareness programs, then we can conduct mobile clinics. Mobile clinics can be done. Telemedicine conference can be taken. So once a month itself, every one of us should go out into the rural areas, create awareness how to protect the feet, how to, if there's a small ulcer, about diabetic awareness, symptoms of diabetes. And even if there's a small ulcer, 85% of amputation starts with a small ulcer. That's what they say. So when there's a small ulcer, how to take care of it. Like Dr. Jesse was telling how to debride and all. So this even, the breach in the skin is the beginning of the diabetic foot. Breach in the skin is the beginning of diabetic foot. So a multidisciplinary approach is required. In the disciplinary approach, patient is the main person. There are endocrinologists, physicians, podiatrists, orthotists. Everybody has to reach the poor section of the society by taking our time and in alliance with the government as well as with the non-government organizations. Amma does a lot of work reaching out to the poor, and we conduct a lot of programs in diabetes and other areas also, awareness programs. And prevention is better than cure. So pre-ulcerative lesions like calluses, these things can be very easily addressed and make the patient aware with compassion. Otherwise, they will not listen. They don't have education. They don't have food, clothing, shelter. How many percent? 90% of Indians. 86.6% of Indians. Basic necessities, food, clothing, shelter, medical care, as well as these things are not available for the Indians. So we have to work. This knowledge, what we get from these sections, has to be translated to the lower socioeconomic group. Thank you. This is a teamwork. You can see how the birds are flying in the sky, vast sky. It's a teamwork. They want to go against the resistance of the air. Similarly, we have to go against the diabetes and its complications. One of the bad complications, diabetic foot. Of course, there is kidney, CVS, cardiovascular, all other complications. So diabetes is a killer disease. Okay, thank you.
Thank you, Dr. Mangalanand, sir. I welcome Dr. Rajesh Kesavan, sir, to felicitate Dr. T.S. Mangal, sir. I welcome Dr. R.K. sir to give a speech on advantages on single-use negative pressure wound therapy.
Good afternoon, everybody. Before the wound eats the foot and the patient, you need to intervene. So that is what is conveyed by this photograph. So you need to not just your common sense and the way you and your clinical acumen, you also need advanced devices, advanced technology to manage most of these wounds so that you get a very good outcome for these patients. So this is one such device, a single negative pressure therapy device. So I'll be talking on this in this lecture. Most of you will be aware of the Sindbad classification. So this is the classification which is proposed by the International Working Group of Diabetic Foot for classifying diabetic foot wounds. So it looks at the site, presence of ischemia, neuropathy, whether it is infected, the size of the wound, and the depth of the wound. And where the Sindbad score is more than 3, the cost of managing becomes higher, the amputation rates go up, mortality rate also goes up, and healing also decreases. So time is so important. Earlier, the patient is seen by the doctor. Earlier, you are able to intervene. Better will be the results. Time also stands for the time concept, which looks at tissue viability, presence of infection. I implies presence of infection. M, the amount of moisture which is important. As we had discussed earlier, moist wound healing is the most important paradigm in wound healing. And E is edge of the wound, whether the edge is advancing or it is a stalled wound. And when you look at edge, if the wound edge is not moving forward, if the wound is not decreasing in size, if the percentage area reduction of the wound is not as per the requirements, you require the wound to decrease in size at least by 40%. The wound area reduction should be at least 40% in a month's time, in 4 weeks' time. Only those wounds would heal in 12 weeks' time. So if that is not happening, then you need to go for advanced therapies. So some of the therapies which have been recommended include you have negative pressure wound therapy, you have growth factor ointments, various advanced dressing materials, hyperbaric oxygen therapy. So one of the modalities is single-use negative pressure wound therapy. Negative pressure wound therapy has been in vogue for a pretty long time, and as per the guidelines, IWGDF guidelines also, it is recommended to be used on post-debridement wounds in diabetic foot ulcers. So a number of studies have shown that more patients achieve complete wound closure with NPWT. There is fewer secondary amputations on patients who are on NPWT, and the number of dressings also come down, and the wound closes much faster when NPWT is used compared to other modalities. Can you just reduce the intensity of that light? I'm not able to see. So NPWT helps in treating hard to heal wounds. Number of studies have shown that NPWT kickstarts a stalled wound. So wound which stops decreasing in size, we're putting them on the single negative pressure wound therapy, helps in rejuvenating the wound and helps in restarting the healing of these particular wounds. So this was one wound which was not showing much improvement. So started on single negative pressure wound therapy. Within about 4 weeks' time, the wound had achieved complete wound closure. So when you look at the key drivers of wound care, you need to look at preventing complications. You need to prevent the wound from getting infected, from going on to an amputation level. You need to also reduce the number of dressing changes so that the patient need not go to the hospital, or you need not get the nursing care. So the stress on the providers also comes down. And you also want the healing time to be reduced so that the patient is back on his feet and back to work. So let me just go through a few slides on single negative pressure wound therapy. When you look at negative pressure wound therapy, it is used in 2 different scenarios. One, it is used over incisions, closed surgical incision management. Second is managing chronic wounds. And as far as chronic wounds are concerned, when you use a single negative pressure wound therapy device, it protects the wound from external contamination, it allows moist wound healing, and very important part is it decreases edema and congestion, not just in the wound area, but even in the surrounding areas of the wound, and thereby helps in improving the blood supply of these wounds. So treatment goals as far as SNPWT is, you need to manage and protect the wound. You need to get the wound ready for closure. So it's a big wound, you need to get granulation cover pretty soon so that you can proceed to the next stage. You can decide on going for either a split thickness skin graft or going for a flap so that the wound tends to close. And earlier the wound closes, the patient is comfortable. And because edema is reduced, and because pain also comes down, the patient is much more comfortable when you are using this. And because wound heals much more faster, you're also helping in reducing costs for therapy for these patients. So when you look at the indications of single-use negative pressure wound therapy, recommended in closed surgical incisions, chronic as well as acute wounds, traumatic wounds, subacute and dehisced wounds, wounds where there is a lot of exudate coming in, partial thickness burns, etc. So you have a dressing which is put onto the wound, and you have a port, and this has a filter also attached, and this gets connected to the device. It has only one switch, so ease of operation is there. And it also has an indicator to say whether it is on or off. And again, if there is a leak, again you have an indicator which shows that there is leak, so that you can address that leak and the negative pressure can start functioning again. The dressing which is used in this negative pressure device is a special dressing which has something called as an airlock technology. So what happens is it has a semi-rigid honeycomb structure. So this is that semi-rigid honeycomb structure. It doesn't get compressed even with the compression dressing is applied over this. And this tends to reduce edema and pressure from not just the incision site or wound site, but the whole area where the dressing is applied. And the adhesive layer, it is a silicone layer which is the wound contact layer. Silicone layer, the good thing about that is it sticks to normal skin, but it does not stick to the wound. So whenever you change dressing, it does not affect the granulation tissue which is already formed. And on top of it, you have a super absorbent layer. So whatever fluid comes up is converted into a gel and it gets retained in that super absorbent layer. And the top layer prevents any external contamination affecting that wound and also helps in evaporation of whatever fluid is already caught in the super absorbent gel layer. This was an RCT which got published in the Wound Repair and Regeneration. It was a prospective randomized controlled trial on the efficacy of single-use negative pressure wound therapy compared to the traditional negative pressure wound therapy in treatment of chronic ulcers of the lower extremities. Robert Krishna was the principal investigator in this study. Here they looked at adults with lower extremity ulcers which were not healing for at least 4 weeks. So they looked at venous leg ulcers of size between 2 to 36 centimeters and also diabetic foot ulcers of size between 0.5 to 10 centimeters. So about 161 patients were enrolled in that study. 60 were diabetic foot ulcers and 104 were venous leg ulcers. 80 patients were put on the PICO, single negative pressure wound therapy device, and 81 patients in the traditional negative pressure wound therapy device. So patients whose wounds did not reduce in size by at least 30% over 4 weeks, only those patients were included in the study. So only those patients, those wounds which were not healing were included in the study. So the characteristics as the baseline, again, many of the patients were pretty obese. Mean BMI was around 33. Mean wound area size was around 6.6 centimeters square. And the mean wound duration was about 27 weeks. When we looked at the results, PICO resulted in almost like 40% better or wound area reduction compared to traditional negative pressure. Wound depth reduction also was about 30% better in PICO. And the wound volume reduction was more than 90% more when compared to the traditional wound therapy device. And wound closure increased by at least 50% when compared to the traditional device. So this resulted in undisturbed healing, a wider zone of therapy. And this was also portable. The patient can carry it with them. They can go to work. They can move around easily. You can just carry this PICO in your pocket. Just looking at a few cases where we had used PICO, this was a 70-year-old gentleman, diabetic for more than 41 years. And he had a heel ulcer. Heel ulcer was debrided and there was some amount of calcaneal osteomyelitis. Bone curettage was done. A lot of exudate was coming out from the wound. You can see that a lot of maceration surrounding that area. So we went in for a secondary suturing of this wound. And even then you had a lot of maceration. Over this, we had put an incisional single negative pressure wound therapy device, that is PICO was applied on this. And very soon the wound exudates started decreasing. And within a period of about 4 weeks' time, we were able to achieve complete wound closure, and the patient was mobilized within about 6 weeks' time. Heel ulcers are among the most difficult ulcers to manage. So coming on to the second case, this patient had infection in the dorsum of the forefoot. He had osteomyelitis of the second and third MTP joints where a debridement was done. Post debridement, the wound had a lot of exudate coming out and the wound was not showing much improvement. He was put on a single negative pressure wound therapy device. And over a period of about 5 weeks, the wound volume decreased, exudates started coming down, and wound started closing. So you could find that the wound has almost like completely closed. And by about the 6th week, we were able to achieve complete wound closure. The wound had completely healed by about 6 weeks' time. The third case, again, it's not a case of diabetic foot. It was a patient who underwent a CABG, and the chest wall wound had not healed. There were multiple sinuses there. So here again, PICO was applied. And within about 3 weeks' time, we were able to achieve a decent closure in this particular patient. So when you need to decide where you need to use advanced technology, if the wound is not improving, you need to ask yourself why the wound is not improving. If the edges are not moving forward, again, you need to look at using advanced technology. Thank you.
Thank you, Dr. Rajesh Kesavan, sir. Next, we welcome Maureen Bates to give a speech on bedside procedures for the diabetic foot.
Good afternoon once again. I'm just going to talk about, I guess, simple procedures that we carry out in the Diabetes Foot Clinic in the outpatient service there. So I guess not all patients who come into the Diabetes Foot Clinic need theatre, but I suppose in our opinion maybe they all need a podiatrist, because within the foot assessment we're looking for deformities. We always tend to check both feet. You know, when patients come in and they have a foot problem on one side, they don't often want to take their other sock and shoe off because they don't think that there's a problem there. Don't forget they've got poor eyesight, they have neuropathy, they may have peripheral vascular disease. So I like to tell them that it's standard procedure that we check both feet. And so we're looking for bony prominences associated with high mechanical pressures on the skin, which will result in ulceration. We're looking at the tissue, soft tissue, fluctuations, any erythema, any pain in those persons who have less neuropathy. We all know, maybe, that a neuropathic foot is often warm, it's well perfused, with easily palpable pulses, and the problems are going to be on the apices of the toes, the dorsum of the toes, the plantar metatarsal heads. And if the callus is developing there and they're not treated, we're going to end up with ulcers. And then there's the neuroischemic foot that we're looking for, which is often cold or cooler. The pulses aren't so easily palpated. Therefore, the skin is poorly perfused. And these patients will develop calluses and dry skin and possibly fissures on the margins of the foot. And so that's how we tend to categorize both types of patients, the neuroischemic foot and the neuropathic foot. And I think it's very important to know which one is which, because it's going to determine your debriding skills. So we're very skilled at providing sharp debridement for neuropathic ulcers and neuroischemic ulcers. Neuropathic ulcers tend to develop on the plantar surface. they've often got a large build-up of callus surrounding them, whereas neuroischemic ulcers, as I said, tend to develop on the margins of the skin of the foot. They're not necessarily associated with high-pressure areas, but they're cold and they've got fragile skin, and there's not necessarily a good enough blood supply for them to build up callus. So these are standard procedures that we look for in our, I guess, within our skills and our knowledge, so we can look at a foot and are usually able to determine what it is we see in front of us. These are the kind of instruments that we use. There's scalpel, there's forceps, there's scissors, there's probes, and there's some what we call nail nippers. So these aren't, these are standard set of instruments that we have. They're good for nail care, they're good for callus care, and they're also good for removing any osteomyelitis in the tips of the toes or perhaps even metatarsal heads that are exposed. And from the International Working Group, we know that sharp debridement is recommended to remove slough, necrotic tissue, and peri-wound callus, taking into consideration, as I said, ischemia and pain. So the benefits are that of a good debridement is that it allows the true dimensions of the ulcers to be perceived. It allows drainage and exudate and removal of dead and devitalized tissue, and therefore will reduce the burden of bacteria. And it also prepares the wound bed and the surrounding tissue if we're wanting to use topical negative wound therapy. It also converts a chronic wound into an acute wound in a neuropathic ulcer. Don't forget, with diabetes, it's an autoimmune disorder. The body becomes lazy, therefore it's not trying its hardest to heal these wounds. Therefore, with neuropathic ulcers, it's fairly okay to be aggressive, to cause some bleeding, and activate that wound into a more acute wound. And of course, it assists wound healing post-surgery, and as I said, it enables deep tissue and swab samples, either tissue or even swabs. But the gold standard for any infectious disease consultant or microbiology team is for us to take the deepest tissue samples that we can to be taking to the microbiology lab. And then what we mustn't forget is that this is very important because it allows us to target antibiotic therapy and not overuse antibiotic therapy or inadequate use of it, and continuing with the same antibiotic. It could be the wrong one, could be the right one. So deep tissue samples are extremely important. And then it's important also not to forget that when we're dealing with a neuroischemic foot, we've got to do very careful sharp debridement because we don't want to cause any soft tissue damage that the patient is already struggling to heal. So just a few examples here of what we carry out. So as you can see, the main goal is to heal ulcers as quickly as possible, and then we're also wanting to take into consideration acute phase etiology. This gentleman has an apical ulcer. We're able to make him a little toe prop quite easily, and if he is compliant, then perhaps that would be enough. But if he's non-compliant, perhaps he needs a flexor tenotomy or even a tendon Achilles lengthening. And you can see with this foot, there's callus on the apex of the third toe. You can see by debriding the callus, it's releasing the pus, and then that little toe can go on to heal. But of course, we want to be then using preventive methods such as a flexor tenotomy or a silicone prop or changing the footwear even. And if we don't get that right and the patient still continues to have problems, then we'll be referring to our orthopedic colleagues. It's a simple example of a neuropathic foot ulcer. It's been debrided with a size 10 scalpel. it's revealing that in this case that the wound is clean, it's healthy. The main problem here is the offloading, and if we're not successful with casting and offloading procedures, then once again we will be referring to our orthopedic colleagues to help with the deformity. And here is another example of a patient who came through as an emergency. I think he'd been on holiday and came straight to the foot clinic because he did too much walking. We can see that there's redness and there's swelling. And then when we debrided, we were able to take a nice tissue specimen of the base of the wound. And again, he went on to heal quite quickly. We can see that his ulcer is associated with hallux rigidus, and perhaps that's something that could be corrected in the future. So we get over the acute phase of the infection and bring him back to the orthopedic team later on. You've already seen these little autoform. You probably, no doubt, use these here as well. And as I said, if the patients are compliant, then they're quite good at preventing apical ulcers in the future. And of course, we've got these, this is what we use to do our flexitinotomies, where we have this apical ulcer here. If you can achieve 5, maybe even 10% of correction, it's a minimally invasive procedure. Oh, maybe it's the battery's lost. It goes on to heal. And of course, this is another acute presentation of an elderly gentleman attending the clinic as an emergency with a red hot swollen foot. You know, if you just look at it, then you can see it's red, you can see it's swollen, you can see it's hot. He would have gone for an x-ray, he would have had a vascular lab scan and a thorough check to determine what was the cause of the redness. And we found an interdigital ulcer associated with that subluxated right second toe. That's on your right side. We would have given that patient antibiotics. We would have been debriding, taking tissue samples. He was not keen to have the toe removed. So despite the unlikelihood of perhaps this healing and remaining healed was unlikely, but despite that, he would not agree to have the toe removed. So we persevered with seeing him on a 1 weekly and then 2 weekly basis. I'm glad to see that he did go on and heal, but then he was provided with footwear and things to prevent the rubbing in the future. And as in the previous session, there's lots of things that we're not just paying attention to the wounds on the foot, but also to the patient's medical and social needs. And of course, you can't always give them what you would like to give them because they may have eyesight problems, balance problems, frailty and mobility problems, living alone, working. Can they work? Can they not work? If you're going to put them in some form of offloading, will the work environment allow them to go to work like that? So these are all the things, in addition to the financial implications, that we have to take into consideration when we're looking after any single patient. Now, this is an example of a bowler walker. I didn't quite have time to talk to you about this in the last presentation, but these are devices that we've been using more frequently, along with a total contact cast. It has, as I said, a steel bar that extends the medial aspect and the lateral aspect of the leg, and then it supports the foot with a rocker sole, and then it's the tibial flares that take a lot of the weight, so the foot is suspended. And of course, when you've got wounds like this is an ulcer on the first metatarsal head. Patient was treated in a total contact cast and a bowler walker, in addition to having a tendon Achilles lengthening. And then he went on to heal and would go on to orthotic footwear successfully. And then this gentleman was the same, and that was just to hold him until he had more, I guess, further surgery. So we saw larval therapy. This is another bedside technique. I won't talk about this because you saw a lot of that. And then if we look at this foot, you might think that that's a lymphangitis on that right foot, but it was cold. You can see that the ulcers and the fissures are on the margin. This patient needed to go to a vascular lab and vascular colleagues immediately. He needed a distal bypass to return his foot colour and nutrition and skin quality back to normal. And this is a last example of a patient who'd had the venous arterialization. For what you can see on the picture is a necrotic toe. Unfortunately, he advanced to a transmetatarsal amputation along with venous arterialization, and it was left with the podiatry team to offer offloading and wound care. It was really very, very, I guess, a challenging case to deal with. However, we ended up giving him a total contact cast plus a bowler walker, and then he went on to have this type of orthoses, which is a ground reaction ankle-foot orthosis that fits inside his shoe, and that has allowed him to remain healed very successfully. So in summary, advantages of bedside debridement and procedures is it's instant. There's no theatre lists needed. We avoid admission. We can get rapid infection control. And we all know that it doesn't stand alone and it takes a team. Thank you.
Thank you, Dr. Maureen Bates. Now we welcome Dr. Nagarajan sir to share his knowledge on debridement, red lights and green lights.
Moving இது forward. எங்கள் வாழ்வும் எங்கள் வளமும் மங்காத தமிழென்று சங்கே முழங்கு என்ற வாசகத்துடன் இங்கு குழுமியிருக்கும் அனைத்து தோழர்களையும் வணங்கி இந்த மாநாட்டிற்காக அயலக நாடுகளிலிருந்து இங்கு வந்து அவர்களுடைய உணர்வுகளையும் அவர்களுடைய கற்ற அறிவுகளையும் நம்மளோடு பகிர்ந்து கொள்ள வந்த அனைத்து அயலக மருத்துவர்களையும் தமிழக மாண்போடு தமிழக சுயமரியாதை பகுத்தறிவோடு அனைவரையும் வரவேற்று என்னுடைய உரையை தொடங்க இருக்கிறேன். I must be thankful to RK Diabetic Center, Dr. Kesavan sir, Madam Sheila Madam, senior faculties, the doyens of the diabetic surgery. I must congratulate RK Diabetic Center for inspiring the lady surgeon to take over the diabetic foot as a special life for them. One among the things the madam is sitting there, another one is that Dr. Aarti, though I thought of it, she might be a surgical oncologist, but finally I learned that when she has the interest towards diabetic foot, I congratulate Dr. Aarti. I congratulate both of you also for a dynamic lady doctor being that inspired for taking the specialty, the diabetic foot as a specialty for her life. Similarly, another three people, I must be thankful to them. One is Dr. Nikhil. He is our PG, a senior PG. He himself registered and asked the permission for attending the conference from Savida Medical College. Another lady, a dynamic military surgeon, going to be a military surgeon, Dr. Diksha, Dr. Venugopal, both of them are very much interested to attend this one. I saw that people are very eagerly observing the things. I welcome you all for these ones. Before going for that, my topic was given is that wound debridement, red light and that green light. I do not know that one. Sir, why he has chosen this one to me? But anyway, I'll try to see that one, how the things are going on. The world which I have seen with my both eyes, one side, the person is with that dead tissue. If I'm looking at the other side, I am seeing a person, though we are looking like me with the coat suit or something like that. In the mind of that people also, they are having a dead tissue. I have to address, as a doctor, I have to address the both persons. So I think I saw that my previous speakers were told so many things, whatever the things I'm going to tell, but I will be concentrating more on that. The living person is, or the person is accompanying that diabetic patient. Their dead tissues or dead concept has to be removed. That is a better debridement than that of doing the things to the patient. So with this perception, I am starting the things. So wound debridement in Tamil Nadu, we are proudly says that one. We are the Tamil Nadu doctors are following that principles laid by the Tiruvalluvar 4,000 years back itself. He said that there is one God. He does not have anything. Similarly, he said that by birth everyone is equal. No one can claim that he is a big man. I am a smart, tiny man, or not like that. So by doing your work, you can claim that you are a man superior. Otherwise, your color, contrast, nothing will differentiate between you and other persons. So this is the Tamil Nadu culture. The persons that gave hand to stand before you all starts from my father, mother, and my teachers. Because of them only, I am standing before you all. I must be thankful to them. So similarly, that Agara Mudala Eluthallam Adi Bhagavan Mudatre Ulagu, that for the world, so that letter, Tamil literature starts with A. Similarly, that God also is there is a one person is there. That is the first person for the world. But nobody has given any shape, size for that God. So it is not to fight each other for showing this is my God, this is a color, all those things. That Tiruvalluvar has told all those things in the 4,000 years itself. We are the followers of him. As a doctor, whatever the things you are learning you learn it properly. By the learning, after learning it, you stand for the whatever the things are you are learned. That is also is being given by that this one. For a doctor, Tiruvalluvar has given that noi nadi, noi mudal nadi, adu thanikum vai nadi vai pasayal. So how a doctor should live in this world, how to practice, all those things being given by the Tiruvalluvar in Tamil Nadu. We are proud of that one. So no one can claim that they are a saint. So anyone in the world, including the President of US, cannot say that he is the supermost power. Everyone is a comma. So not a full stop. So that reverse. 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 Okay. So that, so maybe that I never claim that I am the master in the subject. Still every day I am learning from morning to evening. Now that human physiology also, as well as a pathology also, are nobody can define that one, what is the things going to happen in another minute. I saw the patient in ICU, another 5 minutes, if the call will be coming there, the patient is gasping. So no one can say that the physiology and the pathology are very defined one. So you have to prepare yourself to see that unexpected consequences. Current world, the patients are coming to us with so much amount of unrealistic expectations. The patient with the gangrene expecting us to give you a normal leg, not more than that one. If you're looking at this one, the attenders also looking that one, we have to give you that leg, original leg. This sorts of that situation, as a doctor, we are living with the patient society. So it requires, as you have discussed length and breadth, that it is not a single man show. It has to be shared by so many people. So that it requires a multidisciplinary approach. Everybody has told that one. Not only on that one, it requires a society that contribution for that treating that patient. Appreciating or discriminating shades of red and green in the diabetic foot is always look personalized. So what I am thinking that on the red light and green light, what I am thinking it is a red, it may be green for Diksha or somebody, Kesan sir. So that I am not sticking on to that colors, red or green. Now the types of the debridement, so many things we know that when surgery is the foremost thing for taking out the dead tissue. Other than this one is, so many things is there, but it is a adjuvant one. But the primary things is that the surgeon hand is that foremost hand to remove the dead tissue. So the different type of the debridement, mechanical, that enzymatic, biological, vac therapy and all those things all are being told length and breadth. So before going for the debridement, I always make 10 commandments on myself. I'll ask the questions. I will try to answer, satisfy myself. And if I am comfortable with more than 50%, then only I will be treating the patient. Otherwise, I am very careful to treat the patient. So currently, this patient, what is the patient I am seeing? Is that a compensated patient or a decompensated patient? Is that acute disease or a chronic disease? Is that the second one is, who is the primary physician treated the patient? Is that allopathic man? See that allopathic era, that man, now I divided into pre-NEET and post-NEET. Is that man is studied in the government medical college or studied in the private or deemed university? There is a marked difference between these people and that people. So when we were the students, pre-NEET, I came the pre-NEET, we were living with the patient. Nowadays, though that people are saying that NEET is giving a extraordinary knowledge to the doctor, but the NEET to post-NEET is giving only a simulation-trained doctor, not a really trained doctor. So you must be cautious about the things before handling the patient. Or sometimes that allopathic medicine is equated with an alternative medicines. How it is going to be equal with that allopathic and the alternative medicines, that is also very careful about the things. Then another than this one, so many students are gone to abroad. After finishing the things, the MBBS degree they got it in the post that the COVID period without attending the practical examinations. So that the people, that you have to ascertain that one, whether that doctor seen by is that doctor studied in foreign countries, is he completed that exit exam or not completed the exit exam. These are all some of the things you have to, as a doctor, a treating physician, you have to see that one. Then other than this one, you have to see the background support to ascertain that the patient will be compatible or the patient background is sufficient to treat the patient in your hospital. Because with your, that the doctor is always a sacrificing community. You will be thinking that you want to do something better. Initially, the patient will be accepting that one. But after 2 or 3 days, the patient will be fighting with there the problem will start. So before going for the things, better to assess that all the background so that you can come out of the problems without damaging your nursing home. The primary plan is multidisciplinary, optimization, early management, late management, rehabilitations, ideas for decreasing the rate of recurrence. So with this perception, I always go for this one is. Before going for the wound debridement, I will ascertain that the type of the wound, whether it is based on the etiology, based on the contamination, based on the depth, based on the complexity, based on the complications. So I will ascertain the wound first before going for that. This one is. So for the debridement, I follow the principles of preparation, compartment syndrome, under the principles of management of the wound, physical therapy, thrombolysis, monitoring the complication and progressions, back therapy. This is one adjuvant therapy will be doing that one. So whether that tetanus prone, take a prophylaxis for that tetanus prone wound. So debridement plan, once you decide the debridement plan, so go for a fasciotomy, slough excision, minor amputation or a major amputations. This is a way we used to practice that our wound debridement. So based on the structures involved and patient counseling, everything has to be done by that video so that when you are, because the evidence is alone is going to save you in front of the court. So everyone in our practice, we will be video recording everything, whatever the things being told to the patients. So if the demands, we will be presenting it to that the court. The aim of that team is mutilation of that idea of the diabetic surgeon is to preserve the limb. Beyond the limit, there no other choice for us except of going for a mutilations. Then after the mutilations, we have to do that degravitation, anti-edemal measures, that slough excision. These are all some of the things we'll be doing that one. That mutilating surgeries are, is it the toe disarticulations, amputations. These are all the way we are practicing that different type of that excision is going on. That finally we will be going for a wound care. There is one custom that one care that a negative pressure section, that one customized negative pressure section we devised ourselves. That is a customized one. That is called Kimaka customized VAC therapy. It is called as Keelpark Medical College, that VAC therapy. Because I studied in that college, that devised a VAC therapy by using the glove. The cost about the things only 1,800 rupees. But conventionally, we are applying a machine. It will cost about daily for 5 days, it's 8,000 rupees. So you can shorten that the wound by putting the things. So the red signs, as I told you, that one is decompensated patient. See the background of the patient, as well as the green signs. If it is the disease is a localized one, if it is a dry gangrene, or if it is a first infection, these are all the green signals. I used to think it out there. So with the things, few words, I concluding that presentation. Once again, I'm thankful for Dr. Kesavan and Sheila Madam for giving this opportunity for presenting my views in front of the audience. Thank you all.
Thank you, Dr. Nagarajan sir. Now we welcome Dr. Prashant Vas sir for sharing his knowledge on managing small fiber and large fiber neuropathy.
Thank you all. Thank you very much. It's a pleasure listening to the experts on the podium, and also it's good stamina from all of you to be here this afternoon. We've had 3 days of pretty hectic, non-stop education, and as Professor Nagaraj said earlier, you know, no one is a full stop, although, even if you think they are one. You know, we live in a different world now. You know, while you were talking about things, I was on ChatGPT looking up, you know, what are the things that we should do for, say, debridement, and the artificial intelligence now is good enough to tell us what are the key parts of managing certain elements of diabetes. But you have to live it as a clinician, because what the books tell you is one thing. And I'm here to talk about some pearls about diabetic neuropathy. Nothing, I suppose, very different to what you've heard before, but perhaps to consolidate. You know, diabetic neuropathy, it's like, how do I say it? This should be the prequel. It's a prequel. This is the condition that has allowed, we are here as a reason of diabetic neuropathy. And it's very common, causes a lot of distress, a lot of people develop pain. And perhaps as surgeons, primarily in the audience, and sort of allied health workers, first thing to know is that diabetic neuropathy is not just caused by high blood sugars. That's perhaps the commonest contributor and a common associate. But neuropathy can exist even before you get the classical diabetes. So the neural damage occurs or starts to occur when you have pre-diabetes. And if you look at studies that look at impaired glucose metabolism, and many of our patients in that sort of cohort already start to develop neuropathy. In fact, if you look at some of the older diabetes, type 2 diabetes incidence papers, up to 25% have it at the time of recognition. And that's because in addition to hyperglycemia or glucose, you have contribution from those other elements like dyslipidemia, hypertension, insulin resistance, and of course, intracellular effects that drive all this. And although we call this a microvascular complication of diabetes, increasingly we recognize neuropathy to, especially in type 2 diabetes, to be metabolic in origin, and also with a huge contribution from tissue hypoxia. It's a big contributor to all this. There is a lack of a sort of a hypothesis that tells us why some people get neuropathy and some people don't get, and how the damage happens if it's not just glucose. But that is something I think we're working on to understand. And nerve damage can happen everywhere. It's not just in the feet. People with neuropathy can come to you with pain and numbness and certain other features. Of course, the commonest one, and the reason we are here, is because of classical sensory neuropathy that most of our patients have. And aren't we just glad that the motor effects are much later? Now, and I won't go too much into this, as more physicians, we look at the sensory and the symptoms here, and it's good to divide them into positive and negative sensory. And the positive things are things that would trigger the nerves, so the tingling, the burning, you know, those sort of things. It's like your screen here flickering. And you know, when you have things like that, you can do something to calm it down. So your medications that you will use will work on the positive sensory symptoms. But the negative ones, the numbness, the extreme feeling of cold, those kind of things where the nerve and the signaling above can't talk. Now, you can give them all the pregabalin you want, but it's not going to work so well, because it's only going to dumb down the excitation parts of the nerves, not the nerves that are already diffusely involved and don't have these primary effects. We get certain presentations. This is in the hand, a classical patient with diabetic neuropathy, one of our patients. You can see the lower limb muscle wasting. You can even appreciate the thigh muscles in this wasting away. They've got a foot deformity, and a possible Charcot on the left leg over here and the left foot, sorry. The hand gets involved very often. Yesterday we had a lovely lecture on painful neuropathy. I won't go on to it. But painful symptoms are an extension of your neuropathic symptoms. So if I shake hands with Rajesh, it's a comfortable experience. But if I start squeezing his hand, that pressure then escalates to pain. So you have nerves that get excited, and that excitement, when it goes beyond a certain level, you get pain. And depending on the little nerve fibers that get involved, you get various different characters and experiences with pain. And the challenge for us with diabetic neuropathy is many of our patients are asymptomatic. And these are the patients that come to you with their first foot ulcer, with their gangrene, because this is our big challenge. Those with those sensory symptoms are actually protected. In fact, I think I've made this comment to Maureen in the past that we have a neuropathic pain clinic, and very rarely do I need to refer someone for a foot ulcer from the neuropathic pain clinic. They often have severe pain, but they don't have insensitivity to, say, the monofilament. They're not insensate. So neuropathy is a spectrum. It's a spectrum from when you have perfectly well-functioning nerves, and then the nerves start getting slower. It's a bit like you after lunch, you just don't want to concentrate. But that's okay, because, with good exercise and treatments, that could get better. But then that gets worse, and the small fibers, those that mediate pain and temperature, can often get involved. And then the larger fibers that mediate the touch and the vibration, proprioception, they get involved. Often they get involved in parallel, but the smaller fibers, because they don't have the myelin sheath, they get glucotoxicity or other elements they get a hit much more early. And then, of course, the fiber changes, and then the fiber dies, and you have sort of a more established neuropathy. So if I was going to look at it as a time scale, you can see you have no neuropathy, then mild neuropathy. It can get worse. And this is what we use, and this is what we detect with our monofilament, the loss of protective sensation. Very advanced neuropathy. And we call this diabetic neuropathy. There's a lot of neuropathy before that, and that is like a tip of the iceberg for a lot of your patients that come to you, and sometimes even your Charcot patients, you can have small fiber dysfunction, normal monofilament, but you have enough C fiber damage there to develop a Charcot foot. So your neuropathy tests, bedside ones, can be normal. So don't be put off diagnosing conditions such as Charcot in your patients. Of course, we use the monofilament, lots of different spaces, areas to use the monofilament. In our clinic, we use the neurosthesiometer to detect loss of protective sensation. And that's me during COVID, trying to do these things. And there are various different tests. You've got to find one that you can adapt to your thing. We sort of developed the touch the toes test. But it's a very clunky field, and there's one test that does one thing for yourself. You can buy all of this, and then you have a comprehensive neurological assessment, which I think is a good idea. I did look at this display outside with the NeuroTouch. It's quite an interesting device, and it's got 4 or 5 different testing modalities. You can do vibration, hot and cold. You can also do a pressure monofilament, which I think is good. And this is a more comprehensive battery of tests. I think has got good potential for the future. But you need to find what you're going to do. And the big question is, what are you looking for? Are you looking to assess for a loss of future risk of ulceration? Then you just need to look for loss of protective sensation, a 10-gram monofilament or a vibration perception, or if they can't feel the tuning fork, you got your diagnosis. If you're looking for more subtle forms of neuropathy, of course, you need to look a bit more deeper. But if they already got loss of protective sensation, you kind of got your diagnosis. You don't need to look further. Of course, if that is normal, you got to think of alternatives. And I'm not going to go too much into this, but maybe you could send them to a neurologist if you really want to pursue a question of, do they have an atypical neuropathy? But the real time you want to pursue a question about, do they have an atypical neuropathy, is if they come in with symptoms over a few days. If you come in with weakness of your legs and pain and tingling that has happened over 72 hours, 48 hours, that is not going to be a classical diabetic neuropathy. That's an atypical neuropathy. It may be from diabetes, but 9 out of 10 times there's an alternative diagnosis for it. So that's one time we need to get a neurologist involved, and even we do that. But all of these come together to drive your risk of diabetic foot. And that's why we need to get on top of that. Now, in terms of management, we don't have good treatments for diabetic neuropathy. The goals we have is to improve diabetes control. We have some good medications for it now, and we really need to sort of focus on diabetes control. A lot of our patients are at high cardiovascular risk, and neuropathy is a risk factor. So we really need to optimize those elements. And in UK and in the US, we don't have treatments licensed for this. I think you have one drug available over here, but it's not licensed in sort of the Western countries, so we can't use it. And sometimes we use things like antioxidants, but they are all in the periphery. They're not there is no disease-modified agent like you have for rheumatology available yet. I hope it comes in the future. We had a lovely chat yesterday about the various different medications, what to use, what not to use, but it's very difficult because you don't know where the pain is generated, whether it's generated in the brain or is it generated in the periphery. Because at some point of time, if all the nerves are involved, you can have pain generation in the spinal cord or in the brain, and you still will experience pain. So if you stick a plaster on your leg, it ain't gonna take away your pain. But it's good to measure pain, and it's good to explore what will work for the patient. I hope in the future we can phenotype the patient to where their pain generation is initiated and treat accordingly. But at this time, we try various different options. Topical options. We use the Opside spray a lot in our clinic. It's backed by some good evidence. We use the Cutenza patch. It's not a first-line intervention. It works that it prunes the nerve fibers, and we use it for our more complex patients with quite severe pain. This lady did not actually respond to it. I just did a video for you to have a look, but we try this for our patients, but there is some good evidence to back that up. We can't use some of the drugs in UK very easily. They have potential for toxicity and also for abuse. Combining the neuropathic agents is a good idea, and really optimizing and avoiding opiates is our goal. We're doing a lot of work now in neurostimulation, and I think this has a role for the future. My time is up. There's a lot to talk about these pearls, isn't it? But spinal cord stimulation is something we are increasingly considering. Maureen thinks it's a brutal strategy, but for a specific group of people, you can use these implantable sensors. We've got to be careful in diabetes, but there is good evidence now for low frequency as well as high frequency neurostimulation that it really helps our patients. But in our clinic, this is how we do. We look for good control of glucose. If the pain score is less than 5, so 4 or below, we try simple techniques. If it's more than 5, we try various different measures. Not one thing works for our patient. And we refer them to the pain clinic. This is our pain service, which is within the diabetic foot clinic. Having them with our podiatry team is very good. Neuropathic pain patients can also have biomechanical pains and whatnot. And having our team looking at that, adjusting their footwear adjusting various elements, making sure there's no vascular disease, allows you to focus just on the neuropathic pain element. And this is our team at King's. This is the team at St. Thomas's, where I also work. They do the neurostimulation. It's, I suppose, an enjoyable process. And I think Maureen showed this picture, how time flies over the years. This is them catching up after 30 years of previous interaction. This is before my time and after my time. And this is the picture that our patients see when they come out of the pain clinic. You know, it's a beautiful picture. It should help relieve the pain, but the rascals in the Houses of Parliament often exacerbate the pain for our patients. So it's been a great pleasure coming here, Rajesh. Thank you for the invite, both for myself and for Maureen. And I wish Chennai Diabetes and Wound Care all success from King's College Hospital. Thank you very much, and very good.
Thank you, Dr. Prashant sir. Now we request Dr. Santosh Murthy sir to enlighten us about synthetic absorbable dermal substitute. It's a new entity in complex wound care.
Good afternoon, everyone. I know this is a very tiring session. Post-lunch, it's difficult to give a talk and also sit and listen. So, but then, again, I will ask for another 10 minutes of your time, and I'm pretty sure this will be a great value addition for your clinical practice. So, where do we feel it so difficult in healing diabetic foot wounds? It is not at the infection control or inflammation control, it is at the wound closure. Because when the wound closure is not so proper, you see that there is a chances of recurrence which is high. What do we do for that? We have got plastic surgeons, we have got vascular surgeons, we have got podiatric surgeons, good offloading techniques, everything. But still, there is a recurrence because there is a limitation for the plastic surgery point of view. Because, you know, when the vascularity is not good, it will be high risk to apply a microvascular flap on it. So what do you do in that case? So there are so many recent advances which have come up, which can definitely change your perspective towards complete wound closure. That is synthetic bovine source or human source of dermal substitutes. Now, why this dermal substitutes is really required, where you fail to close the wound with a flap, just allowing the wound to heal with a secondary intention, which is taking months together of your time. This is time saving, and the end result is definitely fantastic. Not just saying my words, I'll show certain cases and then discuss about the product. So why dermal substitutes? Let me give you a brief introduction. The dermal substitute should be tissue compatibility. It should be less toxic, it should be permeable, and it should be definitely infection resistant. If these qualities are there, then you can make sure that yes, it can be a replacement. Types of dermal substitutes. Now there's a lot of theory going into it, but then there are like temporary and permanent with biological or biosynthetic or only synthetic. Now today I'm focusing only on the synthetic dermal substitutes. Classifications and all, fine. Now I'll show you the case scenarios. Now this patient you see, can you play the video please? Now this patient you see is a necrotizing fasciitis case, not just necrotizing fasciitis case. This patient had anti-nuclear antibodies positive, he was on steroids, he was on immune modulator drugs. And can you play the video please? Can you play the video? No. What's happening? You can play it here directly. Okay, so this is another patient. This man is 84 years old and he had a gangrene. Now people want to go for a below-knee amputation, we all know. But see, with the good vascularity control, coming? Okay, so good vascularity improvement, a good nutrition and good wound care, we could achieve this. Now, how to close this wound? If we go with the human dermis or animal dermis, I'm pretty sure chance of infection was high. But we could cover this with a nice skin graft after putting synthetic dermal substitute, in which we can make sure that the infection rate is less. Because it was a gangrene case. And now, because the wound has healed, this 84-year-old man is now walking back on his feet. Just imagine if it had just amputated. What was his survival rate afterwards? So this is definitely the dermal substitutes are bringing newer ways of wound healing and giving a better life opportunities to my patients. Now this is another patient in which vascular surgery was already done. Can you play the video? Yeah, okay. Vascular surgery was already done, but still a midfoot amputation happened. Now this wound was not healing. I don't say only synthetic dermal substitute did all the magic. Definitely hyperbaric oxygen therapies along with the good nutrition support and good wound care. But the final picture which we received and the final closure you achieved, it didn't take like months together. It was hardly finished in a span of 2 months. And now this man is happily walking back. Now why we need dermal substitutes in the foot end? Because that is a weight-bearing area. And weight-bearing area, when you definitely need flaps to cover it. But when we are sure that flaps may not be well taken up or only 50% chances are there, why can't we go with dermal substitutes? And when we go with the regular available dermal substitute, that is the human one or the biological one, which is the animal origin, we are sure the chances of infection is also high. When it comes to synthetic, it will not be taken up by the infection. We can make sure that adherence is good and well taken up by the body. Now this is another patient in which, you see, every foot, I showed a full foot, then an amputated foot, and now this is, can you play the video? And this patient in which a below-knee amputation was already done, and still the wound was not healing. Yeah. In which vascular procedure was done, post-revascularization, there is a reperfusion injuries which generally commonly see. And then this ended up into an amputation. They asked for above-knee amputation. What we did, we improved the vascularity, hyperbaric oxygen therapies, local oxygen therapies, good nutrition control, and then the nice dermal substitutes which covered the bones and tendons, and then a nice skin grafting over it. We were thinking like maybe it will not be so pliable, it will not be able to take up the weight. But then the wound healing was so good that with the proper prosthetics, this man is again walking back. What if we'd have done an above-knee amputation? What was his life expectancy after amputation? So definitely, the quality of life improves when we use advances. Now, this is also, now that was a below-knee, though this is an above-knee amputation. Above-knee amputation, the wound was not healing. Then, can we assure that we can put a flap and close it? We can't. So what is the next opportunity? The next best opportunity is a dermal substitutes again. So good proper infection control, good dermal substitutes application. Now see the proper granulation which has come up. Now we can easily go for a skin grafting and close the wound. Now this is coming to the foot region. Now, can you play this video? In the foot region you can see the kind of quality, the end result. This is all because of the dermal substitutes. Because dermal substitutes give you that quality, that aesthetic look, which you expect after a flap also. Can you play the video? Okay, fine, leave it. Yeah, even in these cases, the final end result is so good looking, as if the wound was never existing before. It is because we are replacing the thing which is lost from there. We replace the dermis, we have replaced the fat with fat grafting, we replace the dermis with the dermal substitute, and then the end result is so good. Now, can we assure that recurrence rate will also be less? Yes, with the proper offloading, the recurrence chances will also be less. Now, in this cases also, you see, the wound was so necrotized and there was a lot of tissue loss, but then the end result, without the skin grafting, we could achieve this because of the dermal substitutes which we have used. Now, what is the dermal substitute which I'm talking about? I've shown all the videos. So this is the synthetic bioabsorbable material that provides temporary wound closure and also supports in reconstruction of the dermis. When the dermis is replaced only, the epidermis can be replaced. What we are doing, we are not replacing the dermis. We're only putting the epidermis, that is a regular skin graft. And the skin grafts, we know that contracts. And when the skin graft contracts, the chances of recurrence is high. And the wound, there is a contraction, the chances of breakage is high. So all these things are happening. So when we replace the dermis and then do a skin graft, the impact is different. So this kind of dermal substitutes are approved for burns patients, traumatic wounds, complex surgical reconstruction wounds, and chronic wounds like diabetic foot ulcers or venous ulcers. So it is approved. Now, the synthetic dermal substitutes, they often be retained while the infection is being treated. Because it is synthetic, the bacteria cannot eat it. As simple as that. So even if there is an infection, you don't need to be worried, okay, the cost may be high. And what if the infection is eating up my wound? So first of all, we should be pretty sure that your debridement, your wound bed preparation is so good that you don't need to worry on that part. And even if you have worries, then synthetic dermal substitute is an answer where even a little bit of infection, it is not going to spoil the material. And compared with primary skin graft, like I've already said, that the contracture which forms after skin grafting is minimalized after putting a dermal substitute. And definitely it is an alternative for covering the bones and tendons. That is a big nightmare for all of us. When the bones are exposed, tendons are exposed, how are you going to cover that? Are you going to amputate off? No. Dermal substitutes can definitely change the picture. Now, when we compare extracellular biometrics, which are many available in the market, and this synthetic dermal substitute, which I am talking about, Polynova BTM, what is the difference? The difference is that the foreign collagen, that is the extracellular matrix extracted from humans or animal sources, must be absorbed by the body, and that can have or induce an immune response, whereas the synthetic dermal matrix is free of biological material, so chances of immune response by the body is minimized. Chances of infection is high when there is a biological dermal substitute, whereas even though there is infection, the chances of product loss is minimalized when there is a synthetic dermal substitute which we use. Size limitations are there when we go with other, but synthetic dermal substitute, the sizes are available up to 20 into 40 centimeter, which no other dermal substitutes are offering. The cost of biological dermal substitutes, especially the human dermis, are very expensive. But this is like almost half of the price, not because it is synthetic, but just because it is not having the biological components which need to be preserved. So that is the reason the cost is also coming down. Coming to the acellular dermal matrix also, it is again the same comparison. The limitations in the size and multiple applications are required, whereas single application of BTM is quite good. The most important point is most of the dermal substitutes you see in market, they're having a synthetic lining over it, okay, which is acting as a protective layer for the dermis, which is the biological dermis. There is a protective layer. Mostly it is silicone. But in this BTM, the covering layer is actually adhered to the dermal substitute, synthetic dermal substitute. And because it is adhered, the chances of the slipping away, or it is not able to retain properly on the wound, like which we have complaints in most of the dermal substitutes are not happening because it is quite adhered to the dermis. So, the phases of wound healing, there is no difference. It is the same phases of wound healing. Only thing, we are not forcing our body to produce a lot of granulation, heal on itself. The body is already tired. All our patients' bodies are already tired. They are not nutritionally fit enough. They don't have so much of content. They don't have so much of material. They don't have so much of blood supply or oxygen supply to heal on themselves and make a proper good granulation. So let us support the body by providing it a platform where the dermis is actually already prepared. You're giving it a ready-made dermis and just asking it to grow blood vessels into it so that the healing can be almost 10 times faster. The wound which takes 8 to 9 months to heal is actually healing within 1 to 2 months. So that is all about dermal substitutes. Thanking you.
Thank you, Dr. Santosh Murthy, sir. Now we request Dr. Sheila Sasikumar, ma'am, who has been multitasking since the past couple of days, to talk about the impact of silk on inflammatory and proliferative markers in the wound healing.
Good evening to one and all gathered here. At the onset, I wish to thank my sincere thanks to my director, Dr. Rajesh Keshavan, for providing me the opportunity. Thank you, sir. And here, this is an ongoing study that we are conducting in our Department of Research and Education, and they are the team members whose names are enlisted here. And this is a clinical study where we want to show not only clinically about the material, the safety or the efficacy of the product, we want to extend the study or move to a deeper level to show at the molecular level. So that's why we started this study. So past 3 days, we were hearing about diabetic foot ulcer wounds, different types of management, materials used for the dressing materials used, etc. Now, we all know wounds, especially chronic wounds, are going to be a silent epidemic, and there are many factors which causes the silent epidemic. But whatever it is, this is going to add burden not only to the patients but also to the healthcare system. There are so many factors that we see here. The most important one we think about is infection, poor circulation, and inadequate wound care that causes the silent epidemic. So we know that there are many materials available. So when, as a clinical research person or a person with an expertise in clinical trial, we always see that when any product moves from bench to bedside, we call it as B2B, or from the laboratory to market, whether sufficient studies are being conducted. So we all know it starts from the in vitro studies, then we move to the preclinical models, then we end up in clinical trial to show that efficacy, move to different phases, and then finally to PMS. And now in India, you have the material-vigilance program where every 2 years, you have to show the efficacy of the product, 6 months report for the subsequent 2 years. So like that, we have so many products. So any traditional dressings, we all know there is some, not failure exactly, but there are some factors lagging. So we think about advanced wound care dressings. So what are the factors that they are going to enhance, or what are the factors this advanced wound care dressings is going to focus on? So most of it we think about non-adherence, then maintaining a moist wound, managing the exudate, preventing infection. But also if there are factors where the tissue regeneration happens, or anything that can promote tissue regeneration, reducing pain and discomfort can also add. So we are thinking about the study, or the objective of the study here is to develop an advanced wound care dressing that accelerate the wound healing. So Ceridom is one such product where we have the protein, silk protein embedded in it. Now this Ceridom is non-adherent, aromatic dressing material, and it has efficacy as an absorbent, very effective in the exudate management, optimal MVTR. So we have to understand the moisture vapor transmission rate, how much of moisture it is absorbing per 24 hours for, you can use per gram or whatever you decide. So this helps to understand that it has a moist wound environment, how well it is safe, efficient, and biocompatible. So Ceridom's innovative design ensures non-adherence, maintains a moist wound environment, effective absorption of exudate, and thus it can accelerate the wound healing process. So then we started the study. This is an academic study, but still then we get the permission from the ethical committee. So we started to frame a protocol, and the protocol was sent to the institutional ethics committee of our hospital. And the institutional ethics committee comes under the CDS code, DCGI. So we got the approval, and this study, we have a total number of subjects of 20, and it's an ongoing study based on the inclusion and exclusion criteria, which is listed here. It's very difficult, so you can go on. So based on these factors, we started to screen the subjects. Once we started to screen, then the subjects who fit into the inclusion criteria of the protocol, we started to recruit. So recruit the subjects. Once we started to recruit the subjects, then we have to take all the factors, the demographic, the normal, whatever the comorbidities, all the factors concerned will be taken off with the proper informed consent from the subjects. Now, along with the clinical, vital, and other signs, we started to take the swab to understand what happens at the molecular level. So normally when I say at the molecular level, we always think about DNA. Yes, of course, DNA is going to be the excellent genetic material to understand the specificity and whatever the marker or molecular marker that I'm talking about. But here we made a little bit variation. We used reverse transcriptase polymerase chain reaction, where the principle of this technique is going to be the same, but one step ahead, we separated the RNA molecule from the cells, and this RNA was reversely transcriptase was used to convert it into a complementary DNA. So the RNA template will have the complementary DNA. Once we get the complementary DNA, this DNA will be used by the same polymerase chain reaction. We have the tag polymerase, and we have 3 steps ahead where we have the specificity and whatever the molecular markers that we are identifying can be studied. So that is a little bit hi-fi technique to understand the molecular markers. So during each visit, we collected the swab material, wounds were photographed, the wound images were captured, and dressing was changed. So this swab, whatever we have collected from the subject, we used to dissolve it in the trizol reagent and stored it at room temperature. Once all the visits were completed, we then took for the analysis. What are the markers that we have analyzed? So we know the wound acceleration or wound healing follows 3 different steps. So what we did is, we identified the molecular markers or the molecular markers in different phases of this wound healing, and we tried to study the markers. So what are the markers we have studied is TNF-alpha, cytokines IL-1 beta and IL-6, metalloproteases, and also inhibitors of MP, that is metalloproteases. Then we have the transforming growth factor beta. For the angiogenesis, we took Ang1, And for extracellular matrix deposition, to prove that, what we did is we took the collagen 1 type, 1 alpha. Then to understand the homing and the angiogenesis process, proliferation process, we started to study the stromal dermal factor, that is SDF1 alpha, then CXCR4, then about angiogenesis we have VEGF and VEGF-R2, and we all know that reactive oxygen species is going to be one of the culprit in all the diseases concerned, and here also in diabetic foot ulcer it is going to play a vital role. To understand that this product, whatever I'm going to talk about, has an efficacy, we thought of identifying an enzyme to know that whether this has a effect on that. So we identified manganese superoxide dismutase also as one of the factor or molecular marker. Now, whatever markers I told you, why we have chosen this. So this figure will explain for that. Now, if you see here, this is a normal person, or when a normal person has a tissue injury, what happens? So we all know it follows a different phase. So during the inflammatory phase, which is going to happen, the TNF alpha, the cytokines, interleukins 1 beta and IL-6 will be released. So you have the clotting process, you have the primary response of inflammation happening, release of many inflammatory factors. Then what happens is it proceeds to the next phase where you have the collagen 1 alpha is being produced, SDF1 alpha, CXCR4, and also VEGF. Subsequently, you will have the other proteins which are being released, that is angiotensin, not angiotensin, for the Ang1 for angiogenesis, then PECAM, which is nothing but cathepsin, then VCAD, etc. So you have subsequent release of various protein factors during this scenario. As a result, what happens, even though there is an inflammation at the beginning, some of the factors will reduce the inflammation and bring the recruitment of the fibroblastic cells. It enhances the angiogenesis, new blood vessels are being produced, collagen synthesis, re-epithelialization all happens, and finally what happens is tissue regeneration with the scalp. This is in a normal case. Then why in case of diabetic foot also we have delayed wound healing, we talk about non-healing wounds, etc. Definitely this is at the molecular level we have to think about. So at the molecular level, what are the pathways that are being triggered? Where there is a hindrance, where there is an upregulation of proteins, where there is a downregulation of essential proteins, that has to be identified at the genetic level. So that's what we thought about. So in case of a person coming for the diabetic wounds, the delay happens at the molecular level. So the culprit that is going to be here is nothing but one factor, hyperglycemia. Hyperglycemia releases or it triggers many pathways. One of the pathways that I usually talk about is advanced glycation end products. So we all know in diabetes, AGE plays a role. Whenever AGE is synthesized or produced, it immediately goes and binds with a receptor called RAGE, and it induces several reactions or accelerates several reactions, triggers many products. So as a result, what happens is that many kinases pathways are accelerated. So you can see earlier what and all I spoke about in case of normal wound healing, there is a reverse thing happening here. So the inflammatory cytokine proteins, or at the genetic level, they are always upregulated. You have to understand, whenever there is a genetic expression continuously happening, the proteins are always produced at a large amount due to the central dogma theory. As a result, there will be a prolonged inflammation happening. This prolonged inflammation is one of the cases where it causes the delayed wound healing. The other thing is the proteins that are required for the healing process are down-regulated. That means they are produced in a small amount. As a result, what happens is that there is a delay in wound healing. So there are 5 subjects we have come across. This is one case study that I'm projecting here, where you can see clinically how it happens. So here we are changing the dressings every week, 5 plus or minus 2 days according to the protocol to meet the compliance of the protocol. Granulation and epithelialization is happening at the 2nd visit. So if you see here, the inflammatory markers, first, in case of first one, Ceridum is going to facilitate the wound healing by down regulation. I told you the first inflammatory markers are going to be always upregulated. We observed that there is a down regulation. There is a down regulation of these markers. You can see here, and there is a graph being shown here. So at the baseline visit, you can see there is an increase, where at the subsequent visit, there is a decrease of these TNF alpha, all these factors. So as a result, what happens? It moves from the prolonged inflammatory phase and comes down. And simultaneously, there is a down regulation of MMP, and also there is an activity shown in the T, that is inhibitor of metalloproteases is being augmented. And also you can see it facilitates the migration of homing and proliferation cells. It also helps, you can see here, it manages the level of ROS, manganese SOD or superoxide dismutase enzyme. It facilitates the angiogenesis. So you can see there is a upregulation of all these proteins from the graph. And here you can see how it is being expressed during each visit. So this is one, one study at the molecular level to show that it has an effect. So this is a heat map. Since we cannot show all the cases in so many graphs, we generated the heat map where you can see the expression of all the proteins in 5 different subjects. The darker area shows the higher expression. That is how we can see that there is an effect in these molecular markers. So finally, to say that the Ceridum, which is made up of silk protein called silk fibrin and silk sericin, has a role at all the pathways concerned, where I am giving justification of each pathway and each molecular marker is being assessed so that it can be definitely used as a dressing material, as an advanced wound care dressing material. To prove that, we are continuing further studies, and we want to prove with a statistical analysis with a number of subjects. So Ceridum accelerates wound healing via anti-inflammatory, antioxidative stress, and anti-apotopic pathway. If there is a possibility, definitely I would work on mitophagy to show that autophagy of mitochondria, that is degraded mitochondria, is also removed, because that is one of the most important factor. In future, we have to talk about the diabetic foot ulcer. So mitochondria is always forgot. It is one important thing that we bring it maternal inheritance. There is definitely an impact. So to prove, finally, through the molecular pathways, and through various Janus kinases pathways, through various factors, through all the pathways, we showed that there is benefit for Ceridum. In case of wound healing, it reduces inflammation, reduces oxidative stress, stimulates collagen synthesis, promotes angiogenesis, and prevents tissue degradation, and restores diabetes dysfunctionality axis, where I showed you the AGS pathway. So definitely it will be an opportunity to add value to the patients and to the stakeholders concerned. Thank you for the opportunity.
Thank you, Dr. Sheila ma'am, for linking molecular mechanisms to the clinical care. Now the final talk that concludes the meet is by Dr. Zulfikar Ali Abbas about managing diabetic foot in low-income countries.
Start with the name of Almighty God, most gracious and most Today I have been given a task on managing diabetes-related food complications in low and middle-income countries. Thank you so much, Chairperson, for your kind words. Thank you. Good morning, afternoon, or evening, wherever you are. I start with the name of Almighty God, the most gracious and most merciful. Today I have been given a task on managing diabetes-related food complications in low and middle-income countries. Before I start, I would like to thank the organizers for inviting me to give this talk, and I'm going to talk for next 10 minutes. So let's start. I come from Dar es Salaam, Tanzania, which is at the east coast of Africa. It's the land of Kilimanjaro, Ngorongoro crater, the largest craters, largest game park, Serengeti, Zanzibar Stone Town. You are all welcome. Look at the global populations from from January 2025, which has been recorded. Asia and Africa are the largest two continents in the world, which covers about 77% of populations, and 80% of diabetes come from these regions. So we have a huge problem. We are still not finished with communicable disease, and we are adopting non-communicable, whereas the rest of the world, the population is 23% of North America, South Antarctica, Europe, and Australia. These are the regions. Look at the prevalence in these regions. So if you look at it, Africa is going to lead in next 20 years, 134%, followed by Middle East and North Africa, followed by Southeast Asia and Western Pacific. So low and middle income countries are going to be hit extensively with diabetes. In Africa, where were we 20 years ago and where we're going to be next 20 years, increase of 55 million, that is 134%. Diabetes is going to increase, the complications are also going to increase, and what we are here today for diabetic foot, 60% of non-traumatic lower limb amputations occurs with the patients with diabetes. Burden of diabetes-related food complications. As I mentioned, diabetes is going to increase parallelly, the complications are also going to increase, and the most dreadful complications out of all the complications is going to be diabetic foot. It's going to be major public health problem, prolonged hospital admissions, cost will be not sustainable. Commonly in our setup is infectious etiology followed associated with peripheral neuropathy, associated with underlying neuropathy or arterial disease. As we say, time is tissue in diabetic foot, and when you see this type of patients which do not have the time in his tissue in these patients is called term diabetic foot attack, and this has to be treated like heart attack or stroke. So these are the patients most of the time we see when they come to our setup. And typical sequential timeline and decision to make and see us in whether you are in Asia or Africa is patient usually starts at home, then visit to the herbal or faith healer, traditional healer, visit to the primary health center, comes to the district or regional health center, and by the time they reach to the specialist or referral health center, it's too late to save even the life. Amputations, gangrene and infections are the most common cause of amputations. True prevalence is always underestimated in these two continents, Asia and Africa, because we don't know what is happening in rural area. Published report says it's delay presentation is the main cause of amputations, and most of the patients need amputations die even before the surgeons see them. So, as calculated, estimated in 2005, the amputation occurs every 30 seconds due to diabetes, which was re-estimated in 2017, and it went bad to worse. It becomes every 20 seconds, so 3 in a minute now, before it was 2. So all these seminars, conference, hands-on experience, all these things are still, we need to create more awareness. Global economic burden of diabetes-related food there's a study done in 7 regions, 36 countries, 51 centers, was just published last month in March. You can see in Africa, to treat a diabetic foot ulcer takes about 30 months of the salary, whereas in Southeast Asia is 34 months of salary. So it's a huge economic burden to the patient's family. Socio-economic factors, we still haven't finished with our patients. All this barefoot walking, inappropriate footwear, home treatment, and etc. Non-existing of podiatry service, non-ulcerative pathology of ulcers. These are the patients when they come to us, we usually do not check them. So it's a non-ulcerative pathology, for example, callus, corns, fungal infections, hypertrophy of the nails, cracks, fissures. So this has to be taken care so to reduce morbidity and mortality. Where do we go from here with an aim of reducing amputations? In summary, many reasons for poor food care in various low and middle income countries globally have been discussed. Increase in high technology, rocket or molecular genetic science has and will not change the practice in low and middle income countries of diabetes related food complications. If we have to ask what has changed in past 25 years we change the practice of diabetic food in next 25 years, the answer to this question would be, reply to this question is not that high technology, but rather dissemination of knowledge, education. In two distinct areas, this has been an impact and has been seen, and I will show you the powerful tool for prevention and control of diabetes-related food complications in our part of the world is prevention and control, and to empower the healthcare professionals. So, role of education on preventive and therapeutic strategies. As I always say and would say it again, education is the only powerful tool we have, especially in low and middle income countries, which is free of charge for the patients and effective if it is implemented properly. Guidelines of implementations and of prevention and therapeutic strategies. Whatever you do, this has to be done before we start anything. A strategy is required to have a successful and effective healthcare program for diabetes-related food complications. Potential barriers need to be identified and act as soon as possible. Program has to be a goal-focused and properly implemented, otherwise it will fail. Has to be tailor-made according to the local situation and local champions in each and every country. It cannot be adopted from other countries. Education material and all other has to be produced locally and available locally, and this all leads to a good outcome. Closing the gap of available and affordable diabetic food care is very important. Practical approach to reduce ulcers leading to amputations in diabetic foot is diabetic food care education. So preventive and strategy, most of the food problems are prevented by early identification, prompt and skilled healthcare professional, and every healthcare profession should be able to do a basic examination of peripheral neuropathy and peripheral arterial disease. At least that has to be known even at the primary and grassroots level. So one of the program was step-by-step food prep, which was started in 2003, which was piloted and carried out in Tanzania and India. When it started in Tanzania in 2003, this program showed ulceration, infection, and limb amputations are the potential preventable if it has been implemented properly. Several step-by-step food projects were done in Tanzania from 2004 to 2012. Even the surgeons were trained, and then it was exported to other countries in Africa and outside Africa, 15 to 18 countries now in Africa. And then we said that we cannot go around to each and every country, so then it was step by step was converted to train the food healthcare professionals. So now everybody who is involved in diabetes, it is their business, it is their duty to look after the food. So in 2023, we decided that we should do it according to the region and not going to individual country. So we call them in all the countries in that region to one city. So train the food healthcare professional is a training program that teaches the course structure, organized delivery method, and evaluation skills. Is a course run for healthcare profession to train others to become expert in clinical and education skills and knowledge. And there are three parts: basic, step by step; advanced course, step by step; and then implementation and sustainable. And obviously we also tell them to collect the data. Several the food healthcare professional courses have been done, and in last 2 years we managed to do 5 of them in 5 regions. So it was in South America, it was Western Pacific, then we went to Europe. Even there were about 12 to 13 countries were given the training, Sub-Saharan Africa in Zanzibar, and then last was in Karachi for MENA region. So basic education for the people, which people should be targeted for food care education. It has to be stratified according to the service, starting from general information and going high to the risk food, intensive food education according to the grade. So this was step-by-step food project was started in low-income country, Tanzania, and it went up to the Europe to high-income country, and it has almost touched 128 countries since 2003. If I've given you too much information, then take-home message: how to prevent food problems, regular inspection and examination of the feed, identification of high-risk food, that is PN and PAD, education of the patient's family and healthcare workers, appropriate footwear, and treating the non-ulcerative pathology as soon as possible. In conclusion, efforts are required to increase awareness of diabetes and its complications among healthcare workers and patients. Early detection and treatment of diabetes will improve the course of disease and reduce morbidity and mortality. I leave with this thank you slide. As Mahatma Gandhi, the great two people, one of them, Mahatma Gandhi from Asia, said, live as if you were to die tomorrow. Learn, educate yourself as if you are never going to die. Then we also saw Nelson Mandela. He said, education is the most powerful weapon which can be used to change the world, and he did. And I would say that education is the only powerful tool we have it in developing world, which is free of charge for patients and effective if it is implemented properly. Thank you very much. Thank you.
Thank you, Zulfikar sir. We move on to the Q&A session right now.
Now we have final question for the day to Dr. Santosh Murthy sir. Which is the best synthetic dermal substitute in your practice, sir?
See, it's all about dermal substitutes. There is no best synthetic dermal substitute. It is the dermal substitutes which are of three types that I was telling: biological and synthetic. Biological is further divided into human source and animal source. And that's what I was telling. The synthetic dermal substitutes, because it is not having any biological material in it, so the bacteria doesn't eat it. Whereas the animal or human, the chances of eating it and material loss is high. That is the only major difference which we see. And yes, because it is synthetic, absorption into the body is also taking a little extra time. Maybe if this biological takes around 10 to 15 days, this may take around 20 to 25 days. Absorption may be delayed, but chances of infection and material loss is absolutely zero.
Thank you, sir.
I think there was one more question on the volume of fluid that a Pico dressing can take. It is about 300 ml for the Pico 7 days, Pico 7.
So I particularly wanted to ask, because we general surgeons generally are scared to use Pico dressings on diabetic foot wounds. Conventional, we are a little bit confident, like you can even have a wound wash and so many different things we can do. But you could use it even in the cavity wounds. How could you do that? Can you give an example?
The cavity wound, it may be a little difficult, mostly on incisions and on wounds which have some amount moderate exudates, because pretty good.
Quite regularly.
On diabetic foot wounds, sir?
In diabetic foot wounds, post-surgical, but the initial part of the post-surgical management would be through a regular wound, and then when you get good granulation, often sending them home on a Pico, the large one can be a challenge if you're elderly, so we'll change it over to a Pico. But it's something you can start working very cautiously. Caution is good, so well done. And then maybe perhaps, gain more confidence. But it's being extensively used in the UK now for post-operative wounds. Sometimes like an incisional wound or very straight away. But if you're talking about deeper wound post-operative, after a period of intensive, regular negative pressure. Thank you.
And so any role of PICO on dermal substitutes also?
Yeah, very similar to traditional.
Very similar,
this
same thing.
So once you put a dermal substitute, the exudate amount is going to go down substantially. So it becomes ideal for using like that. Good thing is it is small, the patient can walk around with it or move around with it easily.
And ma'am, what about Ceridum, which you are using now, silk dressings? Is it only for the wound bed preparation, or can we use it as a dermal replacement also?
It is only for a wound bed preparation. It is not a dermal replacement.
Because they claim like we can even, the smaller wounds can get sealed.
Yeah, smaller wounds will close. Smaller wounds.
Like a replacement to dermal substitute? No.
It's not as such a replacement to dermal substitute.
Wound closure, it is also, we can use
another advanced dressing material which can be used for wound closure. Correct. More like a...
Because it has a natural product.
Thank you, sir. I would like to felicitate Dr. Nagarajan, sir, by Dr. Vas. Dr. Vas to Sheila ma'am. We come to the final section. Thank you one and all. I would request Dr. R.K. Rajesh Kesavan sir to say a few words before we start the valedictory function.
It has been 3 days of hectic learning where we have had the opportunity to continuously get exposed to various modalities of managing diabetic foot, from the first day workshop to 2 days of lectures continuously. Can we have the slides, please? I would like to thank all the delegates for staying back. We have had a registration crossing 435, and it's a pretty organic group which has come in to learn about diabetic foot. I mean, all of us are in this journey of reducing the number of amputations which are happening in the country. So healing a wound is going to heal, prevent an amputation. So I would like to thank all of you for being here and participating so well in this. And from morning to night, all of you have been here in this hall, and my heartfelt thanks on behalf of all my team. Ready? Life, as all of you know, it's a continuous journey where we continue to learn all the good things. And not only learning good things is important, we need to also unlearn whatever errors which we have learned or which have accidentally come into our practice. So it is time that we update our knowledge and apply whatever we have learned now in this practice. And I'm happy that a number of delegates have come from the neighboring countries. We have delegates coming from Sri Lanka, Malaysia, and Bangladesh, and Africa also. So we are trying to gather all the again, we are trying to gather knowledge from all over the country. And again, we were fortunate to have people, senior people coming from abroad. Fortunate to have the team from King's College London, Dr. Prashwas, Maureen, and Venu have spent a lot of time here. And I would like to thank them. So with lots of gratitude from Team RK, I would like to thank all of you. Next slide, please. I would like to thank the DFSA Executive Committee, Professor Arun Bal, Dr. V.B. Narayanamurthy, and team for giving us an opportunity to do this wonderful conference, the midterm conference. This is among the biggest midterm conferences ever held, and it's as good as an annual conference. We have been very serious about doing this conference. I think you would have seen this in the way it has gone through. We started on time, and we are almost ending it on time. Next slide, please. We also would want to express our gratitude to the partner associations, Diabeticfoot International, led by Dr. Zulfikar Ali Abbas, Association of Diabetic Foot Surgeons, International Association of Diabetic Foot Surgeons. Next. The King's Diabetic Foot Units of King's College Hospital, London, Maureen and Presh are representing the King's unit here. The Asia Pacific Association for Diabetic Limb Problems, Dr. Sanjay Vaidya is the Vice President of this association. We would also extend our heartfelt gratitude to Professor Lee Rogers, Dr. Prashant Vas, Maureen Bates, Venu Kavatapu, Dr. Jeffrey Nesgoda, Zulfikar Ali Abbas, and Dr. Taylor Sexton for sharing their knowledge with us here in India. We would also want to thank the 51 national faculties who have come here to share whatever knowledge they have and help us in this journey. We would also want to thank Dr. Nellayapar, Tamil Nadu Medical Council observer, who has been here all through from day one to get to the concluding ceremony now. And our special thanks to all our delegates, without which this would not have been a success. And the role of the sponsors is so much to conduct a meeting in such a nice atmosphere, helping all of us to come together. I would like to extend our heartfelt thanks to Smith & Nephew and group. So, Tariq, Basil, Sharanya, Nadeem, and Komesh, all of them have been very, very helpful from the time we had planned this conference. Smith & Nephew have been instrumental in giving us an educational grant of about $100,000 for this conference. So they have been very, very much helpful, without which this may not have happened. We are also thankful to all the other sponsors. All of them have come in good numbers, and they have also exhibited their products. And my heartfelt thanks to all our sponsors who have taken part in this wonderful conference. And stage 3, I think everything went on without a hitch from the time we started our conference. We started our conference on time and are almost ending it on time. And we had a wonderful performance, entertainment performance yesterday also. The audio, video, slides, the workshop. The workshop was, again, very difficult to coordinate, and in spite of everything, it went on very well without any hitch. So my thanks to Santosh and team of Stage 3. And the venue managers, the Hilton managers, I would like to thank them. So they have provided a very, very good place where we could come together. The organizing team has been with me. Shailaja has been a very, very important part. I only plan, but all the execution goes with my team. My team has been instrumental in following all of you, from the delegates to the faculty, coordinating with the hotel and with the Stage 3 team. Dr. Sheila, a special mention for her. Dr. Murali, Dr. Karthik, all of them have been wonderfully helpful in this meeting. And this is our core family of Dr. RK's team. And my sincere thanks to the RK's family from manning the reception. Again, first day, I think we went to bed at 3 a.m. in the morning and we started again at 7 a.m. in the morning on day one. Thursday night we were here. And so thanks to each and every member of this team who have made this conference a big success. I'm not naming each person by name, but again, all of them have been very instrumental in running this. And I would like the delegates and faculty to say a few words, what they felt about this
feedback
conference, yes, their feedback.
I'm a good friend of Rajesh, but still, I can't stop myself. It's a really fantastic show. And as he said, it's very much like a national conference in all aspects. The best part I would like to say is the RK's team. Nothing more. Fantastic. Especially Sheila Madam. And I would like the delegates' opinion. Anyone, please?
Yeah. My name is Dr. B.T. Chaudhary from near Rajamandri, Andhra Pradesh. It's a wonderful experience and learning new things and rectifying whatever they used to do in the blunders. Now I can do it very well. And I thank RK sir for the wonderful opportunity to give us to learn. And I request RK sir, is there any refreshing courses for the practicing doctors for the like 1 week or 10 days in-house program? If it is there, definitely please let us know to enhance our skills for the regular to help our patients in the regular practice. Thank you.
Thanks a lot, sir. We would keep that in mind.
I'm Dr. Gopi Shri. I'm a surgeon practicing diabetic foot. I'm from Sivagasi, the cracker city, Tamil Nadu. Actually, before coming to this conference, I would say I was like a pre-KG student in treating diabetic foot. But at the end of these 3 days, it gave us vast insight and so much of education we were able to gain from this conference. We are very thankful to RK sir for hosting such a wonderful conference. Thank you, sir.
And before closing, I would want to just distribute a few mementos to the core members of my team. I would like to welcome Dr. Shailaja and Dr. Sheila on stage. Shailaja and Dr. Sheila. I would like to thank both of them wholeheartedly for their work here. You can take the mic.
Mr. Santosh N from M Stage 3.
Santosh is not there. Anybody from their team can come and collect it.
Mr. Aravind Devaraj from Stage 3. Mr. Loganathan from Stage 3. Mr. Anbu from Stage 3. Mr. Loganathan.
Anbu, our stage 3.
To Dr. Sheila Sasikumar. To Ms. Saileja Pramod, ma'am.
Dr. Murali K. Dr. Karthik Selvam. Dr. Indra. Mr. Dinesh. Dinesh.
Special thanks to Dinesh. Again, he had worked tirelessly. He is among the persons who has worked continuously. He has put more man hours into this. Thank you.
Dr. Sri Priya M. Our staff can come in front. Please come in front. Simbu. Vanita. Divya Yogesh Kumar. Suman. Shekina. Saju. Malin. Prakash. Prakash. Naveen. Silambarasan. Gokul. Anya. Ajit Kumar. Sampat Kumar. Janani. Manigandan. Manigandan. Pramod Balachandran. Bharat Kumar. Srijit. Bhaskar. I ask Krishnan. Thank you, sir.
So thanks a lot. We will meet in the next third Chennai Advanced Wound Care Conference to be planned next year. And we also have our annual conference, DFSA annual conference from 31st of October to 2nd of November going to happen at Amritsar. Dr. Vikas Kakkar is representing the team. Words, Vikas?
Thank you, sir. After having this excellent conference and enthusiasm, even after the finishing of the conference, what I'm seeing with the team, so this is remarkable. Sir is having an excellent team. So I will request each and everyone to join us at Amritsar also for this annual conference. So that Amritsar is a good place, rich cultural heritage and good food. So along with academics, you will enjoy the Amritsari hospitality. So give us a chance. Thank you.
Thank you, sir.
Thank you. I think there is going to be a small cake cutting. Shailaja. Team. Maureen, come. A small cake cutting just to celebrate this occasion.
Rajesh, as you are serving the cake, on behalf of Maureen and myself and the wider King's team, we would like to congratulate you on organizing this wonderful event. I think it's a major seminal event for Chennai, what you got, and I can see what an impact you're having, not only in Chennai, but in wider Tamil Nadu and in Andhra Pradesh. So huge congratulations to you. And also, we made some great new acquaintances. Top of the list, of course, is Sheila. But you have a wonderful team. And a team like this is what you need to deliver the best, highest quality care. So congratulations for being the rock behind Dr. RK.
No, I I echo that. I can just see that the team adore you. You've obviously got a lovely working relationship with one another, and that's what makes a great success. So congratulations.
Thanks a lot. Thank you.
And finally, if you have any residents who want to take in experience after taking experience with you to blend in with what they've learned with you, we would be very happy to help and support that initiative. So if that could be discussed, but having seen what's happening here, we have advised a few of the delegates who approached us to consider doing fellowship first with Dr. RK, and then it could be a joint exercise with that.
Thanks a lot, sir. Thanks for the support. Thank you.
கீழே